Hello, my dear doctors. A very good evening to everyone. This is Dr. Azam here, your faculty of anatomy at PrepLadder. Hello, my dear doctors. And today we are going to do the LRR, that is a last resort revision of anatomy, especially for the students who are preparing for FMGE 2026. So now, my dear friends, before starting the session here, let me just clarify a few things here. uh, now, now let me just clarify a few things here, my dear friends. Please remember that we are doing LRR right now, and right now it is supposed to be that you have already completed your entire subject at least once. Fine. And after completing the entire subject from all the main videos once, then of course now if you do the revision, that is your rapid revision or your LRR, that is your last resort revision, that is going to help you a lot. Okay. So please don't ask me that question and again कि sir इतना पढ़ेंगे तो हो जाएगा. Obviously the meaning of revision itself is like a revision. So I am expecting that you have already done the entire subject at least once. And the second thing that I want to tell you people here is that in this last resort revision, it's not like we are doing the regular classes kind of thing where we are going to discuss the entire topic in detail. It's like it'll be like a quick revision. तो मैंने यहाँ पर क्या किया है, what I have done is that in this entire PDF, many places where it is like requiring a lot of time just to write down. For example, we are going to discuss ulnar nerve. तो ulnar nerve अगर हम ये moment पर draw करेंगे तो your time will be wasted. So I don't want to waste the time of my students here. That is the reason why many of the things are actually already written over here, and we are going to have a quick revision in this one. Okay, I hope you're getting it this one here. So in this manner हम लोग यहाँ पर revise करेंगे फटाफट, ताकि आप लोग जो है ना क्विकली सारे टॉपिक्स अपने माइंड में रिवाइज कर सको जस्ट बिफोर योर एग्जाम. एंड आई होप एंड आई विश दैट योर प्रिपरेशन इज गोइंग वेरी वेल फॉर योर एग्जाम एट दिस लास्ट मोमेंट ओवर हियर. इज इट ओके? नाउ विद दिस नोट माय डियर फ्रेंड्स, लेट्स गेट स्टार्टेड. तो चलिए स्टार्ट करते हैं विद अवर लास्ट रिसोर्ट रिविजन ऑफ एनाटमी, एंड वी आर गोइंग टू डिस्कस all the high yield topics. And not only that, a lot of clinical anatomy will be done. I'm also going to deal with all the syndromes like brainstem syndromes and all those things. And we are of course going to discuss not randomly here and there. We are going to discuss like topic wise. Okay, so we'll do neuroanatomy, then head and neck, then upper limb, lower limb, thorax, abdomen, embryology, histology, as well as the joints. Every topic we are going to discuss. So अगले 2-3 घंटे I want you all to be like completely with me. Completely मतलब completely with me. And just have your water, your coffee or your chai along with you. And yes, don't disturb from your place. अपनी place से वहाँ से disturb मत हो जाइए सर, बस मेरे साथ में रहिए. And of course, out of the 20 questions, you will be able to solve many of the questions in the exam from this LRR session. Now saying this, let's get started with the session right now. The first topic we are going to begin is neuroanatomy. So let's get started with the neuroanatomy first of all here, sir. Now in neuroanatomy, every time I'll be telling the students that please learn all the 3 sections of the brain. Why? Because there'll be a definite question from the 3 sections of the brain. I mean to say, the exam paper will not be completed without a section of the brain. ये definitely आपके exam में आएगा. So now the very first section that we are going to discuss here will be the coronal section. And in the coronal section itself, we are also going to discuss about the lateral ventricles. Now in this diagram, you are able to appreciate one of the lateral ventricle here, and then there is another lateral ventricle here. And these lateral ventricles are going to open into the third ventricle via foramen of Monro. There is a foramen, that is foramen of Monro. Now above the lateral ventricle, you are able to appreciate the fibers which are going to connect the right and left half of the brain. And we know very well the fibers which are going to connect the right and left half of the brain are nothing but commissural fibers. And out of all the commissural fiber, the largest commissure here will be the corpus callosum. And you can very clearly appreciate in our diagram here that corpus callosum is the one which is actually going to form the roof of the lateral ventricle. Okay. So in this way, in the coronal section itself, you're also going to learn about the roof also, my dear friends. So the roof of the lateral ventricle is formed by corpus callosum. Now recently it was asked last month in the INI set exam, between the 2 lateral ventricles there will be a septum in the middle, and that septum will be the septum pellucidum. And remember, septum pellucidum is the one which is going to form the medial wall of the lateral ventricle. So that is going to form the medial boundary of the lateral ventricle. Now what is going to form the entire floor of the lateral ventricle? Number 1, this nucleus that you are able to see here will be the caudate nucleus here. After the caudate nucleus, there'll be a vein here. That vein will be the thalamostriate vein. And then after that, you'll be able to appreciate that there will be a thalamus present over here. And then this network of capillaries which is present here will be the choroid plexus. So I repeat again, this will be the caudate nucleus here, thalamostriate vein, thalamus, and the choroid plexus. And yes, my dear doctors, please remember that if this one here will be the septum pellucidum, in the lowermost part, I mean to say the lower border of the septum pellucidum will be attached with fornix. Okay, and that is also present in the floor. So this one here will be the fornix. And this fornix is also present in the floor of the lateral ventricle. So I repeat again, what are all the structures which are going to form the floor of the lateral ventricle? They are formed by the caudate nucleus, thalamostriate vein, and then the choroid plexus, thalamus, as well as the fornix. All of them are present in the floor of the lateral ventricle. Okay. So now, once you are done with this one here, my dear friends, you are able to see here, we are also done with the boundaries of the lateral ventricle. I repeat once more here, a roof will be formed by corpus callosum, medial wall will be formed by septum pellucidum, and the floor will be formed by caudate, thalamostriate vein, thalamus, choroid plexus, as well as fornix. Done. Now, once you are done with this one here, recently in one of the exam, they have actually, in your FMGE exam, from here, 2 times this image was given. Number 1 time, what is this nucleus here? Arrow mark, you have to identify the nucleus. I hope you'll be able to tell me this nucleus is lentiform nucleus. And last year itself, they have given arrow mark at this place here. Now, what is this? Bundle of fibers which are going to pass in between the caudate nucleus on one side and lentiform on the other side. This one here will be the internal capsule. So we have covered like 2 questions here. And one more question which was actually given in the PG exam, they have given an arrow mark on this black colored substance over here. And this one will be the substantia nigra. That one will be the substantia nigra. So in this manner, my dear friends, we are done with each and every point in the coronal section. Let's go ahead. Along with this, we are also going to discuss about the lateral ventricle, as I said you. In the lateral ventricle, there will be one anterior horn, which is extending into the frontal lobe. And then there will be the central part here. And then there is a posterior horn, which is extending into the occipital lobe. And then you have inferior horn, which will be extending into the, temporal lobe there. Now, in one of the exams, they have given a section of this inferior horn here. Okay, you can clearly, the posterior horn here, sir. So this one here will be the posterior horn. So we have given a section of the posterior horn. In this posterior horn, one thing that you are able to clearly appreciate that the roof and the lateral wall. The roof and the lateral wall is formed by which fibers? That is tapetum fibers. So please remember, tapetum fibers are going to form the roof as well as the lateral wall of the posterior horn. Perfectly done. And then what about the medial wall? Now on the medial wall, this is something really important. You'll be able to find like 2 depressions here. And this one here will be the bulb of the posterior horn. And this one here will be the calcar avis. Calcar avis. Now they have asked already in the exam, the bulb of the posterior horn is formed by the fibers of forceps major. ये सारे fibers मैं आपको आगे वाले diagram में बताऊंगा. For now, you just remember. Let us just repeat this once more here. What is going to form the roof and the lateral wall? That is formed by tapetum fibers. Whereas the bulb of the posterior horn, it will be formed by the forceps major fibers. ये आपको याद रखना बहुत जरूरी है. Already exam में पूछा गया है. Clear? Moving ahead. Now, can you answer me this question here? The structure which is indicated in the image originates from where? Now, अभी मैंने आपको बताया है, जो arrow mark है, that structure is fornix. But they are not asking you to identify the fornix there. They're asking it is going to originate from there. It is going to originate from the hippocampus. Now, that is the reason why I told you we are going to discuss in such a way that, at one place, all the concepts will be covered. At one place itself, my dear friends, we are going to see all the concepts here. So now let us discuss each and every point regarding the fornix. Please look at this diagram here. Now in this diagram, first you're able to appreciate here, this is hippocampus. And from the hippocampus begins your fornix here. And this fornix is all the way going and joining with the mammillary body. Let me show you like one more diagram here. Please look at this diagram here, my dear friends. This one here will be the hippocampus. And this red colored fibers here will be the fornix. And fornix is finally going and joining with the mammillary body. And from the mammillary body, the fibers, that is mammillothalamic tract, will be going to thalamus. And please remember, it is going to the anterior nucleus of thalamus. Anterior nucleus of thalamus. तो सबसे पहले आपको ये सीखना होगा कि from the hippocampus, the fibers are going to mammillary body via fornix. ये आपके एग्जाम में कई बार पूछा गया है. And from the mammillary body, there will be mammillothalamic tract. There will be mammillothalamic tract and it is going all the way up to thalamus. Or exam में पूछा गया था which nucleus of thalamus. So please remember it will be the anterior nucleus of thalamus. Anterior nucleus of thalamus. Perfect. So here itself we have actually covered like 2 MCQs, my dear friend. Now welcome to the third question. Phonics. They're asking phonics belongs to which type of white matter fibers? Is it association fiber or is it commissural fiber or projection fiber? Please remember the answer should be all the above. All the above. Phonics belongs to association, commissural and projection fibers. Is it okay? Then after that, what is the best answer? Suppose if all the 3 options are given, then what will be the best answer? Remember, association fiber will be the best answer, sir. And after that, my dear friend, if they're asking a combination, the best combination will be association plus commissure. So in this manner, on this slide here, we have completed each and every point in each and every question related to phonics. Okay. So we are done with each and every point regarding the phonics here. तो जैसे मैंने आपको promise किया था, हम एक ही जगह पर क्या करेंगे? At one place we are going to complete everything regarding the concepts. Okay. अब चलिए आगे बढ़ते हैं सर अगला concept. Now, मैंने जैसे आपको बताया था, in coronal section, they are giving this diagram and in this diagram, they are just putting an arrow mark and asking you. So you should be able to identify all the nuclei belonging to the basal ganglia here. Now, in this diagram, this nucleus that you are able to appreciate here, this one will be the caudate nucleus here. And then this nucleus that we are able to appreciate here will be the lentiform nucleus. Now, my dear doctors, we all know that lentiform nucleus is in turn made up of putamen and globus pallidus. और आपके FMGE एग्जाम में एक बार ये भी पूछा गया था कि what is the positioning of that one. So please remember the putamen will be on the outer aspect here on the lateral side, whereas globus pallidus will be on the inner side, sir. Globus pallidus will be in the inner side, and I think आपने physiology में पढ़ा होगा कि globus pallidus will be intern divided into 2 parts. Globus pallidus internus होता है और globus pallidus externus भी होता है. तो आपको इसका पोजीशन भी पता होना चाहिए कि लेटरल में पुटामेन होता है एंड मीडियल साइड में ग्लोबस पैलिडस होता है. इवन दे हैव आस्क्ड दिस वन इन द एग्जाम. और जैसे मैंने आपको ऑलरेडी बताया था, रिसेंटली देयर वाज एन एरो मार्क हियर एंड दिस वन हियर विल बी द इंटरनल कैप्सूल. सो आई होप नाउ यू विल बी एबल टू आइडेंटिफाई ऑल द न्यूक्लियाई. Now, apart from identifying all the basal ganglia nuclei, they're also asking here in the exam about the lesions. And in lesions, they're asking in a vice versa manner. For example, if there is ethetosis, then which part of the basal ganglia will be involved in ethetosis? Remember, that will be globus pallidus. If there is a lesion in putamen and caudate, it will lead to what's a chorea. ये recently पूछा गया था. Like which nuclei of the basal ganglia are involved in the chorea? That is putamen and the caudate nucleus. पार्किंसोनिज्म ये तो सबको पता है, यस, सब्सटेंशिया निग्रा. एंड देन हेमिबैलिस्मस भी पूछा गया था, इसमें कौन सा वाला न्यूक्लियस इन्वॉल्व होता है? दैट वन विल बी द सबथैलेमिक न्यूक्लियस विल बी इन्वॉल्व. सो प्लीज रिमेंबर द लेशन. Please remember the lesion and which part of the basal ganglia that will be involved in this lesion here, sir. Perfect. Then moving ahead. Now, once I am done with the coronal section, I hope all of you are understanding my planning here. In one section, we have completed like many topics. We are done with the topic of phonics. We are done with the topic of basal ganglia, identifying all the nuclei and what will be the lesions in that one. Now, once you are done with this one, let us go ahead with the sagittal section right now. Now, my dear doctors, in sagittal section, ये वाला जो ventricle होगा, this ventricle here will be the third ventricle. Now, this ventricle here will be the third ventricle. Now, my dear friends, if you look at this section here, अभी मैंने आपको बताया था कि ये वाला third ventricle होगा. From this diagram itself, you can tell me what is going to form the roof of the third ventricle. In the roof of the third ventricle, you are able to see network of capillaries, choroid plexus, along with you're able to see the phonics here. Perfect. And you can even tell me about the lateral wall. The lateral wall is actually formed by the thalamus, और thalamus के नीचे यहाँ पर क्या होगा? Obviously, there will be hypothalamus. So thalamus and hypothalamus is going to form the lateral wall of the third ventricle. And yes, of course, the roof will be formed by choroid plexus and the phonics. Perfectly done. तो इसी diagram से आप यहाँ से सीख सकते हो, है ना? So now come down here. The phonics and the choroid plexus, these two are going to form the roof of the third ventricle. Now, we know that out of all the commissural fiber, the largest commissural fiber will be the corpus callosum. So this one here will be the corpus callosum. ऑलरेडी आपके FMG एग्जाम में पूछा गया था कि हाउ मेनी पार्ट्स आर देयर इन द कॉर्पस कैलोजम? दे आर लाइक 4 पार्ट्स. Rostrum, the bent here will be genu, and then you have body, and then there will be splenium. I repeat again, there are 4 parts: rostrum, genu, body, and the splenium. Just below the rostrum, there will be anterior commissure, and below that anterior commissure, there will be lamina, and that is nothing but the lamina terminalis. Lamina terminalis. And these two are going to form the anterior wall. It is going to form the anterior wall of the third ventricle. What is going to form the posterior wall? First of all, you should be able to identify that there is a gland here. That gland will be pineal gland. Above the pineal gland, there will be one commissure, that is habenular commissure. Below the pineal gland, there is one commissure, that is posterior commissure. Repeat again, pineal gland, above that there will be habenular commissure, and below that there will be posterior commissure. And then there will be a duct present over here. This duct here will be the aqueduct of Sylvius. And all these structures together, they are going to form the posterior wall of the third ventricle. Posterior wall of the third ventricle. And finally, we are now left out with the floor. In the floor, first you'll be able to see this crossing here, and this crossing will be the optic chiasma. And then you'll be able to appreciate the infundibulum here, which is getting attached to the pituitary gland here. And then this body here will be the mammillary body. And then you're able to appreciate perforated substance here, which is referred to as posterior perforated substance. And yes, of course, this will be the tegmentum part of the midbrain. अगर आपको ये पता है तो बहुत अच्छी बात है, नहीं पता है तो ध्यान से सुनिएगा. जो एक्विडक्ट होता है, एक्विडक्ट के पीछे वाला जो पार्ट होता है, द पार्ट प्रेजेंट बिहाइंड द एक्विडक्ट विल बी टेक्टम एंड इन फ्रंट विल बी द tegmentum. So this is tegmentum part, and all these structures together, they are going to form the floor of the third ventricle. I repeat again, the floor of the third ventricle is formed by, yes, number 1, optic chiasma, then infundibulum, then the mammillary body, then posterior perforated substance, and tegmentum part of the midbrain. Perfectly completed here, sir. So by this, we are done with the sagittal section. Now I'll tell you one thing here. After teaching my students all the structures over here, and my students have learned the structures very well, but in the exam, they have given, yes, an X-ray image. In the X-ray image, the arrow mark was here. Just identify this structure. And who doesn't knows that one? ये किसको नहीं पता है, आप मुझे बताइए. ये वाला पार्ट आपका अगर मिड ब्रेन होगा तो ऑब्वियसली यहाँ पर होगा हाइंड ब्रेन, ये पॉन्स होगा, फिर मेडुला होगा, और इसके पीछे यहाँ पर होता है सेरिबेलम. Okay, so in this manner, the image was given to you, radiological image, and in the radiological image, the arrow mark was on this one. Identify this one, Pons. Okay, and remaining structures my student knows very well. अभी मैंने आपको बताया है सर. ठीक है ना? Thank you. Okay, चलिए आगे बढ़ते हैं सर. Now, once you are done with the coronal section as well as the sagittal section, now let us go ahead with the transverse section of the brain. Now, to understand this diagram, first look at this small diagram here. Now, in this small diagram, you are able to appreciate that green colored structure over there will be the corpus callosum. Corpus callosum will have rostrum, then genu, then body, and the splenium. And we are going to cut transversely here and remove the upper part and throw it off. And then we are seeing from above. हम ऊपर से देख रहे हैं. ठीक है? तो जेन्यू के आगे ये वाला जो लोब होगा, ऑब्वियसली ये फ्रंटल लोब होगा, और स्प्लीनियम के पीछे वाला जो लोब होगा, ये ऑक्सिपिटल लोब होगा. Perfect. Now once you are seeing from above, the diagram is something like this here. Now in this diagram, my dear friend, this one here will be the genu part here, and this one here will be the splenium part here behind, and we are taking a transverse section seeing from above. हम ऊपर से देख रहे हैं. Now you can clearly see the white matter fibers connecting the genu with the frontal lobe here, sir. The fibers which are going to connect the genu with the frontal lobe will be forceps minor. The fibers which are going to connect the splenium with the occipital lobe over here, now these fibers here will be the forceps major fibers, forceps major. And in the diagram, I have shown you very clearly that the genu part is connected to the splenium with the help of the body. But in this diagram, in the transverse section, we are not able to see the body there. Fine. Just imagine कि body वहाँ पर है, and from the body, the fibers are going laterally, and those fibers are referred to as tapetum fibers. Okay. Tapetum fibers. तो एक बार मैं दोबारा रिपीट करता हूँ neat and clearly, my dear friends. From the genu to the frontal lobe, there'll be forceps minor. From the splenium to the occipital lobe, there'll be forceps major. And from the body going laterally will be tapetum fibers. Clear? Now, once you are done with this one here, welcome. Again, the same thing here. This one here will be the caudate nucleus and the thalamus, and this one here will be lentiform. In between them, whatever white matter fibers that you're able to appreciate here, this one here will be the internal capsule. ये वाला आपका internal capsule होगा. Okay. Then if this is internal capsule, obviously the white matter present on the outer side here will be external capsule. And then there is one more white matter present here. This sheet of the white matter here will be extreme capsule. Let us repeat that again. This is internal capsule, external capsule and extreme. अब आप इस डायग्राम को थोड़ा और ध्यान से देखिए. Look at the diagram more closely, my dear friend. Between the external capsule and extreme capsule, you are able to see that there is a thin sheet of gray matter, and that is nothing but claustrum. इसको हम कहते हैं क्लॉस्ट्रम. और एक बार एग्जाम में पूछा गया था, लाइक व्हाट इज दिस कॉर्टेक्स प्रेजेंट ओवर हियर? दिस इज नथिंग बट द इंसुलर कॉर्टेक्स. यहाँ पर होता है इंसुलर कॉर्टेक्स, और सिंपली वी कैन कॉल इट एज इंस्यूला. तो इन दिस मैनर आई होप नाउ माई स्टूडेंट्स हैव रिवाइज्ड, है ना, द ट्रांसवर्स सेक्शन ऑफ द सेरिब्रम ऑल्सो. The transverse section of the cerebrum is also done here, my dear friends. Is it okay? So by this, we are done with what here, sir? Coronal section, the sagittal section, and transverse section. And take my words, whatever we have learned in the last 15 minutes, my dear friend, definitely one question is going to come from here. एक सवाल यहाँ से पक्का आएगा. Okay? And imagine you are at 149 and that one mark is giving you that 150th. इट मैटर्स अ लॉट. सो एक मार्क बहुत इंपॉर्टेंट है सर, इसीलिए ना ध्यान से सुनते जाइए. अगले 2 घंटे कोई भी ना डिस्टर्ब नहीं होगा. डोंट डिस्टर्ब योर सेल्फ, जस्ट बी अलॉन्ग विथ मी. एंड यू हैव सीन वी आर नॉट गोइंग टू वेस्ट इवन अ सिंगल मिनट हियर. हम 1 मिनट भी यहाँ पर वेस्ट नहीं करेंगे. मतलब सिंपली ऐसे लिखने करने में ना सब कुछ रेडी है. बस फटाफट मेरे साथ में बैठिए और रिवाइज करते जाइए. कीप ऑन रिवाइजिंग अलॉन्ग विथ मी इन योर माइंड. ठीक है ना, सो दैट यू आर एबल टू जस्ट रिवाइज बिफोर द एग्जाम. द नेक्स्ट वन सर. Now in this diagram I told you यहाँ पर internal capsule होता है. There will be internal capsule. तो हम इतना सा part यहाँ से pick up करते हैं. Let us remove this much part from here. Now if you remove this much part from here, this is how your internal capsule will look like. Now in this diagram you're able to appreciate here, this one will be the internal capsule. Okay, what do you have on the medial side? On the medial side there will be caudate nucleus and the thalamus. Then what do you have on the lateral side? On the lateral side, this nucleus is lentiform and it is again made up of putamen and globus pallidus. Already मैंने बता रखा था. Clear? तो in this manner we are done with the relations here. अगर आपको एग्जाम में रिलेशन पूछा जाएगा, what is the medial relation of the internal capsule? Caudate nucleus and the thalamus. What do you have on the lateral side? That will be the lentiform nucleus. Okay. Next one. अगला सवाल यहाँ पर ये है, what are the parts of internal capsule? Remember there are totally 5 parts. One will be the anterior limb, another one will be the posterior limb, the vent in the middle will be genu, and then there will be retrolentiform part and sublentiform part. So in this diagram here, I'll just write down, this one here will be the anterior limb, the vent will be genu, and this is posterior limb, and the part which is going below the lentiform, there is nothing but sublentiform, behind the lentiform, that is retrolentiform. Sublentiform and retrolentiform. There are totally how many parts? 5 parts. Now the most important thing to learn in the internal capsule is about tracts passing through the internal capsule and the blood supply. सवाल यहीं से आएगा. Now which tract is going to pass from the genu wala part? Remember it is cortico-nuclear tract. This is going to pass from the genu. Now similarly remember cortico-spinal tract, my dear friends. It is the one which is going to pass from the posterior limb. You can clearly see in the diagram it is passing from posterior limb. But remember, anterior 2/3 of posterior limb. So corticospinal tract is passing from anterior 2/3 of the posterior limb. So these 2 points are extremely important to remember. Then apart from that, sir, how to remember the blood supply of internal capsule? This is the best diagram by which you can remember the blood supply. Now in the internal capsule, remember again the same thing. There are like 5 parts. I told you anterior limb, genu, posterior limb, retrolentiform and sublentiform part. Now in the anterior limb and the genu and the posterior limb, you can actually divide that into 2 parts, sir. That is your upper part and lower part. I mean to say the superior and inferior part. Superior part of anterior limb, the genu and posterior limb, superior part will be actually supplied by, yes, the striate branches of middle cerebral artery. That is why it is written as M here. It's middle cerebral artery. Which branches? Striate branches. Okay. अब इन स्ट्राइट ब्रांचेस का दूसरा नाम भी होगा. अनदर नेम ऑफ दिस वन विल बी लेटरल स्ट्राइट आर्टरी, या फिर इसको हम कहते हैं आर्टरी ऑफ चार्कर्ट्स हेमरेज भी कहते हैं. ठीक है ना. इट्स अ ब्रांच ऑफ योर मिडिल सेरेब्रल आर्टरी. What about the inferior part now? The inferior part of the anterior limb will be supplied by a recurrent branch of Hubner's, या फिर उसको Hubner's artery हम कहते हैं इसे. And the recurrent branch of Hubner, it is also nothing but your medial striate artery. Similarly, the inferior part of the genu will be directly supplied by the internal carotid artery. I लिखा है वहां पर. And then the inferior part of the posterior limb, retrolentiform part, sublentiform part, remaining everything highlighted in the blue color there will be supplied by anterior choroidal artery. Anterior choroidal artery. इसलिए मैं कह रहा हूँ प्लीज रिमेंबर दिस डायग्राम. ये डायग्राम से ही आपको याद होगा. इंडिविजुअली आप यहाँ पर आर्टरीज याद नहीं रख सकते हो सर. सो यू कैन सी द निमोनिक हियर, इट इज रिटन एज मारिया हियर. ऐसे याद रख लीजिए. ठीक है. डन सर. In this manner, we are done with all the 3 sections, and along with that, many topics related with that one is done, sir. अब चलिए आगे बढ़ते हैं अगले segment की ओर. Another segment right now, brainstem. Now, brainstem, we know very well it is made up of 3 parts, sir. This one here will be your midbrain, and this one will be the pons, and this one here will be the medulla oblongata. Now, the ventral aspect of brainstem, the cranial nerves which are going to originate from here will be 3rd to 12th cranial nerve is going to begin from here. From the midbrain, you are able to appreciate the 3rd nerve here and the 4th nerve here, sir. Now, this 4th nerve nowadays is very much important for your exam. Please remember, you can very clearly see in the diagram that it's not having ventral origin, it's actually having dorsal origin. ये dorsally originate होती है और फिर turn होकर आगे आती है. Point number 1. Now, because it is having dorsal origin, it is traveling longest. It is having longest intracranial course. And then after that, remember, it is also having internal decussation. It is crossing. Decussation means crossing, but it is crossing inside the midbrain. इसीलिए उसको internal decussation कहा जाता है. So please remember these 3 important points here. Dorsal origin, longest intracranial course, as well as internal decussation. And remember, the 4th nerve is actually the smallest cranial nerve as well as the thinnest cranial nerve. I hope you know that one. Then after that, this one here will be the 5th cranial nerve, trigeminal nerve, and that is going to exit between the pons and middle cerebellar peduncle. I hope you all know that pons is connected to cerebellum with the help of middle cerebellar peduncle. Pons is connected to cerebellum with the help of middle cerebellar peduncle. तो इन दोनों के दरमियान में यहाँ से exit होती है 5th nerve. Then between the pons and medulla there is pontomedullary junction. At the pontomedullary junction you're having 6th nerve, and then the 7th nerve, and then the 8th nerve exiting from here. And then in the medulla oblongata you are able to appreciate that in the middle there will be one sulcus. अगर यहाँ पर sulcus होगा, on either side there is elevation, that is pyramid, and this one here will be the olive, and this one is also olive here, sir. So pyramid, olive. Just lateral to olive you are able to see 9th nerve, and then there is a 10th nerve and 11th nerve. And then between the pyramid and olive there will be the 12th nerve, that is hypoglossal nerve. Now remember one point here itself. 9th, 10th and 11th nerve, together they have a common nucleus, and that nucleus will be known as nucleus ambiguous. Already exam में पूछा गया था. Nucleus ambiguous. Perfectly done. अब सर अगर हमने ये सारे स्ट्रक्चर यहाँ पर आइडेंटिफाई कर लिए हैं, now please focus on this region right now. यहाँ पर ये जो क्रॉसिंग है, क्रॉसिंग is nothing but optic chiasma here, and this one is your optic tract, and this one will be the cerebral peduncle. Listen to me very carefully. I'm not telling cerebellar peduncle here, that is cerebral peduncle. Okay. अब इन सब के बीच में यहाँ पर एक डिप्रेशन होता है, और आप सबको पता है एनाटॉमी में जब कोई भी डिप्रेशन होता है उसको हम कहते हैं फोसा. सेरिब्रल पेडंकल और सेरिब्रल पेडंकल, इन दोनों के बीच में यहाँ पर जो फोसा होगा इसको हम कहते हैं इंटरपेडंकुलर फोसा. वाओ, द नेम इज वेरी मच मीनिंगफुल हियर. Interpeduncular fossa. Now, what are the contents of interpedunclar fossa? That is infundibulum along with tuber cinereum. Number 1, infundibulum along with the tuber cinereum. Number 2, this body here will be the mammillary bodies here. Number 3, there is posterior perforated substance here. And number 4, that is your cranial nerve number 3, that is oculomotor nerve. As simple as that. I repeat the contents again. Infundibulum along with tuber cinerarium, mammillary body along with that posterior perforated substance as well as cranial nerve number 3. Now my dear friends, in this LRR session here right now, if you have revised this with me, now you are ready with any question related to the ventral aspect of brainstem. We have revised everything in the ventral aspect of brainstem here. Okay, now let us see one MCQ here, sir. In one of the exam, they have given this ventral aspect of the brainstem. You can clearly see the arrow mark here. अगर यहाँ पर injury होगा, if there is a lesion here, then what is going to happen? अभी मैंने आपको बताया ये जो elevation होता है, इस elevation को हम कहते हैं pyramid. क्यों कहते हैं? Why this elevation is referred to as pyramid? Why? Because the pyramidal tract is going to pass from here. It's a descending tract. Pyramidal tract is a descending tract. The corticospinal tract, so it's going to pass from there. And after passing from here, 90% of the fibers are going to cross on the other side. You're able to appreciate the crossing also. And these 90% of the fibers which are going to cross, almost like 85 to 90%. 85 to 90% of the fibers which are going to cross, they are going to form lateral corticospinal tract. And the remaining 10 to 15% of the fibers, 10 to 15% of fibers will remain on the same side, and they are the one which is going to form anterior corticospinal tract. Perfectly done. I repeat again, because the pyramidal tract is going to descend from there, that is the reason why the name is given as pyramid. That elevation is referred to as pyramid. 90% of the fibers are crossing and they are going to form lateral corticospinal tract. And then 10% are remaining on the same side. They are going to form the anterior corticospinal tract. Anterior corticospinal tract. और आप क्लियरली यहाँ पर देख सकते हो क्रॉसिंग हो रही है और इस क्रॉसिंग को हम कहते हैं पिरामिडल डेक्यूसेशन. और ये पिरामिडल डेक्यूसेशन कहाँ पर होता है? इन द लोअर पार्ट ऑफ द मेडुला. लोअर पार्ट ऑफ द मेडुला. तो लेट्स रिवाइज ऑल द पॉइंट्स रिगार्डिंग पिरामिडल ट्रैक्ट हियर इटसेल्फ. Okay, so it's like very well planned LRR session here, sir, so that you can complete maximum things in less amount of time and in less space, sir. Okay, so now what is the another name of the pyramidal tract? It is also referred to as corticospinal tract. पिरामिडल ट्रैक्ट डिसेंडिंग है, तो डिसेंडिंग ट्रैक्ट मतलब कहाँ से ऑरिजिनेट होगा? ऑब्वियसली मोटार एरिया से ऑरिजिनेट होगा. तो इट्स गोइंग टू बिगिन फ्रॉम प्राइमरी मोटार एरिया, एरिया नंबर 4, pre-motor area, area number 6, and even some fibers are coming from primary sensory area, 3 to 1. 30% of the fibers will come from the primary motor area, remaining 30% will come from pre-motor area, and then 40% of fibers are coming from the primary sensory area. And I told you the most repeated question in your exam, pyramidal decussation kahan hota hai? Pyramidal decussation ekkada avutundi? Of course in the lower medulla. It will be in the lower medulla. अब आ जाइए सर, वेलकम बैक टू अवर क्वेश्चन. अब हमारे सवाल की तरफ वापस आ जाइए. अगर यहाँ पर पिरामिड में अगर यहाँ पर इंजरी होता है तो क्या होगा? प्लीज रिमेंबर, वेन एवर यू गेट अ क्वेश्चन इन द एग्जाम रिगार्डिंग इंजरी टू पिरामिडल ट्रैक्ट, अगर आपका पिरामिडल ट्रैक्ट इंजूर होता है, योर क्राइटेरिया शुड बी, इज इट बिफोर द डेक्यूसेशन और आफ्टर द डेक्यूसेशन. आपको देखना होगा कि डेक्यूसेशन से पहले है कि बाद में है. अगर डेक्यूसेशन से पहले इंजरी होगा तो ऑब्वियसली द ऑपोजिट साइड मसल्स आर नॉट गेटिंग द सप्लाई. देयर विल बी कॉन्ट्रालेटरल हेमीप्लेजिया. देयर विल बी कॉन्ट्रालेटरल हेमीप्लेजिया if the injury to the pyramidal tract is before the decussation. If the injury is after the decussation, it will be ipsilateral hemiplegia. Okay, so thank God we are done with one more concept in this diagram. अब चलिए इस ब्रेन स्टेम को हम पीछे टर्न करते हैं. लेट अस सी द डॉर्सल एस्पेक्ट ऑफ ब्रेन स्टेम. अब डॉर्सल एस्पेक्ट ऑफ ब्रेन स्टेम से ना हमेशा जो सवाल आते हैं, द क्वेश्चंस आर गोइंग टू कम ओनली एंड ओनली फ्रॉम दिस फेशियल कॉलिकुलस. विल डिस्कस अबाउट दैट वन इन डिटेल, डोंट वरी. पहले हम फटाफट सब कुछ आइडेंटिफाई करते हैं. What do you have behind the midbrain? There will be superior colliculus, and then inferior colliculus. All together we are having 4 bodies here. इसको कहते हैं corpora quadrigemina. Recently in one of the exam they have given this image, and in the image there was an arrow mark at this nerve. Identify the nerve. अब ये भी मैंने आपको बताया था, out of all the cranial nerves, the only cranial nerve having dorsal origin will be the 4th nerve. Okay, it has to be the trochlear nerve. So behind the midbrain, that has to be the trochlear nerve. Perfectly right. Now what about behind the pons and medulla oblongata? Pons और medulla के बिल्कुल पीछे होता है 4th ventricle, and you are able to see this is the floor of the 4th ventricle, जिसको हम rhomboid fossa भी कहते हैं because it is rhomboid in shape, floor of the 4th ventricle. Okay. Fine. So that is the floor of the fourth ventricle here. Now in the floor of the fourth ventricle, this elevation here will be the facial colliculus. Then this elevation here will be the hypoglossal triangle. This elevation here will be the vagal triangle. And finally, this will be vestibular area. Now you got to learn what is the reason for this elevation, why it is elevated here. Remember, the vagal triangle, it is actually formed due to the vagus nucleus, the 10th nucleus. Similarly, hypoglossal triangle, it is formed due to the 12th nucleus, hypoglossal nucleus. And then vestibular area is actually formed due to the vestibulocochlear nucleus, that is your 8th nucleus. My dear doctors, please pay attention that I'm writing nucleus there, not the nerve. It's nucleus. And second thing I would like to tell you that please forget about all these things. Examiner will never ask you. Now you might be like, sir, why are you telling like that? Of course, please study smartly. Think like an examiner. Already नाम में लिखा है vagal triangle, तो obviously vagus nucleus होगा. क्या examiner ऐसे सवाल पूछेगा? बिल्कुल नहीं. Welcome here. सवाल आता है facial colliculus से. Facial colliculus will be formed due to the 6th nucleus. Please remember, it is not 7th nucleus. It is not facial nucleus. It is due to abducens nucleus. It is 6th nucleus. 6th nucleus. But why the name is given like this here? If you are going to take a section at this level, अगर आप यहाँ पर section लोगे, transverse section of the pons, then what is going to happen? अगर मान लो कि if this is the transverse section of the pons, try to recall from our main videos. तो 6th nucleus, यहाँ से 6th nerve होगा, लेकिन जो 7th nerve होता है, that 7th nerve is going to take a turn around the 6th nucleus and come out. That's the reason why on the dorsal side you'll be able to see this elevation here, जिसको हम कहते हैं facial colliculus. Are you able to revise, my dear friends? I hope you're able to revise quickly in your mind now. Come on. I hope everything is getting revised in your mind. आपने already anatomy class में पढ़ रखा होगा, है ना? That's really nice, है ना? Few days before the exam, if you are able to revise all these things, wonderful. तो फेशियल कॉलिकुलस का नाम फेशियल कॉलिकुलस इसीलिए होता है क्योंकि 7th nerve is going to take around that 6th nucleus. Crystal clear, sir. Very nice. Then apart from that, few questions already asked in the exam. In the floor of the fourth ventricle, you'll be able to see this bluish gray pigmented area. And this bluish gray pigmented area, superior fovea कहते हैं, वहां पर होता है. और इस एरिया को एक्चुअली कहा जाता है लोकस सेरुलियस. तो आपको ये नाम याद रखना होगा, लोकस सेरुलियस कहा जाता है. और ये क्या सेक्रेट करेगा? डोपामीन. डन. नाउ आई एम डन विद द फ्लोर ऑफ द फोर्थ वेंट्रिकल. नाउ व्हाट अबाउट द रूफ ऑफ द फोर्थ वेंट्रिकल? रूफ में ना दो व्हीलम होते हैं. एक होता है सुपीरियर मेडुलरी व्हीलम और दूसरा वाला होता है इंफीरियर मेडुलरी व्हीलम. और आपको सिर्फ एक पॉइंट यहां पर याद रखनी होगी. सुपीरियर मेडुलरी व्हीलम विल बी अ nervous structure, whereas inferior medullary velum will be non-nervous structure. It is non-nervous structure here. That's all. We are done entirely with the fourth ventricle here. तो इस तरीके से ना we are done with the dorsal aspect of brainstem also. Along with that, we have even seen what here, sir? Yes, the entire fourth ventricle is completed here. Now welcome to the clinical anatomy. Topic complete हो गया. अब हम देखते हैं clinical anatomy. Recently आपके एग्जाम में ये इमेज दिया गया था और यहाँ पर एरो मार्क. चलिए बताइए एरो मार्क कहाँ पर है? फेशियल कॉलिकुलस. अगर यहाँ पर इंजरी होगा तो क्या होगा? व्हाट विल हैपन? तो रिमेंबर, मैंने आपको क्लियरली बता रखा है कि फेशियल कॉलिकुलस विल बी फॉर्म्ड बाय 7th nerve व्हिच इज गोइंग टू टेक अ टर्न. अगर यहाँ इंजरी होगा तो सबसे पहले क्या होगा? नर्व इन्वॉल्व होगा. विच नर्व इज इन्वॉल्व? 7th nerve विल बी इन्वॉल्व. तो प्लीज रिमेंबर, द मसल्स ऑफ फेशियल एक्सप्रेशन विल अंडरगो पैरालिसिस. Don't mark the answer that 6th nucleus will be undergoing, injured there, and then lateral rectus muscle will be involved there. No. Remember, I'm telling you clearly, crystal clearly, that the 7th nerve is going to take a turn around that one. तो अगर facial colliculus पर injury होगा तो सबसे पहले 7th nerve injure होगा and muscles of facial expression will be gone. Clinical anatomy is also completed here. चलिए next topic. Now one more question here. In one of the exam they have given this image. In the image there was arrow mark behind the midbrain, and behind the midbrain arrow mark अगर यहाँ होगा तो कौन सी cranial nerve नजर आएगी यहाँ पर? Of course the 4th nerve. अगर मान लो if the arrow mark is little bit below behind the pons, and of course the cranial nerve that is visible behind the pons will be the 7th nerve. Please be very careful in the exam. ये मैंने आपको इमेज इसीलिए दिया है क्योंकि आप उसको प्रॉपरली वहां पर arrow mark देख पाओ. If the arrow mark is behind the midbrain, that is 4th cranial nerve visible, and if the arrow mark is behind the pons, then 7th nerve is visible. And by this, we are actually done with the ventral and dorsal aspect of the brainstem. And now, my dear friends, I want you all to be like 200% alert. अभी आपको ना धीरे धीरे समझ में आ रहा होगा. Almost like 30-35 minutes of the session is done here. I think now you're understanding my planning. We are not going to leave any topic here. We are going to discuss each and every topic. So in neuroanatomy, we are discussing like every topic possible here, है ना, जहाँ पर students especially you'll be like confused or you'll be making a mistake in that one. तो सारे topics हम यहाँ पर complete करेंगे. Is it okay? तो just be along with me here. चलिए आगे बढ़ते हैं. Now we are able to see the transverse section of the midbrain here. In the transverse section of the midbrain, this is the ventral aspect here and this is the dorsal aspect. और अभी अभी मैंने आपको बताया था dorsal aspect behind the midbrain there will be corpora quadrigemina. So for example, we have taken a section at the level of superior colliculus. Superior colliculus. Now, what do you have in the front here? There is a depression here, fossa, and that fossa will be interpeduncular fossa. इसको हम interpeduncular fossa कहते हैं. Now, this aqueduct of Sylvius is a very important landmark. इसके पीछे वाला जो part होता है ना aqueduct के पीछे, this part here will be tectum, and the part in the middle here, this part here will be the tegmentum. This is tegmentum part, and then in the front here, this one will be the cerebral peduncle. And between the two cerebral peduncle, obviously this fossa here will be referred to as what? This fossa here will be the interpeduncular fossa. So cerebral peduncle and cerebral peduncle, between them there is interpeduncular fossa. Perfectly done. Now after this, my dear friends, at the level of superior colliculus, you are able to appreciate a big nucleus here, which is red in color. This is red nucleus here, red nucleus here. ये भी आपके एग्जाम में पूछा गया था. Red nucleus is present in midbrain. And then you'll be having three lemnisci here. And these three lemnisci here, the medial most one, of course, that one will be the medial lemniscus. Okay, then you have got the trigeminal lemniscus, and then you'll be having the spinal lemniscus here. There are three lemnisci. And the fourth one, that is the lateral lemniscus, which is a part of your auditory pathway, where you learn that lateral lemniscus with the mnemonic as E. coli ma. याद होगा आपको. Remember that lateral lemniscus will not be visible here. Why? Because in E. coli ma, you know that the lateral lemniscus is going to continue along with the inferior colliculus. Inferior colliculus के साथ में वो continue करता है. And then the midbrain is connected to cerebellum behind with the help of superior cerebellar peduncle. This one is superior cerebellar peduncle. Okay. And lastly, every student knows very well, in the cerebral peduncle you'll be having gray matter, that is substantia nigra, and then the white matter here will be the crus cerebri. This is the crus cerebri here. I hope it is crystal clear. So once you are done with the transverse section of midbrain here, my dear friends, let us see all the midbrain syndromes right now. So already I have taught you this one in detail in our main videos. Okay. अगर आपको डिटेल में सारे सिंड्रोम देखना है, slowly you can go back to the main videos. Now welcome to LRR. Okay, let us have a quick revision here. Number one, I told you just now, this one here will be the white matter, and the white matter here will be the crus cerebri. In that white matter, you can actually divide that into three parts here. Out of the three parts, in the middle part there, that is a corticospinal tract, pyramidal tract that is going to descend down. Now, whatever area that is highlighted in red color, if this area is undergoing lesion, now this syndrome here will be nothing but your Weber's syndrome. तो Weber's syndrome में basically कौन सी nerve involved होती है? Third nerve. तो of course it will lead to what? Ipsilateral third nerve palsy. My dear friends, please remember, whenever nerve is involved, nerve is actually a part of your lower motor neuron. And lower motor neuron, it cannot be like contralateral. It is actually ipsilateral. तो यहाँ पर कोई confusion नहीं है. Nerve is a part of your lower motor neuron and it has to be ipsilateral only. And third nerve palsy, यार आपने ophthalmology already पढ़ रखा है, तो किसको नहीं पता है कि उसमें क्या होता है? In third nerve palsy, there will be down and out eyeball. Down and out eyeball. There will be loss of light reflection and all those things. तो of course, ये सब आपको already पता है. Number two, what else is getting involved here? Corticospinal tract. कॉर्टिकोस्पाइनल ट्रैक्ट कहां पर इन्वॉल्व है? मिड ब्रेन में. क्रॉसिंग कहां पर होता है? लोअर मेड्यूला में. इसीलिए तो मैंने ऑलरेडी आपको टॉपिक बता रखा है. तो इफ द इंजुरी टू कॉर्टिकोस्पाइनल ट्रैक्ट, पिरामिडल ट्रैक्ट इज टेकिंग प्लेस इन मिड ब्रेन, इट इज बिफोर डेक्यूसेशन. Before decusation, of course, it will lead to what, guys? Contralateral hemiplegia. Okay, and apart from that, you also have the UMN fibers of seventh nerve passing from here. Upper motor neuron, upper motor neuron fibers of seventh nerve passing from here. And you know very well, UMN fibers of seventh nerve, अगर वो injury होता है तो it will lead to contralateral facial paralysis, that to only the lower half. If the patient is going to come to you with these three things over there, of course he's suffering with what's a Weber syndrome. So third nerve palsy, ipsilateral third nerve palsy with the contralateral hemiplegia as well as contralateral facial paralysis. Of course, the person is suffering with Weber syndrome. Next one, please look at this diagram right now. Now in this diagram, if this much part is actually involved here, yes, of course, it will lead to Benedict syndrome. और बेनेडिक्ट सिंड्रोम में सबसे पहले आप देख सकते हो थर्ड नर्व इज गोइंग देयर, इप्सिलेटरल थर्ड नर्व पाल्सी होगा. Along with that, the important thing to remember is red nucleus, and please remember, red nucleus is the one which will be connected to basal ganglia, and basal ganglia में अगर वहाँ पर लेशन होगा तो obviously it will lead to chorea as well as tremors, and it will be contralateral chorea and resting tremors will occur. फाइन. अगर आपके एग्जाम के लिए अभी आप LRR सेशन में एटलीस्ट इतना अगर आपने रिवाइज कर लिया ना, यू विल बी एबल टू सॉल्व द MCQs देयर गाइस. यू डोंट हैव टू गो इनटू मच डिटेल्स अबाउट दिस ऑल द लेमिनिस्काई. अगर आपको पता है तो बहुत अच्छी बात है, अदरवाइज यू डोंट वरी अबाउट ऑल दिस थिंग्स राइट नाउ. जस्ट रिमेंबर दिस वन हियर माय डियर फ्रेंड्स. इज इट ओके? नेक्स्ट वन. Now, if superior cerebellar peduncle is involved along with the third nerve, then this syndrome here will be the North-Nagel syndrome. North-Nagel syndrome. Again, third nerve is involved. Nerve, it will be ipsilateral third nerve palsy. Superior cerebellar peduncle, cerebellum is getting involved. Of course, it has to lead to what? Gait ataxia as well as intentional tremors. Contralateral होते हैं, other की important है. And finally, behind this colliculi here, you'll be able to appreciate the pineal gland here. And अगर मान लो कि यहाँ पर pinealoma होता है, okay, then this is going to compress the colliculi. And colliculi are the one which are actually concerned with your vertical gaze. Or therefore, what is going to happen because of the pinealoma, this will be getting affected there, leading to, yes, impaired vertical gaze, where you have that classical sun setting sign in the Perinod syndrome. Okay, classical sunset sign in the Perinod syndrome. So in this manner, we have covered like all the syndromes in one diagram itself, my dear friends. In this manner, in one diagram itself, we are done with all the syndromes here, sir. Now moving on to the transverse section of the Pons. Now in the Pons, this one here will be the ventral aspect, and this one here will be the dorsal aspect. So in the ventral aspect, you're able to appreciate that there is a corticospinal tract passing from here and corticospinal tract passing from here. And then this one here will be the sixth nucleus and the sixth nerve coming out here. But this is the seventh nucleus here, and the seventh nerve is going to take a turn and then come out here, sir. So this is the seventh nerve here. And then, my dear friends, this is the eighth nucleus here, and eighth nerve is going to come out. जो मैंने आपको अभी बताया था, 6, 7 and 8 are going to exit from the pontomedullary junction. So remember that nuclei are present in the pons and the nerves are actually coming out from the pontomedullary junction. Perfect. If this is recalled in your mind, अगर आपने ये recall कर लिया है, and now, my dear friends, welcome here. Welcome here. Now in the Pons, if this part is involved, I mean to say the sixth nerve is involved, seventh nerve is involved along with the corticospinal tract, इस syndrome को हम कहते हैं Millard-Gubler syndrome. Millard-Gubler syndrome. मैंने आपको अभी एक को hint बताया था. What is a hint? जब कभी भी, whenever the nerve is getting involved, don't even think there, my dear friend. It will be ipsilateral only. Nerve, it's nothing but element. Element ipsilateral होता है, ठीक है ना? तो seventh nerve अगर involve होगा sixth nerve अगर involve होगा यहाँ पर ipsilateral convergent squint होगा. We know the world famous formula SO4 LR6 rest all by 3. LR6 lateral rectus is supplied by sixth nerve. If that lateral rectus is gone, of course it will be leading to convergent squint there. Seventh nerve. If seventh nerve is gone, again ipsilateral facial paralysis will occur. And corticospinal tract, again the same thing, that is before crossing. So therefore it will lead to contralateral hemiplegia. If you see this combination, of course it will lead to what's a Millard-Gubler syndrome. Is it okay? Next one, sir. After that, if the seventh nerve as well as the eighth nerve and this part is involved here, it will lead to what, guys? Pontocerebellar angle syndrome. Pontocerebellar angle syndrome में involved होता है. And remember, it's not due to any artery, the stroke of the artery. It's actually involved due to acoustic neuroma. Seventh nerve involved होगा, again the same thing, ipsilateral facial paralysis. Eighth nerve involved होगा, ipsilateral progressive deafness will occur in that one. And yes, of course, cerebellar peduncle. अगर peduncles यहाँ पर involved होंगे, cerebellum का involvement होगा, obviously it will lead to what, guys? Ataxia. So in this manner, in one diagram, you'll be able to remember the syndromes, my dear friend. Now, when you see the ventral aspect of the pons, तो यहाँ पर से क्या होता है, right in front of the pons there will be one artery. That artery will be the, yes, basilar artery. And if basilar artery, यहाँ पर अगर main trunk of the basilar artery, इसमें अगर stroke होता है तो obviously it will be leading to what? Bilateral effect. तो अगर bilateral effect होगा, it will be leading to bilateral Babinski sign. Bilateral Babinski sign will be occurring if the main trunk of the basilar artery is involved, sir. Next one. This diagram was actually given in your FMG exam, sir. आपके FMG exam में ना ये diagram actually दिया गया था. Just to identify, it is a transverse section of midbrain, pons or medulla. And after teaching you the concept very clearly here, my dear friend, this is the transverse section of midbrain, transverse section of the pons here, and the transverse section of medulla. You can clearly differentiate. Clearly, I told you that there will be like two elevations in the front, pyramid, and this elevation here will be the olive and olive, sir. And behind here, this one will be the floor of the fourth ventricle here. Is it okay? Next one. Now let us take one half of the medulla. I'm not drawing the entire medulla oblongata here. We are just taking half of the medulla oblongata over here. Fine. And in this one, if this part is involved, the medial wala part, medial medullary syndrome, that is also referred to as Digerine syndrome. Similarly, if this lateral wala part is involved, the lateral medullary syndrome or Wallenberg syndrome, जो आपके एग्जाम्स में हमेशा सवाल आता है. So please pay attention here, 200%, my dear friends. This is very important slide right now. Medial part, you're able to see the 12th nerve. 12th nerve is going to come out between the pyramid and olive, मैंने आपको कहा था. Done. And then there is a medial lemniscus here, as well as the corticospinal tract or pyramidal tract passing. All these structures are involved here. All these structures will be involved here, sir. Is it okay? So in medial medullary syndrome, what is going to happen if 12th nerve is gone? 12th nerve is the one which will be supplying to what? The tongue. So tongue will be deviated when the person is asked to protrude the tongue. और आपको पता है जो नर्व इंजूर होती है उसी साइड में टंग डेविएट होता है ऑन द इप्सिलेटरल साइड. 12th nerve के लिए टेस्ट होगा. Medial lemniscus, of course, it will lead to loss of contralateral, loss of fine touch, vibration, proprioception and all. And corticospinal tract, again the same thing. I told you very clearly, crossing medulla में होता है लेकिन lower medulla. तो here also the injury is actually before the decussation. तो contralateral hemiplegia होता है. Contralateral hemiplegia होगा, ठीक है ना? Now this syndrome is nothing but the medial medullary syndrome here. Now welcome to the Wallenberg syndrome, the lateral medullary syndrome. In this, I have highlighted two things here in the blue color. Observe that very carefully. I'll tell you a little bit slowly here. Now, number one, there will be fifth nerve nucleus involved. Trigeminal nucleus will be involved. That is the sensory nucleus of trigeminal. Sensory nucleus of trigeminal. That is the king of all the nuclei. I told you it is the biggest nucleus. It is having three parts. The mesencephalic, the chief sensory and spinal nucleus. तो यहाँ पर होता है medulla oblongata में spinal nucleus. I hope you are able to quickly revise, my dear friends. Then after that, you will also have spinal lemniscus. And spinal lemniscus किसका continuation होता है? It is the continuation of a lateral spinothalamic tract. Lateral spinothalamic tract का continuation होता है. So spinal nucleus of trigeminal, if there is a loss, we know that the trigeminal nerve is the one which is going to carry the sensory supply to your face. So if that is gone, it will lead to ipsilateral, on the same side, loss of pain and temperature from the face. Whereas, if the spinal lemniscus is gone, it is going to carry pain and temperature from the body. आपको याद होगा हमने एक निमोनिक पढ़ा था फनी सा, लात स्पाइनोथैलेमिक ट्रैक्ट. अगर आप किसी को लात मारते हो तो यस उसको पेन दर्द होता है और उसका तापमान बढ़ जाता है, टेम्परेचर बढ़ जाता है, बड़ा गुस्सा आता है ना? तो पेन एंड टेम्परेचर बट फ्रॉम वेयर? फ्रॉम द बॉडी, एंड दैट टू कॉन्ट्रालेटरल साइड, क्योंकि लेमिनिस्कस हमेशा क्रॉस होता है, क्रॉस होने के बाद ही फॉर्म होता है ना? तो देयरफॉर अगर आप ये ऐसे इसको ध्यान से देखोगे तो इन द फेस पेन एंड टेम्परेचर इज लॉस्ट ऑन द इप्सिलेटरल साइड, whereas in the body the pain and temperature is lost on the contralateral side, and this is known as crossed hemianesthesia. Crossed hemianesthesia. And अगर आपने ये देख लिया एग्जाम में, yes, blindly you can actually mark the answer there as lateral medullary syndrome. Lateral medullary syndrome, nothing but the Wallenberg syndrome, sir. Understood? So in this manner, please revise these 3 pages here, sir. In these 3 pages, yes, each and every syndrome will be actually covered in the simplest, easiest manner possible. अब इससे भी और भी आसान कुछ नहीं हो सकता है। इसके बाद सिर्फ यही बाकी है कि मैं जाकर आपका एग्जाम लिखूंगा या फिर सारे फैकल्टीज जाकर आपका एग्जाम लिखेंगे, ठीक है ना। तो इन वन प्लेस वी हैव कंसाइज्ड ऑल द सिंड्रोम्स हियर माय डियर फ्रेंड्स। अब इसके बाद भी अगर आप पूछोगे कि सर और कौन सा सवाल आएगा, उसको कैसे पढ़ना है सर, ये सारे सवाल आजकल ना, लाइक मोर यू गो नियर टू द एग्जाम, दिस टाइप ऑफ क्वेश्चंस विल कीप ऑन कमिंग अप इन अवर डीएम्स कि सर कैसे पढ़ना है सर, समझ नहीं आ रहा है सर, नॉट इतना आसान है सर, 3 पेजेस में सिंड्रोम खत्म हो गया, दैट्स ऑल। वन क्वेश्चन विल कम फ्रॉम हियर, डेफिनेटली वन क्लिनिकल क्वेश्चन विल कम फ्रॉम हियर, एंड देन यू कैन आंसर दैट वन सर। इज इट ओके? सो थैंक यू, थैंक यू, थैंक यू, थैंक यू। या of course, anterior-spinal artery will be involved. Yes, have some patience. We'll also do Brown-Sequard syndrome when we discuss about tracts. Of course, nowadays we have integrated questions only. Questions तो overlap ही आएंगे ना. चलिए sir. Now welcome to the next concept, that is about the tracts right now, guys. Pain, temperature, crude touch, and pressure. All of them is going to enter from the dorsal root ganglion. After entering from the dorsal root ganglion, it will go and end in a nucleus here. Can anyone tell me what is the name of the nucleus? Already asked in your FMG exam, sir. Already आपके FMG exam में आ रहे हैं, पूछा गया है sir. Can anyone tell me the name of this nucleus here? This nucleus here will be substantia gelatinosa. This one here will be the substantia gelatinosa. Okay. Now after yes, ending in the substantia gelatinosa, from here another fibers are going to begin. Yes, of course, my dear friend, there will be image based questions from here. That is the reason why I'm showing you so many images. That's the reason why I'm showing you images. I don't understand this question now. ये मैंने आपको इसीलिए तो बताया है, और मैंने बोला था कि आपके एग्जाम में ऐसा एरो मार्क दिया गया है और यहाँ पर इंजुरी करके पूछा गया है, तो इमेज दिया गया है ना. I don't understand this type of questions right now. Of course, images will be given. It's anatomy. Come on. Chaliye. Now, from the substantia gelatinosa, some of the fibers are going to begin, and those fibers are going to cross and go to the lateral side. और यहाँ से ये continue होता है as lateral spinothalamic tract. ठीक है ना? Then from here another fibers are going to begin. They're going to the anterior column, and they are the one which are going to form the anterior spinothalamic tract. और जैसे मैंने आपको अभी बताया था, just now I told you, pain and temperature will be carried by last spinothalamic tract, whereas the crude touch and the pressure will be carried by anterior spinothalamic tract. Is it okay? Next one. Now the fine touch, vibration, stereognosis, and proprioception, all this will also be entering from the dorsal root ganglion. After entering from here, yes, they are ascending up. Some of the fibers are coming from lower limb. If they are coming from lower limb, they are going to form fasciculus gracilis. Now some of the fibers are actually coming from upper limb, and if they are coming from upper limb, they are the one which are going to form fasciculus cuneatus. These two are nothing but present in your dorsal column, referred to together as dorsal column tract. अगर आपने मेरा ये सिंपल सा डायग्राम यहाँ पर याद रखा, if you remember this simple diagram over here, you can answer the question, what is Brown-Sequard syndrome? Remember, Brown-Sequard syndrome will be hemisection of spinal cord. आधा spinal cord कट हो गया है, मान लो half of the spinal cord is gone. Hemisection of spinal cord, sir. If half of the spinal cord is cut there, hemisection of the spinal cord, now you yourself answer me from my simple diagram here, अगर ये कट हो जाएगा तो pain, temperature, crude touch and pressure will be lost on the contralateral side. So contralateral loss of pain and temperature. Whereas fine touch, vibration, stereognosis and proprioception will be lost onto the same side. So ipsilateral loss of vibration, the position sense and everything will be there. And if you see this combination here, of course, the person is suffering with Brown-Sequard syndrome. So one of my students have asked the question, sir, what about the Brown-Sequard syndrome? Here it is, done in 2 minutes. So just remember my simple diagram here. This will help you a lot. Okay. Next one, my dear friends. After this one, welcome to the Brodmann areas and aphasia. Now I'll tell you, out of all the Brodmann area, the most important one, जो आपके exam में पूछा जा रहा है, somewhere here you'll be having area number 44 and area number 45 here, sir. and this area will be the Broca's speech area, sir. This one here will be the Broca's speech area. What is the number of the Broca's speech area? 44, 45. ये कहाँ पर होता है? In inferior frontal gyrus. This one here will be the frontal lobe here, and this one here will be the inferior frontal gyrus. In the inferior frontal gyrus, we'll be having Broca's speech area. And it is motor or sensory? Please remember this one will be the motor area. Now somewhere here you'll be having area number 22, and this one will be the Wernicke's speech area. So this one will be the Wernicke's area, so Wernicke's speech area. What is the number of Wernicke's speech area? Area number 22. कहाँ पर होता है? You can clearly see it's in temporal gyrus, superior temporal gyrus. So this lobe here will be the temporal lobe. ये superior temporal gyrus होगा, middle temporal gyrus, and then the inferior temporal gyrus. And yes, of course, it is actually the sensory area that is used for comprehension, understanding the speech. And these two are actually connected by arcuate fasciculus. Even ये भी आपके एग्जाम में पूछा गया था. So the Broca's speech area and the Wernicke's speech area are connected by arcuate fasciculus. Is it okay? अगर मान लो कि Broca's speech area is gone, if there is a lesion here, the person will not be able to speak, but he will be able to understand everything. Suppose if there is Wernicke's speech area, lesion in the Wernicke's speech area, the person will not be able to understand anything there. He'll be able to speak but not able to understand here. Wernicke aphasia, sensory aphasia. Okay. Then if suppose arcuate fasciculus, if there is a lesion in this one, yes, they are unable to connect. There is no conduction. इसको हम कहते हैं conduction aphasia. So repeat again. If the Broca's speech area is gone, then there will be expressive aphasia. बंदा बोल नहीं पाएगा. Okay, now Broca's aphasia. If the Wernicke's speech area is gone, then it will be sensory aphasia. If arcuate fasciculus is gone, then it will be conduction. The person will not be able to repeat the words. Repetition will be a problem there. Is it okay? Is it fine, sir? Done? Now, once you are done with this one here, I hope this will actually help you a lot in solving the MCQs. Basically, Broadman area से यही सवाल बार-बार पूछा जाता है. Now, welcome to cerebellum. In cerebellum, cerebellar cortex, this image is very much important. Image based question आएगा. In the cerebellar cortex, we'll be actually having 3 layers, and in these 3 layers, we'll be having 5 different types of cells. First, you learn the names of the 3 layers. The outermost layer will be the molecular layer, the middle layer will be the Purkinje layer, and the innermost layer will be the granular layer. In the molecular layer, you'll be having stellate cells and the basket cell. In the Purkinje layer, you'll be having Purkinje cells, and in the granular layer, you'll be having granular cells and the Golgi cells. Is it okay? Now, out of all these different types of cells here, remember, stellate will be inhibitory, basket inhibitory, Purkinje inhibitory, and even Golgi inhibitory. Only and only granular cells will be excitatory cells. Then look at the image there. In the image, the largest cells will be Purkinje cell, and they are flask shaped. So please remember 2 points regarding this one. It is the largest one, and it will be flask shaped cells. Okay? And last and final question here. हमेशा आपके एग्जाम में ये हिस्टोलॉजिकल इमेज दिया जाता है, और इस इमेज में हमेशा एरो मार्क होता है यहाँ पर. Identify this cell, and that is the only cell you can easily identify. That is Purkinje cells. Purkinje cells, guys. ठीक है ना? Next one, my dear friend. Now, after that, we are going to deal with the afferent and efferent. So first, let me tell you about the afferents here, sir. Let me tell you about the afferent right now, my dear friend. Now, what doctors have done here, all the fibers which are going to enter into the cerebellum, they are divided into climbing and mossy fibers. Climbing and mossy fibers, sir. So which fibers are climbing fibers? The fibers which are going all the way up to the molecular layer. That will be the climbing fibers, sir. That will be including only 2 tracts, olivocerebellar and para-olivocerebellar. That's all. Rest all will be the mossy fibers, and mossy fibers will be going only and only up to the granular layer. Clear? So the green colored one here will be your mossy fibers. Done. Then what about the efferent? After the information is going inside the cerebellum, now it has to actually come out of the cerebellum. Okay, so how it is going to come out? Yes, from the Purkinje cells. Now from the Purkinje cells, first of all, the information is going to come out to the deep nuclei, and from deep nuclei, the information is going to come out of the cerebellum. तो यहाँ पर 2 सवाल ध्यान से याद रखना. Efferent from the entire cerebellum. Answer should be the deep nuclei. Efferent from the cerebellar cortex, only the cortex. Then your answer has to be the Purkinje cell. Has to be the Purkinje cells है, ठीक है. And Purkinje cells are going to inhibit the deep nuclei. याद रखो, मैंने आपको clearly कहा था Purkinje cells are inhibitory. They are going to inhibit the deep nuclei via GABA. Fine. And finally about the deep nuclei of the cerebellum. In total, you'll be having 4 deep nuclei in the cerebellum. So. And we remember that with the mnemonic as doctors ate good food. Okay, doctors ate good food. Okay, no? And D stands for dentate nucleus, E stands for emboliform nucleus, G for globose, and F for fastigial nucleus. Dentate, emboliform, globose, and fastigial. You got to remember the order. You can clearly see the medial most nucleus will be the fastigial nucleus. The lateral most nucleus will be the dentate nucleus, and in fact it is the largest one. You can clearly see the shape of that one, that will be crumpled paperback shape. And sometimes what is going to happen, the emboliform and globose are combined together. Together they are nothing but your interpositus nucleus. Interpositus nucleus. Perfectly done. All the points has been revised here, sir. Now moving ahead, the circle of Willis. Okay. Now imagine here, this one will be the vertebral artery here and vertebral artery here. Both of them will combine together to form basilar artery, and finally that is dividing into posterior cerebral artery. So vertebral artery and vertebral artery will combine to form basilar artery, and that is going to finally divide into posterior cerebral artery here, sir. And now imagine here there will be internal carotid artery. That is going to give rise to ACA and ACA. Anterior cerebral artery, anterior cerebral artery. Not only that, the internal carotid artery itself will also give rise to the middle cerebral artery here. So this is middle cerebral artery here. Perfect. Now once you are done with this one, join them together. अब इन दोनों को जोड़ते हैं. Remember, ACA and ACA will be joined together by ACOM, anterior communicating artery. Internal carotid artery मैंने आपको already 2 branches बताए हैं. One is ACA and MCA. Now welcome to the third branch, and this one will be the PCOM, posterior communicating artery. Posterior communicating artery. In this manner, a beautiful circle will be formed there, and that is nothing but circle of Willis. Circle of Willis. Okay. Now, once you are done with the circle of Willis, what are the branches given by this vertebral artery here? You can very clearly see the vertebral artery is near the spinal cord. That is the reason why it is giving anterior spinal artery and posterior spinal artery. Then after that, it is also near the medulla oblongata. It is giving medullary branches. Then it is also giving a branch to cerebellum from behind. Yes, from below there. That is the reason why it will be referred to as your inferior cerebellar artery. And remember, that is your pica, posterior inferior cerebellar artery. Posterior inferior cerebellar artery. And it is also giving certain branches to the meninges covering your brain, and therefore there is nothing but meningeal artery, sir. Done. Clear? Now welcome to basilar artery. Basilar artery is also giving a branch to cerebellum from below, that is anterior inferior cerebellar artery, very famously referred to as ICA. Then it is also giving a branch to cerebellum from above, that is superior cerebellar artery. Already I said you, basilar artery is ending by dividing into 2 branches here, that is your PCA. And then finally, of course, it is lying on the pons. It is giving many branches to the pons there, that is pontine branches. Pontine branches. And finally, about the internal carotid artery, आपको already 3 branches पता है sir. ACA, MCA and the PCOM. ACA, MCA and the PCOM. You need to just add ophthalmic artery as well as the anterior choroidal artery are also the branches of internal carotid artery. Out of all this, remember the first branch here will be the ophthalmic artery, sir. First branch will be the ophthalmic arteries. Done. So in this manner we are done with this one. But आपके एग्जाम में जो सवाल आ रहा है about the aneurysm. If there is an aneurysm of the anterior communicating artery, ACOM, अगर ACOM का aneurysm होगा, आप इसका location clearly देख सकते हो. Of course, it will be compressing what there? Optic chiasma. Similarly, if there is an aneurysm in the PCOM, PCOM के साथ में travel करती है oculomotor nerve. That is your third nerve. That is why third nerve will be involved there. And if there is a rupture of saccular aneurysm, it will lead to subarachnoid hemorrhage. The most important is these 2 points here, sir. I repeat again, ACOM aneurysm is going to compress optic chiasma, and if there is a PCOM aneurysm, it is going to compress the third nerve. Third nerve is going to get compressed there, sir. By this, we have revised each and every topic of neuroanatomy. Okay, now, white matter, gray matter, all the 3 sections, internal capsule, fornix, brainstem, ventral aspect, dorsal aspect, even all the syndromes and everything, cerebellum, as well as, the blood supply of the brain, everything has been revised here. I think more than this, it can't be done in the LRR session, sir. Already we are doing like last resort revision. We are actually done with everything over here, sir. Okay. Piyush Kumar is writing there, advance mein happy birthday. Thank you. Even I don't remember that one. Thank you for reminding me. चलिए सर आगे बढ़ते हैं सर. So entire neuroanatomy is done here. Let's go ahead with the head and neck topic right now, sir. In head and neck topic, the first thing which is very much important will be about the cranial foramen. No doubt about this one, hai na? In head and neck topic, the most important one here will be the cranial foramen, sir. Are you with me? Now in the cranial foramen, in this diagram, it was really good, sir. Thank you, Ishan. Pharyngeal arches key entry. Achha. Fine. Now please look at this diagram here. In this diagram, this one here will be actually the body of the sphenoid bone, and then there is a lesser wing here, and then there will be the greater wing. Now between the lesser wing and the greater wing, यहाँ पर जो foramen होता है, that is superior orbital fissure. Now what are the structures which are going to pass through the superior orbital fissure? Remember the cranial nerve number 3, cranial nerve number 4, and cranial nerve number 6. And these are the one which are going to supply to your extraocular muscles. Along with that, there will be even 5-1, sir. 5-1 will be your ophthalmic nerve. And please be very, very careful here. Remember, ophthalmic nerve is actually not passing from here. Branches pass hoti hain. And that branch will be the frontal nerve. And then there will be nasociliary nerve. And then there will be the lacrimal nerve, sir. So frontal, nasociliary and lacrimal, these three are the branches of 5-1 और वो यहाँ से pass होती है. And along with this one, there will be ophthalmic veins passing from here, sir. So not the artery, remember, there will be ophthalmic veins which are going to pass from here. Is it okay? Ophthalmic vein which is going to pass from here, sir. Okay. How long this session will be? Okay, the session will be approximately for 2.5 to 3 hours. Okay. 2.5 से 3 घंटे तक का होगा. And I think मेरे ख्याल से जिस पोजीशन पर आप लोग हो राइट नाउ, यू डोंट हैव टू वरी अबाउट द टाइम बाय बिकॉज वी आर एक्चुअली इफेक्टिवली यूटिलाइजिंग द टाइम रादर देन वेस्टिंग द टाइम हियर एंड देयर, है ना. शाम के टाइम पर आपके ग्रुप स्टडीज़ वगैरह चलते रहते हैं जहाँ पर आप कॉफ़ी चाय पीते रहते हो. 2-2 घंटे तो ऐसे ही वेस्ट होते हैं. एंड वी आर इफेक्टिवली रिवाइजिंग एनाटमी जहाँ से 20 मार्क्स आते हैं सर. ठीक है ना. सो प्लीज़ डोंट आस्क मी दिस टाइप ऑफ क्वेश्चंस, रिवाइज दिस वन हियर. ठीक है ना. वेर एवर यू आर इन द वर्ल्ड सिटिंग देयर कंफर्टेबली लिजनिंग टू मी सर, स्टडी. ठीक है ना. इतने एक्चुअली ना ये बड़ा अजीब सा होता है एज अ फैकल्टी. आई थिंक एवरी फैकल्टी विल एग्री विद दिस वन हियर. बड़ा अजीब सा ये होता है कि कंटिन्यूसली विल बी गेटिंग मैसेजेस कि सर आप रिवीजन करवा दो, यूट्यूब पर करवा दो रिवीजन एंड ऑल. जब रिवीजन करवाते सर कितनी देर में हो जाएगा. सो इंसानी फितरत है कि इंसान को ना सुकून कहीं पर भी नहीं मिलता है ना. फोरामेन ओवेल. फोरामेन ओवेल वेरी फेमस वन, वेरी इंपॉर्टेंट वन. यहाँ से 4 स्ट्रक्चर्स पास होते हैं एंड वी रिमेंबर दैट विद द निमोनिक एज मेल. एंड इन मेल रिमेंबर M stands for mandibular nerve, A for accessory meningeal artery, L for lesser petrosal nerve and E for emissary vein. And then foramen spinosum is another important one. यहाँ से पास होती है एक आर्टरी जिसका नाम है middle meningeal artery. And in your FMGE exam, they will be giving clinical questions regarding this one. If there is a rupture of middle meningeal artery, it will lead to extradural hemorrhage or we say it as epidural hemorrhage. इसके लिए 2 पॉइंट याद रखिएगा. You'll be able to see that convex, biconvex shaped hemorrhage or we'll call it as idly shaped hemorrhage and all those things. Along with what sir? Lucid interval. Lucid interval. अगर आप ये 2 पॉइंट यहाँ पर याद रखोगे, you'll be able to answer easily any question regarding epidural hemorrhage. The artery involved will be the, yes, middle meningeal artery. Next one, internal acoustic meatus. The cranial nerve which is passing from here will be the 7th and 8th nerve passing from here. And jugular foramen is the one from where 9th and then 10th and 11th nerve is going to pass. Now, recently one question was given in the exam. In that question, my dear friend, remember foramen lacerum is given. This is your foramen lacerum here. But foramen lacerum is not like a proper opening or a foramen there. Remember, it's just a space which is left between the 3 bones. Which 3 bones? Number 1, this one here will be the sphenoid bone here. Of course, your sphenoid bone here. Now, this one here will be the occipital bone here. And yes, of course, this is the apex of petrous part of the temporal bone. Okay, I repeat again, sphenoid bone, occipital bone and temporal bone, इन तीनों के दरमियान में जो स्पेस है उस स्पेस को हम कहते हैं foramen lacerum. So foramen lacerum is the space present between the three bones. Okay, next concept here, sir. Nowadays in your exam, instead of giving the foramen, they are giving this image with the nerves. With the nerves, you should be able to identify the nerves here. Number one, what is the cranial nerve which is going to pass through this cribriform plate here, sir? Via the cribriform plate, it is cranial nerve number 1, olfactory nerve. Anyone can tell this one here. Okay. Then after that, what is this cranial nerve which is going to pass from the optic canal? Of course, it is optic nerve. You can clearly see the optic canal just medial to this process, which is referred to as anterior clinoid process. Just medial to anterior clinoid process will be having your optic nerve there. Now, यहाँ तक कोई भी पहचान लेगा, any student can identify. Now welcome to the confusion, जहाँ से सवाल आते हैं आपके एग्जाम में. Number one, this nerve which is actually going into the superior orbital fissure, this one here will be your third nerve. That is your third nerve, so oculomotor nerve. And this nerve here, so be very, very careful with this one. This one here will be your fourth nerve. I told you the fourth nerve, you just remember one point there. It is having dorsal origin. After originating dorsal, it is going to take a turn and come from the side. So that is your fourth nerve. And in the exam, if this image is given to you and you see any nerve which is climbing up from here, there is a slope and that slope is referred to as clivus. उस स्लोप से अगर कोई नर्व अगर ऊपर आ रही है तो that will be your sixth nerve, that is your abducens nerve. So you should be able to identify these three nerves crystal clearly. After that, anyone can identify here. The largest cranial nerve will be the trigeminal one. The one which is going to pass from internal acoustic meatus will be the 7th and 8th one. From the jugular foramen, there will be the 9th, 10th and 11th one. And then from the hypoglossal canal, there will be the hypoglossal nerve, 12th one. So anyone can identify the one which I have highlighted in the purple color there. That is important. Okay. Done. Moving ahead right now, sir. Superior orbital fissure. थोड़ा सा क्विकली रिकॉल कीजिए. अभी अभी मैंने आपको कहा था which cranial nerves are going to pass from here. Cranial nerve number 3 and then 4 and then 6 is going to pass from here. Along with the branches given by 5-1. What are the three branches given, sir? Frontal, nasociliary and lacrimal. और फिर मैंने आपको कहा था ophthalmic veins भी पास होते हैं. एन ऑप्थेल्मिक वेन दो होते हैं सर. एक होता है सुपीरियर ऑप्थेल्मिक वेन, दूसरा वाला होता है इंफीरियर ऑप्थेल्मिक वेन. नाउ ऑल द स्ट्रक्चर्स आर गोइंग टू पास फ्रॉम द सुपीरियर ऑर्बिटल फिशर. बट आपको याद रखना होगा कि देयर विल बी अ रिंग हियर एंड दैट टेंडिनस रिंग ऑफ जिन कहते हैं. एंड यू हैव टू रिमेंबर व्हाट आर द स्ट्रक्चर्स पासिंग इनसाइड द रिंग एंड आउटसाइड द रिंग. इसके लिए एक ब्यूटीफुल सा निमोनिक है सर, एंड द निमोनिक हियर इज लेफ्ट इज लेफ्ट आउटसाइड द रिंग. LFT, left is left outside the ring. Now what is left here, sir? Remember, L for lacrimal nerve and F for frontal nerve and T for trochlear nerve. So whatever I have highlighted here, LFT is left outside and remaining everything will be going inside, sir. But please be very careful, even the superior ophthalmic vein and inferior ophthalmic vein, that is also outside the ring. So lacrimal nerve, the frontal nerve and trochlear, LFT is left outside along with the ophthalmic veins, the superior ophthalmic and inferior ophthalmic vein. Remaining all the structures are going to pass inside the ring. Done. Next one is jugular foramen. Jugular foramen, what are the structure passing from here? मैंने आपको clearly बताया है कि 9th nerve, 10th nerve and 11th nerve is going to pass from here. Along with that, please remember, even inferior petrosal sinus and sigmoid sinus is going to pass. अगर आप मान लो कि my hand here is like jugular foramen here, sir. Okay, तो sigmoid sinus will come from here, it is passing there. Inferior petrosal sinus is passing, और ये दोनों मिलकर फॉर्म करते हैं internal jugular vein. That is the reason why the name of the foramen is given there as jugular foramen, sir. Understanding? The jugular foramen is the one from where the inferior petrosal sinus, sigmoid sinus, and all the three nerves are going to pass from there. One more question. Out of the three nerves, which is present in a separate sheath here, that will be the 9th nerve. 9th nerve is present in a separate sheath, whereas 10th and 11th will be present together in one common sheath there, sir. Perfectly done. Next one, next concept. How can we forget this one here? Pterion. Pterion is one of the most important topic for your exams. This topic is being asked like many times in your exam. We know that very well. Pterion is actually this H-shaped suture. It is formed between four bones. Number 1, frontal. Number 2, parietal. Number 3, squamous part of the temporal bone, and then the greater wing of the sphenoid. The pterion is formed between all these 4 of them. Now what you have to remember here is that what are the relations of pterion? What do you have just inside the pterion here? There will be middle meningeal artery. And you have to remember it is the anterior division or the frontal division of the middle meningeal artery. Already asked in your FMGE exam. And then yahin par kya hoga? You'll be having your brain here. And if you have your brain here, this is the frontal lobe and this is the temporal lobe. Between these two lobes, this sulcus here will be lateral sulcus or Sylvian fissure. And Sylvian fissure bhi yahin se start hota hai. And what do you have inside the Sylvian fissure? Middle cerebral vessels are present inside the Sylvian fissure. Okay. And then finally remember, pterion is actually formed by the greater wing of the sphenoid. But remember, just inside the pterion, there will be lesser wing of the sphenoid. Okay. So all the relations are completed here. Welcome to clinical anatomy. If there is an injury at pterion, I told you very clearly, what do you have just inside the pterion? Middle meningeal artery. और अगर वो rupture हो जाएगा, again it will lead to what? Epidural hemorrhage. It will again lead towards an epidural hemorrhage. And what is the artery involved there? Middle meningeal artery. It is going to pass from which foramen? Foramen spinosum. Clinically, how to identify? There will be that idly-shaped hemorrhage here, and along with that, there will be lucid interval. Every point is revised in your LRR session here, sir. Next topic, muscles of mastication. Now remember, in total, how many muscles of mastication do you have? You have like 4 muscles of mastication, sir. In total, there are like 4 muscles of mastication. Okay. Now in this diagram, the first one here, this one will be the masseter muscle here. Then this one here will be the temporalis muscle here. And please remember this very carefully. Yes. This one here will be the lateral pterygoid muscle, and this one here will be the medial pterygoid. Okay, so masseter, temporalis, the lateral pterygoid and medial pterygoid. Many times in your exam they have given image-based question of lateral pterygoid. How to identify? Lateral pterygoid muscle is the one which is attached to the capsule of temporomandibular joint. Temporomandibular joint ko attach hota hai, sir. Done. Now let us do one MCQ here itself. Yes. Temporalis muscle जो होता है ना, it's a big muscle, and posterior most fibers are actually more horizontal fibers. Temporalis muscle में ना जो posterior most fibers होते हैं, they're like more horizontal. So because these fibers are like more horizontal, when they are going to contract, it will be helping in retraction of mandible, pulling the mandible behind. Makes sense? And these fibers are actually helping in elevation of the mandible here. ओहो, तो टेम्पोरालिस के कितने फंक्शन होंगे? 2 फंक्शन होंगे. एक होगा एलिवेशन और दूसरा वाला होगा रिट्रैक्शन. अब आपके एग्जाम में दोनों भी ऑप्शन दिया गया था, एलिवेशन एंड रिट्रैक्शन, विच इज मोर बेटर ऑप्शन. तो रिमेंबर, एलिवेशन इज मोर बेटर देन रिट्रैक्शन. पहला सवाल यहां पर सॉल्व हो चुका है. नाउ वेलकम टू दिस 5 पॉइंट्स हियर, एंड फ्रॉम दिस 5 पॉइंट्स द क्वेश्चन विल कम इन योर एग्जाम, सर. What is the nerve supplied to all the muscles of mastication? Remember, all of them are supplied by mandibular nerve 5-3, which is the only muscle which is helping in opening the jaw, okay, or depression of the mandible, that is lateral pterygoid muscle. Remember, L for lateral pterygoid, L for lowering the jaw. L for lateral pterygoid, L for lowering the jaw. Retraction of mandible is done by temporalis. Already मैंने आपको बता रखा है. Most commonly involved in trismus. Trismus क्या होता है? Locked jaw. Locked jaw, it's like mute. Mute, remember, medial pterygoid. So medial pterygoid will be actually helping in, actually involved in trismus. Lateral pterygoid involved will be actually helping in depression of mandible. Don't get confused between medial and lateral there, sir. I repeat again. L for lateral, L for lowering the jaw, that is helping in opening the mouth, and medial pterygoid is the one which will be involved in the locked jaw. Accessory muscle of mastication will be buccinator muscle. ठीक है ना? Now after learning all this, please remember one more question was asked in your exam, sir. Locked jaw while yawning. They did not ask you the question directly like which muscle is involved in locked jaw. Locked jaw while yawning. Yawning, you're like opening the mouth. So then the answer has to be lateral pterygoid. Locked jaw देखते ही वहां पर आंसर medial pterygoid मार्क मत करिए सर, ठीक है ना? Locked jaw while yawning, it is lateral pterygoid. Definitely यहाँ से एक सवाल आएगा. और muscles of mastication, ये 5 पॉइंट अगर आप पढ़ोगे तो you will be able to solve each and every question here, sir. Moving ahead with the next topic now, tongue topic. In tongue topic, remember the muscles of tongue and the extrinsic muscles of tongue are very much important. Extrinsic muscles. Number one, you'll be having genioglossus muscle, genioglossus, and then from the styloid process, you'll be having one muscle here, that is styloglossus. Above here, there will be palate, and from the palate, there is a muscle coming into the tongue, palatoglossus. And below here, there'll be hyoid bone, and from there, there'll be hyoglossus muscle. So genioglossus, styloglossus, palatoglossus, and hyoglossus. All these four muscles you have to remember. Now, three MCQs from here. Out of all the muscles of tongue, which is the largest muscle of the tongue? Answer genioglossus. Which is the safety muscle of tongue? Answer genioglossus. Out of all the muscles of tongue, which is not a true muscle of the tongue? Palatoglossus. ये तो इसके नाम में ही लिखा है. It is a muscle of the palate as well as of the tongue. So palatoglossus muscle. I hope it is very, very clear. Now, all the muscles of tongue will be supplied by which nerve? What is the nerve supplied to the muscles of tongue? That is by 12th nerve, hypoglossal nerve. Except which one here? That is palatoglossus. And palatoglossus will be supplied by vago accessory complex. It is supplied by vago accessory complex. Okay, done. Now, how to test this one here? You will ask the patient to protrude the tongue. अगर मान लो my left side 12th nerve is gone, तो what is going to happen? Genioglossus, जो paired muscle होता है ना, genioglossus, तो left side genioglossus will be gone, that is paralyzed. That is the reason why the right genioglossus is the only one working. Now ask the patient to protrude the tongue. तो जैसे वो अपनी tongue को बाहर निकालेगा, right muscle is more dominant and there is no one to actually oppose from the left side. So therefore the tongue is going to deviate on the ipsilateral side. तो जिस साइड में टंग deviate होगा, उसी साइड वाला nerve involve होगा. So wherever the tongue is getting deviated, same side 12th nerve will be involved, sir. Okay, perfectly done. Now, nowadays they're asking like most of the questions from tongue topic from the papillae of the tongue, sir. Okay, nerve supply तो आप सबको पता है. Many a times in my main videos I told you, remember like 5, 7, 9, 9, 10, 10 आपको याद होगा है ना, anterior 2/3 and all those things. 5, 7, 9, 9, 10, 10 तो nerve supply तो बड़ा आसान है. Fine. Now, how to identify the papillae? Now, number one, this papillae here is actually the circumvallate papillae. Yes, of course, you're answering very correctly here. Hai na? Thank you. Now, how to identify this circumvallate papillae here? Remember, filiform papillae, they're like slender, very much thin papillae here. Fungiform, नाम से हमको समझ में आ रहा है कि they'll be like mushroom shaped, sir. Mushroom shaped होते हैं. But nowadays in your exam, they're giving most of the time circumvallate papillae. How to identify? Remember, circumvallate papillae, when you see the circumference at the top, it will be more longer, more larger when compared to the bottom. And then the most important thing is this cleft here. ये जो trench होता है ना, या फिर cleft कहते हैं इसको सर. So there will be a trench on either side and the bottom वाला part will be narrow when compared to the topmost part. Circumvallate papillae. Okay, circumvallate papillae. और इनका location कहाँ पर होता है? अगर मान लो कि this one is your tongue here. If this one is your tongue here, divide the tongue into anterior 2/3, posterior 1/3. तो anterior 2/3 में यहाँ पर होते हैं आपके circumvallate papillae. Now in this, remember, obviously in the oral cavity, which type of epithelium you'll be having? Is it simple single layered or multiple layered? Of course, multiple layered epithelium होता है. Multiple layered epithelium होता है यहाँ पर. Stratified epithelium होगा. That too stratified squamous epithelium, because wherever you have that wear and tear, ओके, वेयर एंड टेयर जहां पर होगा तो वहां पर ऑब्वियसली मल्टीपल लेयर होगा, स्ट्रैटिफाइड स्क्वामस. नाउ इन द ओरल कैविटी इट शुड बी लाइक केराटिनाइज्ड और नॉन केराटिनाइज्ड. इट शुड बी नॉर्मली नॉन केराटिनाइज्ड, बट द papillae which will be having keratinized stratified squamous epithelium, answer filiform papillae. Papillae का मतलब क्या होता है? Normally they should be having taste buds, but the one which is not having any taste buds, sir, no taste buds, answer again the filiform papillae. Okay, these are all the points you have to remember. That's all. You are ready for your exams. Is it okay? तो अगर आपको टंग टॉपिक में ये पैपिले वाला सवाल आएगा तो आपको ये सारे पॉइंट्स पढ़ने हैं. यू आर रेडी फॉर द एग्जाम्स रिगार्डिंग द पैपिले ऑफ द टंग. नाउ मूविंग अहेड विद द रूल ऑफ 17. अब ये रूल ऑफ 17 क्या होता है सर? Normally many of the students will be having a confusion. Ipsilateral contralateral के deviation कहाँ पर होगा? ओके, इप्सिलेटरल क्वाड्रिलेटरल में डिविएशन कहाँ पर होगा? तो फर्स्ट ऑफ ऑल यू ट्राई टू अंडरस्टैंड हियर, व्हेन द यूवुला इज गेटिंग डिविएटेड, दैट मीन्स वी आर एक्चुअली टेस्टिंग विच नर्व हियर? 10th nerve. When the angle of mouth is actually deviating, we are actually testing your which nerve, sir? 7th nerve. 10 plus 7 will be 17. Tongue, of course, tongue deviation, we are testing the 12th nerve, hypoglossal nerve. And when the jaw is deviated, we are actually testing the 5th nerve. and 12 plus 5 will be again 17. Okay, और जब 12 plus 5 17 होगा यहाँ पर ipsilateral deviation होगा, and then जब 10th और 7th होगा that will be contralateral deviation. That's all. That is rule of 17. Okay, that means if you see the uvula is getting deviated towards the left, it is actually the right vagus nerve which is getting involved. If you see the tongue is deviating towards the left, it means the left 12th nerve itself is involved. I hope you understood the rule of 17 here. By this rule, my students will never ever get confusion regarding ipsilateral or contralateral deviation. Is it okay? Next one, sir. Parasympathetic ganglion. Yes, ये important slide है और इस slide से आपके एग्जाम में कई बार सवाल पूछे जाते हैं सर. Seventh nerve, that is your facial nerve. Facial nerve will give rise to a branch that is greater petrosal nerve. Greater petrosal nerve is ending in which ganglion? Pterygopalatine ganglion. Already आपके एग्जाम में पूछा गया था. And then it is supplying to which gland? Lacrimal gland. Again the same seventh nerve is giving a branch, chorda tympani branch, और वो जाकर end हो जाता है into submandibular ganglion, and from here it will be supplying to submandibular and sublingual gland. And finally ये भी आपके एग्जाम में पूछा गया था, ninth nerve, cranial nerve number 9, via otic ganglion will be supplying to parotid gland. So remember, otic ganglion will be supplying to parotid gland, sir. Remaining glands, that is your lacrimal as well as submandibular, sublingual, everything will be taken care by which nerve? Seventh nerve. But parotid gland is supplied by which nerve? That is your ninth nerve. Very very important slide. देखने के लिए आपको बस 3 लाइन नजर आ रहे हैं, कई सारे MCQs यहाँ पर covered है सर. Just before the exam, when you're going one day before the exam, you just watch this very quickly at 2x, you'll be done, sir. Is it okay? Next one, mandibular nerve. Mandibular nerve, definite question you can actually expect from here. So that is your 5-3 mandibular nerve. Mandibular nerve में ना actually trunk होता है यहाँ पर. जैसे मैं आपको बता रहा हूँ, जहाँ बता रहा हूँ बस उतना ही देखिए सर. Don't get confused by looking here and there. Okay. So remember, mandibular nerve, first of all you'll be having the trunk of the mandibular nerve, and that trunk is dividing into 2 divisions. One is anterior, another one is posterior division. Anterior division, don't even worry about that one. It is supplying to the muscles of mastication. Muscles of mastication. Don't worry about the anterior division right now. You have to worry about the posterior division. Posterior division will be in turn giving like 3 branches, and we remember that as Ali branches. A for auriculotemporal nerve, L for lingual nerve, and then I stands for inferior alveolar nerve. I repeat again, A for auriculotemporal nerve, and then A for auriculotemporal nerve, L for lingual nerve, and I for inferior alveolar nerve. और ये तीनों nerve से, mark my words, there will be a question coming in your exam on 17 January. So 17 January, definitely a question will be coming in your exam from these 3 nerves. Out of these 3 nerves, one nerve will be definitely asked. Now what about the auriculotemporal nerve, sir? Auriculotemporal nerve will be supplied to the skin covering the auricle, only upper 2/3, not the lower 1/3. Lower 1/3 is supplied by the great auricular nerve. मैं आपको अभी बताऊंगा, थोड़ी देर में I'll show you. Okay. So upper 2/3 of the auricle, the skin is supplied by auriculotemporal nerve, and even the skin covering the temporal region, auriculotemporal. It is also supplied to the joint here. Which joint? Temporomandibular joint, and the most important one, parotid gland. It is also supplying to parotid gland, sir. तो अब बस ऐसे याद रख लो, auriculotemporal nerve will be supplying here, sir. Is it okay? Next one, lingual nerve. Lingual nerve, first of all, you should be able to identify in the exam. Remember, lingual nerve is going here, and it is passing through a ganglion here, and that ganglion will be submandibular ganglion. अब यहाँ पर lingual nerve से सवाल क्या आएगा सर? Listen, always the hot favorite question of your examiner. यहाँ पर gland होता है submandibular gland, और जो submandibular gland का जो duct होता है, the duct is going to take a spiral around the lingual nerve. ये lingual nerve के surrounding में ना turn होती है. अगर मान लो किसी वजह से, जैसे नॉर्मली आप लोग गुटखा वगैरह खाते हो, है ना, तो क्या होता है, दे शुड बी सबमैंडिबुलर ग्लैंड रिसेक्शन, उसको ग्लैंड को निकालना पड़ेगा. ऐसे क्लिनिकल क्वेश्चन दिया जाएगा, अ पर्सन वाज कंज्यूमिंग टोबैको एंड ऑल, तो वन फाइन डे व्हाट हैपेंड इज वी हैव टू remove the submandibular gland. So which nerve is most commonly injured there? It is your lingual nerve. Lingual nerve is most commonly injured there. And then inferior alveolar nerve, नाम से ही समझ में आ रहा है, inferior alveolar lower jaw. Yes, of course, it will be supplied to the mandible. It is going to enter into the mandible, and it is going to enter into the mandible via a foramen. That foramen will be the mandibular foramen. It's very simple. So please remember, inferior alveolar nerve is passing through mandibular foramen. It's not given in this diagram. Why? Because we have cut the mandible from here. हमने मैंडिबल को कट कर दिया है, तो अब बस इतना याद रख लो, इंफीरियर एल्वेलार इट्स गोइंग टू लोअर जॉ इट्स गोइंग वाया विच फोरामेन, मैंडिबुलर फोरामेन। परफेक्टली डन। नेक्स्ट वन सर, तो ये 3 एमसीक्यूज याद रख लीजिए, तीनों नर्व से आएंगे। नाउ फ्रॉम द सेम डायग्राम व्हाट आई हैव डन इज आई हैव पिक्ड अप दिस पार्ट हियर सर, हमने यहां से ये वाला पार्ट पिकअप कर लिया है। दिस बोन हियर विल बी द हायोइड बोन and then this muscle here will be the hyoglossus muscle. Now you should be able to identify this nerve here. Now this nerve here will be the lingual nerve, and you can very clearly see it's passing through a ganglion. That ganglion will be submandibular ganglion. और मैंने आपको यहाँ पर कहा था कि there will be a gland. Which gland? Submandibular gland. And you can clearly see the duct, and that duct is going to take a spiral turn around the lingual nerve. So whenever there is a submandibular gland resection, which nerve is most commonly injured? Most commonly lingual nerve will be gone, sir. Done. Next one here, this nerve which is going from below here and then all the way from here, it is going and supplying to all the muscles of tongue. Yes, this nerve here will be the hypoglossal nerve, sir. So this one will be the 12th nerve, hypoglossal nerve. Perfect. So lingual nerve and the hypoglossal nerve, you should be easily able to identify in this diagram. I hope it is crystal clear. Now, once you are done with this one, moving ahead with the next important question for your FMG exam, sir. Facial nerve and the palsy of that one. UMN and LMN lesion of the facial nerve, sir. UMN and LMN lesion of the facial nerve, we need to have a clarity. First of all, in this diagram, you are able to see cerebral cortex here. And then you're able to see the nucleus here. Nucleus, of course, we are speaking about the 7th nucleus, जो pons में होता है. मैंने आपको अभी डायग्राम में बताया था in transverse section of pons. And then you're having the 7th nerve, which is going and supplying to your face. Already in our main videos as well as in our offline classes, मैंने आपको ये detailed diagram हमने draw किया था properly. We have discussed the entire topic in crystal clear manner. अब ये वाले जो फाइबर्स होते हैं, जो न्यूक्लियस के ऊपर वाले जो फाइबर्स होंगे, दिस वन विल बी योर यूएमएन, अपर मोटार न्यूरॉन और सुप्रा न्यूक्लियर, एंड देन बिलो दिस वन हियर विल बी द इंफ्रा न्यूक्लियर और फिर लोअर मोटार न्यूरॉन, व्हाटएवर इट इज. ठीक है. इफ दिस लोअर मोटार न्यूरॉन इज गॉन हियर, रिमेंबर योर एंटायर हाफ ऑफ द फेस विल बी पैरालाइज्ड. If lower motor neuron is gone, then the entire half of the face will be paralyzed on the same side. I'm telling you from the beginning of this session, LMN, it is always ipsilateral. Sir. अगर मान लो कि UMN, upper motor neuron lesion is there, then what is going to happen? Contralateral side, only lower half of the face is gone, sir. Opposite side, only lower half of the face is gone. So first you got to remember that if the person is coming to you with complete half of the face gone, then it is LMN lesion. If lower half of the face is gone, then it is UMN, that to contralateral side. ये clear हो गया. लेकिन हमारे एग्जाम्स में, in our exams, they are not going to give you so nicely, sweetly, like, half of the face is gone and all. Now, listen to me. If lower half of the face is gone, number one, the angle of the mouth is drooping. They'll be giving you hint. So try to listen to me, the hints right now, sir. The angle of the mouth is drooping here, sir. Number two, the saliva will be dribbling from here, dribbling of saliva. Number three, which was given recently in the exam, because this lower half of the face, these muscles are paralyzed here, the food will be stuck between the gum and the cheek here. In this space, the food will be stuck. तो ये 3 पॉइंट आपको याद रखने होंगे. These 3 hints will be given to you. I repeat once more here, it's worth repeating. Angle of the mouth will be dropping, dribbling of the saliva, the food is stuck over here. समझ जाना चाहिए आपको. यू हैव टू अंडरस्टैंड दैट एग्जामिनर इज ट्राइंग टू टेल यू, एग्जामिनर चिल्ला चिल्ला कर आपको बता रहा है कि लोअर हाफ ऑफ द फेस इज पैरालाइज्ड. ओके. नंबर 2, along with this one, even upper half of the face is gone. तो क्या होगा? Yes, the person will not be able to form the horizontal wrinkles on the forehead. ये हॉरिजॉन्टल रिंकल्स फॉर्म नहीं होंगे. ही इज नॉट एबल टू एलिवेट द आईब्रोज, आईब्रोज को ऐसे रेज नहीं कर सकता. अनेबल टू रेज द आईब्रोज हियर. ओके. सो अनेबल टू रेज द आईब्रोज, अनेबल टू फॉर्म द हॉरिजॉन्टल रिंकल्स ऑन द फेस, ऑन द फोरहेड देयर. दैट मीन्स द अपर हाफ ऑफ द फेस इज गॉन, सर. So in this manner, if the complete half is gone, they'll be giving you all these hints here. I hope you understood the hints right now, sir. So please remember that very much carefully. Is it okay? चलिए अब हम बढ़ते हैं आगे. Transverse section of the neck. Now in the transverse section of the neck, my dear friends, you'll be having deep fascia, or we can say deep cervical fascia. That deep cervical fascia will be having different modification. You can see this yellow colored fascia surrounding the vertebrae. This one will be the prevertebral fascia. You can see this blue colored fascia around the thyroid gland, and that one will be in front of trachea, pretracheal fascia. Then you can see this red colored fascia here, which is surrounding the entire neck, and it is enclosing two muscles. One is sternocleidomastoid, another one will be the trapezius muscle here, sir. And this one will be the investing layer. And finally, the favorite of your FMG examiner, this sheath here will be the carotid sheath. Carotid sheath here, sir. Fine. Now, out of all these layers, first of all, investing layer, sir. Welcome to that red colored one, investing layer. Now, investing layer, there is like rule of two. It is investing like two things inside that one. Already मैंने आपको बता दिया, number one, sternocleidomastoid and the trapezius. Sternocleidomastoid and trapezius. ठीक है ना? Fine here, these two muscles. अब थोड़ा सा ऊपर आ जाइए. It is enclosing two glands here, parotid gland and submandibular gland. थोड़ा सा नीचे आ जाइए. It is enclosing two spaces here, supraclavicular, suprasternal. इतना आसान है. Two glands here, two spaces here, two muscles in the middle here. It is enclosing two things here. Along with that, two ligaments there. That is your stylomandibular and sphenomandibular ligament. And then along with that, two pulleys it is going to enclose, and those two pulleys will be for digastric and omohyoids. Done, done, done. Is it okay? Dr. Ayush Kumar, just now I told you very clearly how to differentiate between the inferior alveolar nerve and the hypoglossal nerve and lingual nerve present over there. मैंने आपको clearly आपको बताया है. जो nerve mandible के through pass होगी, that will be inferior alveolar nerve. Yes. वो inferior alveolar nerve होगी सर, जो mandible के through pass होगी, mandibular foramen करके, मैंने आपको clearly बताया था. Okay? Yes. Moving ahead. अगर मैंडिबल को रिमूव करके आपको बताया जा रहा है तो ऑब्वियसली वो हाइपोग्लॉसल नर्व होगा ना. तो मैंडिबल तो रिमूव हो गया क्योंकि वो नर्व मैंडिबल के अंदर से पास हो रही है. ऑलरेडी आई टोल्ड यू मल्टीपल नंबर ऑफ टाइम्स. Carotid sheath content every student knows very well. Inside the carotid sheath you'll be having common carotid artery. Along with that there will be internal carotid artery. Do you have external carotid artery inside that? No. नाम से हमको समझ में आ रहा है कि external carotid artery is actually coming outside, sir. Inside that you'll be having internal jugular vein also. Along with that 10th nerve, sir. यहाँ तक average MBBS student will be knowing very well. So every student will be knowing that inside the carotid sheath you'll be having common carotid artery, internal jugular vein and the vagus nerve, sir, 10th nerve. But please remember that the false contents of carotid sheath, it will also consist of a 9th nerve, the 11th nerve and the 12th nerve, but they are not present throughout the carotid sheath. They are present only in the cranial part of that one. So it is not in the entire carotid sheath, only and only in the cranial part of that one, sir. Is it okay? Next one, sir. Great auricular nerve. You can expect one question from this topic in your January exam, sir. 17 January को यहाँ से एक सवाल आएगा from the great auricular nerve. Now in this diagram, I hope you are able to see this point is referred to as nerve point or Erb's point. और यहाँ से क्या होता है from that Erb's point, yes, totally 4 nerves are coming out here, which are cutaneous nerves, of course, and they're going here, and then one is going here, one is going here, and one is going here. Now, in this LRR session, at least you should be able to identify this nerve here, and this one will be the great auricular nerve. It's going above straight here, that is your great auricular nerve. Now, this great auricular nerve, point number 1, it is going to run along with a vein here. Which vein do you have here, sir? External jugular vein. Now, after going here, it is supplied to the skin over angle of the mandible. The entire skin, the face sensory supplies by trigeminal nerve, the 5th cranial nerve, trigeminal nerve, except for the skin over the angle of the mandible. Skin over the angle of the mandible here, yes, it will be supplied by the great auricular nerve. And not only that, जो मैंने आपको अभी भी बताया था, lobule of the ear. I mean to say lobule of the ear, lower 1/3 of the auricle, that is also supplied by great auricular nerve. Upper 2/3 is supplied by auriculotemporal nerve, sir. ठीक है ना? Next one. Now they have given one clinical question after parotidiectomy. If there is a person is not able to sense anything in the shaving area, यहाँ पर sense नहीं हो रहा है, तो कौन सी nerve involve होती है? Great auricular nerve involve होती है, sir. And then Frey syndrome, yes. Answer me 2 questions, my dear friends. Let me see in the chat box right now. Frey syndrome में कौन सा वाला nerve injure होता है? Can anyone tell me in Frey syndrome which nerve is getting injured? Of course, very good, very good. It is ATN, auriculotemporal nerve is getting injured. एंड जो ऑरिकुलोटेम्पोरल नर्व इंजूर होता है, इट इज गोइंग टू रीजनरेट. नाउ व्हाइल रीजनरेटिंग, व्हाट इज गोइंग टू हैपन? इट इज मोस्ट कॉमनली जॉइनिंग विद विच नर्व? इट जॉइनिंग विद ग्रेट ऑरिकुलर नर्व. तो प्लीज रिमेंबर द नर्व दैट इज गेटिंग इंजूर्ड हियर विल बी ऑरिकुलोटेम्पोरल नर्व. एंड ऑरिकुलोटेम्पोरल नर्व जो रीजनरेट होती है, दैट रीजनरेटिंग ऑरिकुलोटेम्पोरल नर्व इज जॉइनिंग विद ग्रेट ऑरिकुलर नर्व. So you should have a clarity between these 2 points here. And because of that reason, what is going to happen? There'll be gustatory sweating here. Gustatory sweating. Sweating and redness will occur when the person is eating something. So all the points regarding the great auricular nerve has been compiled at one place. You can actually revise this one before the exam. Now, your examiner is also interested in this Zenker's diverticulum. Many times they are giving this image in the exam. This image will be given to you, sir. Zenker's diverticulum. Now, this diverticulum is between which two muscles? Yes, you know very well there is a muscle known as inferior constrictor. Inferior constrictor in fact is having two parts. This one from the thyroid cartilage to pharyngeal raphe, thyropharyngeus muscle, and this one from cricoid cartilage to pharyngeal raphe, cricopharyngeus. Between the thyropharyngeus and cricopharyngeus, there is a triangular area of weakness. And this weak area here will be referred to as what, guys? Killian's dehiscence. Killian's dehiscence. Okay, and from this Killian's dehiscence, there is an outpouching which will be coming here, and that diverticulum is referred to as, yes, Zenker's diverticulum. So Zenker's diverticulum is between which two muscles was the question? Remember, thyropharyngeus and the cricopharyngeus. Thyropharyngeus and the cricopharyngeus. Done. And nowadays the trending questions are, two questions are nowadays trending. So we are updating in our LRR session here, and they're also there in our main videos also, tonsillar bed. Now in this diagram you are able to see this tonsil here. अब ये tonsillar bed में क्या form होता है? पढ़ने का तरीका सीखिए. Remember, our tonsils are first of all present in a muscle here. Which muscle here? That is a superior constrictor muscle. तो पढ़ने आप पढ़ोगे कैसे? मेरे आइडिया से यहाँ पर पढ़िए सर. Study in my style here right now. There will be superior constrictor muscle. फैरिंग्स के जो मसल होते हैं ना, सर्कुलर मसल, कंस्ट्रिक्टर मसल, तो सुपीरियर कंस्ट्रिक्टर, मिडिल कंस्ट्रिक्टर, इंफीरियर कंस्ट्रिक्टर होता है. तो सुपीरियर कंस्ट्रिक्टर जो मसल होता है उसके अंदर आपका टॉन्सिल रखा होता है. अब ये मसल है, तो मसल में एक फेशिया अंदर होगा, एक फेशिया बाहर होगा. द फेशिया विच इज प्रेजेंट ऑन द इनर साइड हियर, दैट इज द फैरिंगोबेसिलर फेशिया, एंड द फेशिया दैट इज प्रेजेंट ऑन द आउटर साइड हियर, दैट इज द बकोफैरिंजियल फेशिया हियर. सो डन. सुपीरियर कंस्ट्रिक्टर मसल, वन फेशिया इनसाइड एंड वन फेशिया आउटसाइड. सर डन. Then after that, we know very well, अगर यहाँ पर ये tonsil होगा तो tonsil is covered by a capsule here, and that capsule is nothing but tonsillar capsule. Now, this muscle here, superior constrictor muscle along with the fascia, this one here is a capsule, और दोनों के दरमियान में यहाँ पर space है, and that space will be the paratonsillar space. And in that paratonsillar space, you're having a vein, and that vein here will be the paratonsillar vein. That's all. तो इस तरीके से पढ़िए आप. तो फर्स्ट सम स्टूडेंट्स आर जस्ट ट्राइंग टू मग अप लाइक इन सीक्वेंस 1 2 3 एंड ऑल दोस थिंग्स. पढ़ने का तरीका ये है, टॉन्सिल है तो मसल है, तो इस तरीके से आप देखिए उसको. ओके ना. ऑब्जर्व इन दिस मैनर कि देयर इज अ टॉन्सिल एंड अ मसल. Tonsil is kept inside a muscle there, and that muscle is having one fascia inside, one fascia outside. सीख लिया आपने. अब ये टॉन्सिल के ऊपर जो कैप्सूल होता है, तो कैप्सूल और उस मसल के बीच में स्पेस होती है. ऑफ कोर्स सराउंडिंग द टॉन्सिल paratonsillar space, having a vein there, paratonsillar vein. That will make your life easier. Understanding, my dear friends? That is all present in the tonsillar bed. Fine. अगर आपको ये समझ में आ चुका है, next another trending topic nowadays is pyriform fossa. Nothing but fishbone area, also known as the smuggler's pouch here. The pyriform fossa present here, sir. Okay. Medially there is epiglottic fold there, and laterally यहाँ पर होता है thyroid cartilage. Of course, the mucosa covering the thyroid cartilage होता है. You don't have to worry much about the boundaries. The most important point to learn here is, yes, what is a nerve? What is a nerve that is running there, sir? The nerve that is running there is internal laryngeal nerve that is going to run there, sir. Internal laryngeal nerve is actually running there. तो क्या होता है, sometimes when you're eating the fish bone will go and get stuck there. There is a pain by which nerve? That nerve will be the internal laryngeal nerve running from there. So these two topics are nowadays trending in your exams, sir. One is about the tonsillar bed, another one is about the pyriform fossa, and yes, of course, there can be a question from there. Is it okay? So please try to learn these topics here, and by this we have revised all the higher topics in head and neck. I hope it is crystal clear right now, sir. Is it okay? Now, my dear friends, here I'll give you 2 minutes of time, a little bit just to relax over there. Then we'll start with the remaining topics, and remaining topics will be done very, very quickly, sir. Okay. Upper limb, lower limb, thorax, and all those things will be done. Embryology part also we're going to discuss. All of that will be done very, very quickly. Okay. So just take a break for 2 minutes, just relax, and then we'll continue, sir. Let me also take a 2 minutes of break as a rest to my vocal cords. Okay. Of course, doctors will discuss nucleus pulposus wherever it comes. Sure. Welcome back, everyone. I hope I'm audible and visible to all of you. Just confirm me in the chat box, my dear friends, if I'm audible and visible to everyone. Yes, thank you. So now let's get started with the other topics. That is your upper limb, lower limb, thorax, abdomen, and the embryology wala part. Okay, and that will be done very quickly. Neuroanatomy and head and neck are those topics where most of the students will be actually not be clear in the concepts and all. So I did not want to take any risk over there. So we have revised almost every topic. Now welcome to upper limb topic. Definitely there will be like almost two questions coming from the upper limb topic, sir. And in the upper limb topic, the first three nerves that you have to learn, sir, out of the major nerve, the three nerves that you have to learn will be your ulnar nerve, median nerve, and the radial nerve. यहाँ से definitely आपके एग्जाम में सवाल आएगा. Now, before going ahead with the ulnar, median, and the radial nerve, try to recall the golden rule that I taught you in our main videos. All the muscles present in the anterior compartment of the arm will be supplied by musculocutaneous nerve. All the muscles in posterior compartment of the arm are supplied by radial nerve. Posterior compartment of the forearm is supplied by radial nerve. Anterior compartment of the forearm is supplied by ulnar and median, and same is with the hand. It is also supplied by ulnar and median nerves. Perfect. I hope everyone knows this one. Now, in this diagram, first you're able to see this is the arm here, sir. Now, in arm, will ulnar nerve supply to any muscle? Absolutely no. Try to recall my golden rule. Anterior compartment is by musculocutaneous, posterior compartment is by radial. Ulnar nerve is not supplying to any muscle in the arm. Now, the most important point you have to remember, this is lateral epicondyle here, and this one is medial epicondyle. Ulnar nerve is going to pass behind the medial epicondyle. And this is like a repeat question in your FMGE exam, और ये image based question दिया गया है. Arrow mark near the medial epicondyle, and what is the nerve going to pass behind that one? That is ulnar nerve. Ulnar nerve passes behind the medial epicondyle. Then after that, it is going to pass between the two heads of flexor carpi ulnaris muscle, और यहीं पर तो टनल होता है, और इस टनल को हम कहते हैं cubital tunnel. So remember, the nerve which is going to pass in the cubital tunnel will be ulnar nerve, and yes, of course, अगर यहाँ पर वो compress होती है, this syndrome is referred to as cubital tunnel syndrome. And now welcome to the forearm. Now in forearm, remember, ulnar nerve will be supplying to the muscles in anterior compartment. Which compartment? Anterior. But not all the muscles. It is supplying to medial 1.5 muscle. Now that one muscle here will be the flexor carpi ulnaris muscle, and another one will be the flexor digitorum profundus muscle, but only half, that to the medial half of that one. So in the forearm, it is supplying to 1.5 muscle in the anterior compartment. Then another point to remember here, चलिए आगे बढ़ते हैं, कहानी को आगे बढ़ाते हैं. It is going superficial to flexor retinaculum. Now this one is flexor retinaculum. और याद रखिए ulnar nerve is going ऊपर से. Remember ulnar ऊपर. तो ulnar nerve is going to pass superficial to flexor retinaculum, and यहाँ पर भी आपको याद रखना होगा, it is passing through a canal, and this canal is referred to as Guyon's canal. Already आपके FMG एग्जाम में सवाल पूछा गया था. It is passing through a canal superficial to flexor retinaculum there, that is Guyon's canal. Now after entering into the hand, again it will be dividing into superficial branch and deep branch. Superficial branch is supplying to palmaris brevis muscle, one of the hypothenar muscle, okay? And then along with that, it is also supplying to the skin of medial 1.5 digit, the little finger and half of the ring finger. Little finger and half of the ring finger, this skin is supplied by ulnar nerve. Then deep branch is taking care of all the remaining muscle, all the hypothenar, third and fourth lumbrical, the palmar interossei, dorsal interossei, and on the other side, adductor pollicis. This is very much important here. And this is the muscle where ulnar nerve is actually going and ending. इसीलिए इसको graveyard of ulnar nerve भी कहा जाता है. Is it okay? Now let us see the test for this one, sir, one by one. Number one, adductor pollicis, from the name itself, we are able to understand it is helping in adduction. So if you are giving a book to anyone or a paper to anyone, they are going to, yes, adduct the thumb and hold that one. अगर मान लो अल्नार नर्व इंजूर हो जाती है तो ऑब्वियसली द पर्सन इज नॉट एबल टू एडक्ट, तब वो क्या करेगा, he'll be using the flexor pollicis longus muscle and it is going to flex the thumb. तो थंब बेंट होगा. अगर ये थंब बेंट होगा, यस, यहाँ पर जो साइन है, इस साइन को हम कहते हैं फ्रॉमेंट साइन. फ्रॉमेंट साइन विल बी पॉजिटिव इन दिस वन. इज इट ओके? इसको हम कहते हैं बुक टेस्ट, दैट इज बुक टेस्ट. Another one, palmar interossei will be helping in adduction, dorsal interossei will be helping in abduction. I hope you all remember that very famous mnemonic, pad and dab. सो पामार इंट्रोशय विल बी नॉर्मली हेल्पिंग इन एडक्शन, और आप अगर किसी बंदे को कार्ड दोगे और आस्क देम टू होल्ड द कार्ड बिटवीन द फिंगर्स, ही इज एडक्टिंग द फिंगर्स. सो दैट मीन्स कार्ड टेस्ट हियर. And if the person is able to hold that card between the fingers here, yes, that means card test, perfectly done there. Palmar introshay, perfect there. And yes, of course, ulnar nerve is perfect over there. Similarly, dorsal introshay के लिए जो टेस्ट होता है पैड एंड टैप, dorsal introshay will be helping in abduction of the fingers. And इस टेस्ट को हम कहते हैं एगावा टेस्ट. This one is a एगावा test. So whether it is card test, whether it is book test, or it is, AGAVA test. In all the three tests, we are testing which nerve here? Of course, we are testing the ulnar nerve. We are testing which nerve only? Ulnar nerve, sir. And Froment sign आपके exam में दिया गया था. That's all. In this manner, neat and clearly, we have learned about the ulnar nerve. And I don't even have to tell you that silly thing. अगर ulnar nerve injure होगा, all these muscles will be gone and it will be like partial claw hand. Partial claw hand में कौन सी वाली nerve होगी? Ulnar nerve. ये तो सबको पता है. That is the reason why I'm telling you all those points where you might be missing before the exam. डन. एंड दैट टू, जैसे मैंने आपको स्टार्टिंग में कहा था, LRR सेशन के बिल्कुल स्टार्टिंग में मैंने आपको कहा था कि यस, इन दिस सेशन वी आर नॉट गोइंग टू वेस्ट अवर टाइम इन राइटिंग द थिंग्स एंड ऑल, सो वी आर सेविंग अवर टाइम. एवरीथिंग इज रिटन देयर. क्विक रिविजन. आई थिंक सब कुछ आपके माइंड में आ गया होगा अबाउट द अल्नार नर्व. मूविंग ऑन टू द नेक्स्ट वन, सर, मीडियन नर्व. नाउ मीडियन नर्व इज गोइंग टू पास फ्रॉम द आर्म. नाउ विल इट सप्लाई टू एनी मसल इन द आर्म हियर? Absolutely no. Try to recall my golden rule. Musculocutaneous and radial. Median nerve is not supplying to any muscle here. Then how it is going to enter into the forearm here? Again, the same thing. It is going to enter into the forearm by passing between the heads of two muscle. Sorry, between the two heads of a muscle. And that muscle here will be pronator teres muscle. That is pronator teres muscle. तो मीडियन नर्व कभी कभी वहां पर भी कंप्रेस हो जाता है और उस सिंड्रोम को हम कहते हैं प्रोनेटार टीरेस सिंड्रोम. Now in forearm, it is very much important. It is supplying to all the muscles in anterior compartment of the forearm except that medial 1.5, which is taken care by ulnar nerve. But important point here is median nerve is giving rise to a branch here, and that branch will be the AIN, anterior interosseous nerve. Anterior interosseous nerve is a branch of median nerve. Now in the anterior compartment, whatever muscles you have here, all those muscles are divided into two layers: superficial layer and deep layer. The superficial flexors are directly supplied by the median nerve itself, whereas the deep flexors are supplied by AIN. So AIN is actually supplying to the deeper layer muscle. Then the next one, about the flexor retinaculum. Median nerve is going to pass deep to the flexor retinaculum. Flexor retinaculum के नीचे से, and there is a tunnel, and that tunnel is nothing but the carpal tunnel. So median nerve is actually going to pass through the carpal tunnel, और अगर यहाँ पर वो compress होती है, it will lead to carpal tunnel syndrome. Again, after entering into the hand, the median nerve will be dividing into like two branches there. And one of the branch will be supplying to the remaining 5 muscles here. I mean to say 3 thenar muscle here, except the adductor pollicis and first and second lumbrical. So first and second lumbrical here and the 3 thenar muscle are taken care by median nerve. Now the cutaneous supply is very much important here. Normally during our first year MBBS days, हम लोग कैसे पढ़ते हैं कि median nerve is supplying to the lateral 3.5 digit here. But now let us learn in depth, my dear friend. There is a digital branch. And digital branch is supplying to the lateral 3.5 digits: thumb, index finger, and the middle finger, as well as half of the ring finger. This is taken care by the digital branch. Whereas the lateral 3.5 palm is supplied by palmar cutaneous. Please look at the way how I have drawn the diagram. Median nerve is actually going to come below the or deep to the flexor retinaculum. But palmar cutaneous branch is going to come above the flexor retinaculum, sir. So imagine this is the flexor retinaculum. Median nerve तो नीचे से आता है सर, palmar cutaneous branch उसके ऊपर से आती है. Is it okay? Done, sir. Now once you are done with this one, you know very well, अगर मान लो कि median nerve injury होता है तो of course all these thenar muscles will be gone and the thumb will be lying along with the finger. Ape thumb deformity, median nerve. Number 2, ask a person to make a fist like this here. Yes, अगर ये fold नहीं होगी finger, that is nothing but the pointing index. And then hand of benediction, median nerve. So please remember all these things. Ape thumb deformity, pointing index, as well as the hand of benediction. Yes, which nerve will be involved? Median nerve will be involved. And what is the test that is done for the median nerve? The test that is done is pen test, sir. So which test are we going to do for the median nerve, sir? Pen test. So we'll ask the patient to keep the hand like this here and keep the pen, ask to test the pen with the thumb like this. If he is able to do this one here, that is nothing but abduction, which is done by your abductor pollicis brevis muscle, one of the thenar muscle. So this is how you are actually going to test your median nerve, sir. I hope the concept is very clear now. Now, once you are done with this one here, let us go ahead with the next one, that is your radial nerve, sir. Now radial nerve is coming all the way from axilla here, sir. Now after coming from the axilla, it is going to go behind the shaft of the humerus into the spiral groove. वो turn होती है. Then it comes towards the lateral side of the arm, and right in front of the lateral epicondyle, it is going to divide into superficial branch and the deep branch. Perfect. So I repeat again, it's coming from the axilla, going through the spiral groove, lateral side of the arm, right in front of the lateral epicondyle, dividing into superficial branch and deep branch. Now let us see about the supply. जैसे मैंने आपको ऑलरेडी बताया है इन द गोल्डन रूल, रेडियल नर्व विल बी सप्लाइंग टू ऑल द मसल्स इन विच कंपार्टमेंट्स? पोस्टीरियर कंपार्टमेंट ऑफ द आर्म एंड फोर आर्म. नाउ इन द पोस्टीरियर कंपार्टमेंट ऑफ द आर्म विल बी हैविंग ट्राइसेप्स. Now in axilla itself it is supplying to the long head of triceps and a part of the medial head. Then थोड़ा सा आगे बढ़ते हैं. In the spiral groove it is supplying to the remaining part of the medial head and the lateral head along with anconeus muscle. And then lateral side of the arm, that is really important, it is supplying to one muscle, that is brachioradialis muscle. Along with that it is supplying to ECRL. Very much important, sir, ECRL. Why? Because ECRL is extensor carpi radialis longus. If this muscle is gone, you're not able to extend near the wrist drop hoga. So there you are going to decide कि wrist drop होगा कि नहीं होगा. Is it okay? That is ECRL. Then it is dividing into superficial branch. नाम से ही समझ में आ रहा है यार. It is going superficial like this here, and supplying to the skin on the dorsum of the hand. Skin on the dorsum of the hand here is supplied by radial nerve, superficial branch. Deep branch का क्या होगा? The deep branch is going to pierce through a muscle, that is supinator muscle. After piercing this muscle, it is going behind, and इसी को हम कहेंगे PIN. The name will change here. That itself is referred to as posterior interosseous nerve, and that is supplying to all the muscles in the posterior compartment of the forearm here. So, is it okay? Now once you have understood the entire course and supply of the radial nerve in a simplest manner, yes, of course, if the radial nerve is injured, am I able to extend near the wrist? No. So there will be a wrist drop. The wrist drop, which nerve is involved? Radial nerve. Saturday night palsy, radial nerve. Crutch palsy, the person is using the crutches, which nerve is gone? Radial nerve. Understanding? But please remember very carefully one beautiful question here. If there is only finger drop but not the wrist drop, wrist is perfect, sir. Only finger drop will occur. So only what is happening there? Extensor digitorum is gone. जो digits को extend करेगा, that muscle is gone. Then the answer has to be PIN. तो मैं यहाँ पर लिख देता हूँ. That is something really important. If there is an injury to PIN, then only finger drop will occur. Finger drop, but no wrist drops. Finger drop होगा, लेकिन wrist drop नहीं होगा. Then your answer has to be what, guys? The PIN. That's all, sir. So that is the best way to revise all the three nerves of upper limb topic. इससे आसान और इतना जल्दी नहीं हो सकता है, sir. So it's all like well planned. Please watch this video as many times as possible before going to the exam, and this is going to help you. And definitely out of these 3 slides, no doubt about that, one question is surely gonna come, sir. Okay ना, ulnar nerve, median nerve and radial nerve, ये 3 स्लाइड से एक सवाल पक्का डेफिनेटली आएगा. Moving ahead. Brachial plexus आप सबको पता है, it's going to originate from C5, C6, C7, C8 and then T1, sir. C5 and C6 together they will be combining to form upper trunk. C7 will just continue here to form your middle trunk, not joining with anyone, whereas C8 and T1 will join together to form the lower trunk, sir. And these trunks will be again dividing into divisions. Divisions will combine to form cords. Cords will divide into branches. ये सब हमको already पता है. अगर मान लो if there is an injury to upper trunk, then what is going to happen? It will lead to Erb's paralysis. So in Erb's paralysis, which trunk is injured? Upper trunk. What is the root value that is involved? C5 and C6 obviously. What is the sign? And the sign is nothing but the very famous one, waiter's tip hand or policeman's tip hand or porter's tip hand. In waiter's tip hand, what is happening at the arm? Arm will be adducted and medially rotated. What is happening at the elbow? Elbow is flexed or extended. You can clearly see in the picture. It's extended. And then what about the forearm here, sir? Forearm is supinated or pronated? It's actually pronated. And finally, the fingers are flexed. I repeat again. Arm will be adducted and medially rotated. Elbow will be extended. Forearm will be pronated. And the fingers are flexed, giving the appearance of a policeman's tip hand. The trunk involved here is upper trunk. And yes, of course, the root value of the upper trunk here will be C5 and C6, sir. Next one. Now the C8 and T1, these two will combine to form lower trunk. अगर मान लो lower trunk damage हो जाता है, it will lead to Klumpke's paralysis. If the lower trunk is damaged, it will lead to Klumpke's paralysis. And in clump-case paralysis, what is the root value that is involved? C8-NT1 will be involved there, sir. And what is the sign? The sign of clump-case paralysis will be claw hand. What is that one? Claw hand. And how to make the claw hand? Metacarpophalangeal joint will be hyperextended. Hyperextension at metacarpophalangeal joint, and then there will be flexion at interphalangeal joint. That makes your hand like a claw hand. Simple. I repeat again, hyperextension at the metacarpophalangeal joint, flexion at interphalangeal joint, make your hand like a claw hand. And claw hand is a sign of clump case paralysis. And then in this diagram, let me take another color here. In this diagram, from C5 and then from C6 and then from C7, and there is a nerve coming here, and this nerve is long thoracic nerve. What is the name of the nerve? Long thoracic nerve. And this long thoracic nerve, it is the one which is also referred to as nerve to serratus anterior muscle, or else it is also referred to as nerve of Bell. If there is an injury in this one, remember this image was given multiple number of times in your FMGE exam. If there is an injury to long thoracic nerve, of course serratus anterior muscle will be paralyzed. If that muscle is paralyzed, you are not able to keep the scapula onto the thoracic wall. It will be winging of scapula. And in winging of scapula, which border of the scapula is going to become prominent? That is medial border. Medial border of the scapula will become prominent. So, perfectly done. So in Erb's paralysis, clump case paralysis, and winging of scapula, yes, many times I'll be giving a question in your FMG exam. So we have revised this one in our LRR session here. Moving ahead, yes, how can we forget this one? Anatomical snuff box. Almost every exam they are giving a question from the anatomical snuff box. If you extend your thumb here, you'll be able to see a box present here, sir. Yes, you can put here something and snuff. Anatomical snuff box. Laterally, there will be like two tendons. One is your abductor pollicis longus, extensor pollicis brevis. Medially, there will be only one tendon, extensor pollicis longus tendon. Done. Now, in the floor, actually, you have to remember like four things here, sir. The lowermost part of the radius, that is nothing but the styloid process of the radius, and then the scaphoid, then trapezium, and base of the first metacarpal. So you actually have to remember the four bones here. But right now, at least, please remember that there is a scaphoid bone present in the floor here, sir. Because they are giving clinical question in your FMG exam. A person falls down on an outstretched arm. एक बंदा गिर जाता है और गिरते वक्त अपना हाथ ऐसे रखता है, outstretched arm पर वो गिर जाता है. Then he comes to the clinic with a pain in anatomical snuff box due to the fracture of which bone in the floor? Of course, most commonly fractured will be scaphoid. है ना? तो एटलीस्ट स्केफॉइड याद रखिए यहाँ पर. देन लास्ट एंड फाइनल थिंग, कंटेंट तो सबको पता है, इट विल बी रेडियल. प्लीज रिमेंबर इट इज आर्टरी सर, रेडियल आर्टरी, नॉट रेडियल नर्व, रेडियल आर्टरी. परफेक्टली डन गाइस. ओके, चलिए आगे बढ़ते हैं. नेक्स्ट वन हियर. हाँ, there are totally like three nerves related to humerus. Number one nerve which is related to humerus here will be axillary nerve, and that is going to pass behind the surgical neck of the humerus. Okay. Number two will be the radial nerve, and that is going to pass in a groove present behind the shaft of the humerus. That is nothing but spiral groove or radial groove. Okay. और अभी मैंने आपको बताया था ulnar nerve, it's going to pass behind the medial epicondyle. ये एक्चुअली आपके FMG एग्जाम में ना हॉट फेवरेट कॉन्सेप्ट है, इसलिए मैं दोबारा रिपीट कर रहा हूँ यहाँ पर. Yes, they are giving X-ray images. Now let us link the anatomy with radiology. If a person comes to you with a fracture of surgical neck of the humerus, most probably which nerve will be damaged? Of course, axillary nerve will be damaged. If the person comes to you with a fracture of shaft of the radius is damaged there, then which nerve can be gone? Radial nerve, because it is going to pass behind in the spiral groove. If a person comes to you with a fracture of medial epicondyle, of course, ulnar nerve will be gone there. So in this manner, I hope you'll be able to answer from here, sir. Next one, carpal tunnel. Now in this diagram, first you'll be able to identify this retinaculum here will be the flexor retinaculum. This is flexor retinaculum. Now what is the structure going to pass above? मैंने आपको अभी बताया था ulnar ऊपर. So what is the nerve which is going to pass above? Ulnar nerve. Along with that there is an artery. Which artery? Ulnar artery. And then there is a tendon here, that is palmaris longus tendon. So these structures are going to pass superficial to flexor retinaculum. Please remember that one. They are all going to pass superficial to flexor retinaculum. Now this tendon here will be the flexor carpi radialis tendon. It has to be radialis. It can't be ulnaris. It is towards the radial side, radialis. And that is going to pass through the flexor retinaculum. It is the one which is going to pass through the flexor retinaculum. Now, if you remember these three structures which are going to pass superficial, and this structure which is going to pass through the flexor retinaculum, remaining everything is going to pass deep to the flexor retinaculum. That's all. Study smartly in this manner. अगर मैंने आपसे अगर पूछा कि what is this nerve which is going to pass deep to flexor retinaculum through the carpal tunnel, of course that nerve will be your median nerve, है ना? That nerve is nothing but your median nerve. So, are you understanding me? Hello my dear friends, are you all alive? चलिए सर. So comfortably we are actually done with the so many topics here guys in the upper limb here. And another, nowadays they are asking a lot of questions here sir, that is about the abduction of the arm. So 0 to 15 degrees of abduction is done by supraspinatus muscle. 15 to 90 degrees will be done by deltoid muscle. The initiation of abduction start कौन करेगा? Supraspinatus. And after that 15 to 90 degrees is done by deltoid. Now I have to move the upper limb above हमको ऊपर करना है, तो that is done by that big muscle here, trapezius, and that will be helped by serratus anterior. Then above 90 degrees it is also referred to as overhead abduction of the arm. Is it okay? So in this manner you actually have to learn all these topics here. Upper limb topic has been completely revised here sir. Now welcome to the lower limb topic. आपको समझ में आ रहा है अभी? So everything is like well planned and सब चीज़ें है ना like quickly revise भी हो रही है in less amount of time, है ना? Crystal clear concept. Thank you. चलिए सर अब रिवाइज करते हैं लोअर लिम्ब टॉपिक. And in lower limb topic, my dear friends, remember, I will teach you one topic here that is going to cover almost everything and one question will come from there. I hope आप लोग नोट डाउन कर रहे होंगे कहाँ से मैं कह रहा हूँ कि सवाल आता है. ओके तो कोई पूछ रहा था कि सर क्वेश्चंस बता दो कौन से आने वाले हैं. एक्चुअली सर अगर ऐसे नहीं होता है, इट इज़ नॉट गोना हैपन लाइक दैट कि आई एम गोइंग टू गिव यू डायरेक्टली दोज 20 क्वेश्चंस व्हिच आर गोइंग टू कम इन एनाटॉमी. सो यू नीड टू कैच द हिंट्स व्हिच आई एम गिविंग यू इन द मिडिल, तो सवाल वहाँ से आएगा, डेफिनेटली आएगा. ठीक है ना? When I'm telling you that one of the section of the brain is coming, of course you need to catch that. एक सेक्शन वहाँ से ज़रूर आएगा. अब वी आर ऑल लाइक फैकल्टीज, वी आर ऑल्सो लाइक ह्यूमन बींग्स. इट्स नॉट लाइक यहाँ पर अचानक से मुझे जो है ना कुछ अता होती जाएगी और मैं आपको 20 सवाल दूंगा, ऐसा नहीं होता है. जो कॉन्सेप्ट होता है वहाँ से आएगा. ठीक है ना? उसको क्या कहते हैं? अता होने को हम कुछ कहते हैं ना कि हाँ प्रकट होता जाएगा और मैं आपको बताता जाऊँगा. मक्खन की तरह स्मूथ. थैंक यू. चलिए सर आगे बढ़ते हैं लोअर लिम्ब. नाउ इन द लोअर लिम्ब टॉपिक प्लीज रिमेंबर दैट फर्स्ट ऑफ ऑल यू हैव थाई. जैसे मैंने आपको अपर लिम्ब में गोल्डन रूल बताया था ना, तो सिमिलरली आई विल टेल यू द गोल्डन रूल इन द लोअर लिम्ब आल्सो. First, you remember in the thigh, all the muscles of thigh will be divided into 3 compartments: anterior, posterior, and the medial compartment. Similarly, in the leg, again it is divided into like 3 compartments: so anterior, posterior, and lateral compartment. It's kind of opposite. I repeat again. In thigh, anterior, posterior, and medial compartment. In the leg, anterior, posterior, and lateral compartment. Perfect. And in the foot, you don't have any compartment, simply muscles of foot. Anterior compartment of thigh is supplied by femoral nerve. Medial compartment of thigh, obturator nerve. Posterior compartment of the thigh is supplied by sciatic nerve, which is in turn made up of 2 components, tibial and common peroneal. Now in the leg region, again the posterior compartment is supplied by tibial. तो आप ऐसे याद रख लो कि in upper limb, entire posterior is by radial nerve. Similarly, in the lower limb, entire posterior will be by the tibial nerve. Now in the leg region, anterior compartment of leg, deep peroneal nerve, and lateral compartment of leg is by superficial peroneal nerve. So please remember this golden rule sir, it will help you a lot. Okay, next one. अब मैं आपको ना लोअर लिम्ब टॉपिक में आई एम गोइंग टू टीच यू द sciatic nerve here sir. Sciatic nerve अगर आप अच्छे से पढ़ लोगे, आई एम टेलिंग यू many times nowadays whatever questions they are giving, directly indirectly it is related with sciatic nerve only sir. तो उसको हम अच्छे से डिस्कस करते हैं. Okay, now first of all, sciatic nerve in the gluteal region sir. In the gluteal region, you'll be having one opening there, and that opening will be the greater sciatic foramen. The sciatic nerve is going to come out from the greater sciatic foramen. लेकिन कहाँ से? वहाँ पर एक मसल होता है जिसका नाम है pyriformis, and you can clearly see in my diagram it is coming below the pyriformis. The sciatic nerve is going to exit below the pyriformis. And we know very well sciatic nerve is made up of 2 components. One is tibial nerve, another one is common peroneal nerve. Will it supply to anything in the gluteal region? Absolutely no. There is no supply at all in the gluteal region. Done. अब थोड़ा सा हम नीचे. From the gluteal region, we are going to enter into the posterior compartment of thigh. And all my student knows very well, In the posterior compartment of thigh, you'll be having hamstrings, semitendinosus, semimembranosus, biceps femoris. Biceps femoris. Yes, these are all your hamstring muscle. अब यहाँ पर पंगा क्या है आपको याद रखना होगा कि सेमी टेंडिनोसिस इज सप्लाइड बाय टिबियल नर्व. आई मीन टू से टिबियल component of sciatic nerve. Tibial component of sciatic nerve. Semimembranosus is also supplied by tibial nerve. Is it okay? And bicep femoris, it will be having two heads. One will be the long head, another one will be the short head. Out of these two, only the long head is supplied by tibial nerve. Now, please remember the most important MCQ. Short head is supplied by common peroneal nerve cell. Short head, it will be supplied by common peroneal nerve cell. Is it okay? I'm not able to read your name, doctor. कीर्ता लिफ्ट, पता नहीं क्या लिखा है 24. ये नाम बड़े अजीब होते हैं आजकल ना, अपनी पहचान को ही छुपा रहे हैं लोग. नाम के लिए सब लोग काम करते हैं और अपने नाम को ही बताना नहीं है इनको. कीर्ता लिफ्ट्स करके कुछ लिखा है 24 में. अचानक से बंदे ने लिखा है कि स्वेस माइनर मसल एट लेसर ट्रोकेंटर PYQ मल्टीपल टाइम. My dear doctor, I am doing exactly the same work over here. Yes, we are discussing all the high-yield topics. I'll tell you about the attachments. If you suddenly write something like that in the middle of our conversation here, of course, others will also get disturbed. And one more thing to tell you, it's not psoas minor. It's actually psoas, yes, major along with the iliacus. So please don't write anything in the middle there. Yes, of course. We are going to discuss all the high-yield topics. At the end, you tell me. Fine. I know you have learned that very well. Please don't disturb others. Thank you. Thank you for understanding this one. Hanji, bicep femoris long head will be supplied by tibial nerve and the short head is actually supplied by the common peroneal nerve. Please remember that exception here. Now moving on to the next one, adductor magnus. थोड़ा ध्यान से सुनना होगा आपको. Adductor, actually it will be present in the medial compartment. अगर मान लो ये थाई है, in the thigh, adductor muscles are present in the medial. If it is present in the medial compartment, it should be supplied by obturator nerve, our golden rule. Adductor should be supplied by obturator. But please concentrate on the other word, magnus. It's a huge one. It's a big one. It's a big one. है ना? So therefore, adductor magnus means it will be present in the medial compartment and a part of that is present in the posterior compartment also. Posterior compartment also. तो इसलिए डॉक्टर्स ने इसको दो पार्ट में डिवाइड किया. Adductor part of adductor magnus in medial compartment, hamstring part of adductor magnus in posterior compartment. So we are in which compartment right now? Posterior. तो ये कौन सा वाला part होगा? Of course this will be the hamstring part. Of course this will be the hamstring part of adductor magnus, and please remember even this is supplied by the tibial nerve. That is the tibial component of the sciatic nerve. So perfectly done. So in this manner I am done with the posterior compartment of thigh. All the hamstring muscles are done here, sir. अब चलिए कहानी को आगे बढ़ाते हैं. I think you are understanding the story right now, sir. Yes. I hope you are understanding the story right now. So first we have seen the sciatic nerve in gluteal region. Then slowly we have seen that in the posterior compartment of thigh. अब कहानी को आगे बढ़ाते हैं. From the posterior compartment of thigh, it will enter into popliteal fossa. Yes. Now it is going to enter into the popliteal fossa. And right in the apex of the popliteal fossa, you can clearly see sciatic nerve के दोनों component फिर separate हो जाते हैं, tibial and common peroneal. And common peroneal is going towards the lateral side. Let us continue with the common peroneal right now. You know, in the leg region, you'll be having tibia and fibula. Fibula on the lateral side. ऐसे याद रख लीजिए. तो common peroneal nerve is going towards the lateral side, exactly near the neck of the fibula. ये landmark बहुत important है. Exactly near the neck of the fibula, deep peroneal nerve and superficial peroneal nerve will be separated. Now let us deal with them one by one. Deep peroneal nerve and superficial peroneal nerve. है ना? Now out of these two, first let us start with the superficial peroneal nerve. Superficial peroneal nerve will be supplying to all the muscles present in lateral compartment of the leg, our golden rule. And in lateral compartment of the leg, you have only two muscles. One is peroneus longus, another one is peroneus brevis. मैंने क्या कहा आपको? Now for example, if this is like right foot and the left foot, this is the lateral border, medial border. अगर आप lateral border elevate करोगे, eversion. अगर medial border elevate करोगे, inversion. Now peroneus longus and brevis are present in which compartment? Lateral. अगर वो muscle pull करेगा, तो that is going to help in what? Elevation of which border? Lateral border. That is nothing but eversion of the foot. So peroneus longus and brevis will be helping in eversion of foot. Deep peroneal nerve, it will be supplied to the muscles present in anterior compartment of the leg. Anterior compartment of the leg, there is one more peroneus और ये third वाली है, इसीलिए इसका नाम होगा peroneus tertius. Along with that, tibia के आगे, we are in which compartment? Anterior compartment. So in front of tibia, tibial is anterior. And in anterior compartment, you're having extensor hallucis longus, extensor digitorum longus. So extensor hallucis and extensor digitorum, these two are helping in dorsiflexion of the foot. है ना? If you're going to elevate the foot like this, dorsiflexion, then plantar. So dorsiflexion में help करेगा. Clear? Next one, sir. Now that is about the anterior compartment of the leg and the lateral compartment. Now what about the posterior? मैंने कहा the posterior compartment, it will be taken care by tibial nerve, sir. And in the posterior compartment of the leg, two muscles which every student knows, in the calf muscles, दो muscles जो सबको पता होता है, एक है gastrocnemius और उसके नीचे होता है soleus. Gastrocnemius के दो heads होते हैं, medial head and the lateral head of gastrocnemius and soleus. And out of these two, I hope you all know that soleus is referred to as the peripheral heart of the body. Peripheral heart of the body. Along with that, you'll be having two small muscle. One is popliteus and the plantaris. And now what you do is compare with the anterior compartment. अभी मैंने आपको बताया था anterior compartment of the leg. Tibial is anterior. तो obviously यहाँ पर होना चाहिए tibial is posterior. In the anterior compartment, you're having extensors. So they should be like flexors present over here. So flexor hallucis longus and flexor digitorum longus. And these flexors, they are actually going to help in plantar flexion. They are helping in the plantar flexion. So that's all. So in this manner, my dear friends, इसीलिए मैं आपको कह रहा था, अगर आप sciatic nerve पढ़ोगे ना, if you learn sciatic nerve, you can obviously see here, we are actually done with the tibial nerve, we are done with the common peroneal nerve, we are done with superficial peroneal nerve, the deep peroneal nerve, मतलब बहुत सारे nerves आपके यहाँ पर cover हो जाएंगे. Hardly in couple of minutes ये सर 2-3 मिनट में इसका रिविजन कंप्लीट हो गया है ना. चलिए सर, अब हम बढ़ेंगे आगे. नेक्स्ट वन हियर. एंड प्लीज रिमेंबर व्हाट इज द नर्व दैट इज गेटिंग इंजर्ड नियर द नेक ऑफ द फिबुला. अगर नेक ऑफ द फिबुला के पास में फ्रैक्चर होगा तो कॉमन पेरोनियल नर्व विल बी गॉन. इफ द कॉमन पेरोनियल नर्व इज गॉन, ऑफ कोर्स इट विल बी लीडिंग टू व्हाट? फूड ड्रॉप देयर. ओके, नेक्स्ट वन सर. थैंक यू. Nowadays in your exam they are giving this image based question and you need to identify the small nerves over here. इनको पहचानने का तरीका क्या होता है? Number one, you're able to see one rectangle shaped muscle over here, and this rectangle shaped muscle here, yes, of course, it will be quadrangular. So therefore quadratus, and it is present in which region? Lumbar region. So quadratus lumborum. And yes, this muscle here will be actually your psoas major muscle. Quadratus lumborum, and this one here will be the psoas major muscle. Okay. Now one of our friend was trying to tell this thing only, suddenly in the middle. This one will be the psoas major muscle here, along with this one coming from the ilium bone, that is iliacus. So iliacus and psoas major together, they are getting inserted onto the lesser trochanter. You can very clearly see in this one. Don't worry, मैं आपको आगे सारे attachment बताऊंगा सर, ठीक है ना? I think our friend was trying to tell the same thing. Yeah, 24. हाँ. Okay जी, हाँ. Now how to identify these muscles? Nerves now. I want all my students to just remember these two muscles here. So one is quadratus lumborum, another one is psoas major. Now observe very carefully. There'll be like two nerves coming in between the muscle. ये दोनों मसल के दरमियान से बाहर आती है. तो ये वाली नर्व होगी iliohypogastric, ilioinguinal. Can you see one nerve which is piercing psoas major? वो psoas major को pierce कर रही है और ये होगी genitofemoral nerve. And then one more nerve which is coming from the inner side of the ilium, ये जाएगी lateral side of thigh में, तो इसीलिए इसका नाम होगा lateral cutaneous nerve of the thigh. Lateral cutaneous nerve of the thigh. तो पहचानने का तरीका बड़ा आसान है सर, ठीक है ना? तो iliohypogastric, ilioinguinal coming between the two muscles there, root value L1 होगा. Genitofemoral nerve जो pierce कर रही है psoas major को, इसका root value होगा yes L1 and L2 there sir. And then finally lateral cutaneous nerve of the thigh, इसका होगा L2 and L3 sir. ये आपको रूट वैल्यू भी याद रखना होगा, इसलिए मैंने आपको सेपरेटली डायग्राम यहाँ पर दिया है. सो फ्रॉम L1 you are going to get iliohypogastric, ilioinguinal nerve, and then from L1 and L2, yes, these two, we are going to get genitofemoral nerve here, and then from L2 and L3 there, and together from here we are going to get lateral cutaneous nerve of thigh or lateral femoral cutaneous nerve. So done. Now, once you are done with this one here, once you are able to identify the nerves, I'll tell you the important MCQs from here. Chaliye, question number 1. The moment you look at this diagram, you're easily able to identify genitofemoral nerves. From the name itself, you're able to understand there are like two components in that, genital branch and the femoral branch. The one which is going here, this one will be the femoral branch here, sir. This is the femoral branch of the genitofemoral nerve, and you can clearly see this will be supplying to the skin over the femoral triangle. The skin over the femoral triangle, ये सवाल पूछा गया था. So the skin over the femoral triangle will be supplied by femoral branch of genitofemoral nerve, sir. What about the genital branch? Another branch that will be seen here will be the genital branch of the genitofemoral nerve. It will be going and supplying to the cremasteric muscle. Which muscle? Cremasteric muscle. ठीक है ना? So therefore, if there is any stroke here on the medial aspect of thigh, the same side, ipsilateral side testicles are going to move up. That reflex is referred to as cremasteric reflex. In every reflex, you'll be having one afferent nerve and one efferent nerve, sir. Which is the afferent nerve? Look at my diagram. It is like crystal clear. Crystal clear. If there is a stroke onto the medial side of thigh, the information will be carried by femoral branch of genitofemoral nerve, and that one will be the afferent nerve. And then after that, genital branch is going to supply to cremasteric muscle, and that one will be the efferent one. Crystal clear concept here. Okay. और यहाँ पर ना कभी कभी क्या होता है, फेमरल वेन जो होती है ना, तो फेमरल वेन को ना कैनुलेशन करना होता है. फेमरल वेन कैनुलेशन में कौन सी वाली नर्व एनेस्थेसाइज की जाएगी? ऑफ कोर्स द नर्व विच इज सप्लाइंग हियर, दैट इज फेमोरल ब्रांच ऑफ जेनेटोफेमोरल नर्व. Even that MCQ is done, sir. So I'm done with all the three questions here crystal clearly. Is it okay? Next one. After this one, nowadays this is like trending concept in your FMG exam, sir. Meralgia parasitica. पहले तो आप आराम से डायग्राम देखकर बताइए, what is this nerve which is coming from the inner aspect of the ilium? Lateral cutaneous nerve of thigh, which is going to supply the skin on the lateral side of the thigh. Is it okay? Now sometimes what is going to happen due to obesity, this nerve will be compressed over here because the abdomen will be protruded. So case number one, obesity. Case number two, or due to pregnancy, or number three, wearing tight clothing. This lateral cutaneous nerve of the thigh will be compressed near the inguinal ligament. अगर यहाँ पर वो compress हो जाएगा, it will lead to numbness, tingling, burning, pain, stabbing, all kind of sensations on the lateral side of thigh. और इसी को हम कहते हैं meralgia parasitica. So the patient will come to you with meralgia parasitica, with a tingling sensation on the lateral side of the thigh. Yes, of course, the nerve involved will be lateral cutaneous nerve of the thigh. And the root value of this one will be L2 and L3. Please remember that. It has been asked many times in your FMG exam, sir. Moving ahead, gluteal region. Now in gluteal region, we know that this muscle here will be gluteus maximus muscle. And then if you remove that maximus muscle, this is gluteus medius muscle here. And this one will be the gluteus minimus muscle. Gluteus maximus muscle, it will be supplied by inferior gluteal nerve, whereas medius and minimus will be supplied by superior gluteal nerve. Maximus is actually going to help in extension at the hip joint. Like whenever you're climbing up the stairs and all, extension at the hip joint. For example, you are sitting there, I'm sitting here. Our hip joint is actually flexed right now. So when you are like, climbing up the stairs, it will be extending. Extending the hip joint will be done by gluteus maximus. Whereas medius and minimus, these two will be helping in abduction at the hip joint. Keep that in mind. Now, apart from that, what else you have to remember here? This foramen here will be greater sciatic foramen. And I told you just now, the muscle coming out from the greater sciatic foramen will be piriformis. Piriformis. Then observe this diagram very carefully. You should be able to identify all these muscles here, sir. Now this muscle here will be the gemellus superior muscle. And just beneath that, this one is obturator internus. और इसके नीचे ये वाला मसल होगा gemellus inferior. This is gemellus inferior muscle, and this rectangle shaped one, again it is quadratus femoris. Quadratus femoris. Fine. And these two will be supplied by the same nerve, sir. Gemellus superior and obturator internus, nerve to obturator internus. And these two will be supplied by the same nerve, nerve to quadratus femoris. Nerve to quadratus femoris, sir. Okay. Now, once you are able to identify all these muscles here in the image, remember image-based question यहाँ से आता है, sir. ये हो गया. Now, the very famous clinical application from here will be the injury to this superior gluteal nerve. If the superior gluteal nerve is gone, medius and minimus will be gone. The person will not be able to walk properly, and that is nothing but Trendelenburg sign will be positive in this one here. Trendelenburg sign will be positive in this one here. Now, please remember this thing very, very carefully. Please, remember this carefully. If they are telling you the pelvis is sagging or dropping towards the left side, एक example याद रखिए, you can easily answer. Don't try to learn everything like left and right, left and right. If they're telling you the hip is dropping on the left side, when the person is walking, left foot is in the air there, left foot is off the ground, and the left side of the hip is dropping, then remember, contralateral side, opposite side, medius and minimus is gone. I mean to say, right superior gluteal nerve is actually gone, sir. Please keep that in mind. Okay, now contralateral side, opposite side superior gluteal nerve is gone, and medius minimus will be gone, sir. That is something important. So they'll be mentioning when the person is walking, the left foot is off the ground, then left side of the hip will drop. Remember, right superior gluteal nerve will be involved, guys. Clear? So that is something important. और इसको हम कहते हैं lurching gait. अगर only unilateral sagging is there, if there is bilateral sagging, there is nothing but waddling gait. I think you have seen those penguins walking. तो penguins are going to walk that waddling वाला gait होता है सर. Bilateral sagging हुआ तो. Now welcome to attachments of femur. ठीक है? Now welcome to attachments on the femur here, sir. Now on the femur, number one, this one here will be the ASIS, anterior superior iliac spine. और यहाँ पर दो structure attach होते हैं. One is your sartorius muscle is going to originate from here, as well as inguinal ligament. And this one here will be AIIS, anterior inferior iliac spine, and the muscle originating from here will be rectus femoris. First you learn this. After learning this one here, welcome to the gluteus muscles. Okay, gluteus maximus muscle will be attached to gluteal tuberosity. Gluteus maximus muscle will be attached to gluteal tuberosity. Already asked in your exam. और bracket में मैंने ऊपर already उसका action भी लिख रखा है. Gluteus maximus will be helping in extension as well as external rotation. अच्छा, by the way, what about the medius and minimus, sir? Remember, both medius and minimus will be attached onto the greater trochanter. But remember, gluteus medius will be attached onto the greater trochanter posteriorly, and whereas minimus will be attached onto the greater trochanter anteriorly. That's all. Okay, na? Ho gaya? The maximus, medius and minimus is done. And the one which is like a repeat question in your exams is lesser trochanter. Lesser trochanter पर दो मसल होती है, एक होता है श्वास मेजर और इलियाकस. और सवाल कैसे पूछा गया था? ऐसे आपके एग्जाम में. So radiological image was given, X-ray was given, and there is an arrow mark onto the lesser trochanter. Which muscle will be getting attached there? Iliacus and psoas major. एक और ट्रेंडिंग क्वेश्चन आपके एग्जाम में जो इमेज बेस्ड पूछा जा रहा है सर, रिसेंटली आईएनएस सेट में भी पूछा गया था एज एन इमेज बेस्ड. इस स्पाइन को हम कहते हैं इश्किल स्पाइन, और यहाँ से टर्न होती है नंबर वन पुडेंडल नर्व. Along with the pudendal nerve, there will be internal pudendal artery and internal pudendal vein. ठीक है ना? Along with that, there will be nerve to obturator internus. So remember PIN, pudendal nerve, internal pudendal vessels, as well as nerve to obturator internus. They are going to turn around the ischial spine. That is the reason why that is the site of, yes, blocking that pudendal nerve block, pudendal nerve blocks. I hope it is crystal clear. All the attachments on femur are completed here, sir. Next one. How can we forget this concept here? I cannot leave this concept even in LRR also. Like continuously in your exams, they're asking questions from here, sir. Every now and then they're asking the questions from here. Now this tunnel here will be the tarsal tunnel. This tunnel here will be tarsal tunnel. Actually, this one here will be medial malleolus and this is calcaneus. Between the medial malleolus and calcaneus, there will be fibrous band-like structure, flexor retinaculum. Because of the retinaculum, there will be formation of tunnel. वहाँ पर tunnel form होता है. Okay. Now remember, three tendons are passing from here. सबसे पहले होता है tibialis posterior. Then there will be flexor digitorum longus, and then there will be flexor hallucis longus. Three tendons. And then the nerve which is going to take a turn from here, coming from behind, will be your tibial nerve. Tibial nerve will be there, and nowadays the most important one, that is posterior tibial artery. There is a posterior tibial artery, and they have given this image in your exam where the doctor is trying to measure the pulse. Okay, now feel the pulse there with the help of which artery? That is nothing but the posterior tibial artery, sir. Posterior tibial artery exam में आ रहा है, ठीक है ना? And if you are done with all the structures, you got to remember them in order also, sir. So order में याद रखने के लिए एक mnemonic होता है, वो mnemonic है Tom, Dick and Harry. सो अगर आप ये निमोनिक याद रखोगे, सारे स्ट्रक्चर आपको ऑर्डर में याद रहेंगे, टॉम डिक एंड हैरी. ओके ना? इन टॉम डिक एंड हैरी, टी स्टैंड्स फॉर, यस, टिबियालिस पोस्टीरियर, And then D stands for, of course, digitorum, and it has to be like flexor, coming from behind the posterior compartment wale muscle, flexor digitorum longus. And in and, if you observe first, A is artery. Which artery? Posterior tibial artery. And N is nerve. Nerve stands for tibial nerve. And finally H here, hallucis. So they are arranged in the order of Tom, Dick and Harry. ऐसे याद रख लीजिए, ठीक है? Now once you are done with this one, welcome to the dermatome. Lower limb will be supplied by your L1, L2 and L3 up to the knee joint. पहले ये याद रख लो. And now lower limb is actually rotating inwards, embryology, है ना? So therefore after L3, L4 will be towards the medial side, whereas L5 will be towards the lateral side, sir. That is something important. They'll give you as an image based question. So L4 will be towards the medial side, L5 will be towards the lateral side, sir. Done. Okay. That is all about the lower limb that you have to revise. Every concept has been completed here, sir. Now welcome to thorax. One of the trending topic nowadays is again esophageal constriction. They can be questioned from here on 17th. Okay, 17th of January यहाँ से एक सवाल आ सकता है. Now esophageal constriction में sir totally ना 4 constrictions होते हैं. How many constrictions are there? 4 constrictions will be there, sir. ठीक है ना? Now first constriction will be right at the very beginning of the esophagus, जहाँ पर pharynx end होता है और esophagus begin होता है, and the muscle present there will be cricopharyngeus. Second one, where arch of aorta is going to cross that one. Third one, where the bronchus is going to cross that one. Okay, na? Left main bronchus or the left principal bronchus. And finally, the fourth constriction will be when the esophagus is crossing the diaphragm. Okay, diaphragm के पास में एक और constriction होता है. But when I was taking like certain offline classes, surgery faculty have told that there will be only 3 constriction. That is the reason why, my dear friends, I am showing you a screenshot from the latest edition of Grey's Anatomy, that is 42nd edition. Okay, and if you want the page number is 1057. Okay, and on this it is very clearly mentioned here, sir. यहाँ देखिए, कंस्ट्रक्शन बड़ा क्लियरली यहाँ पर लिखा गया है. टोटली कितने कंस्ट्रक्शंस होते हैं? 4. हाउ मेनी कंस्ट्रक्शंस आर देयर? 4. एंड यू नो वेरी वेल, वी मेजर फ्रॉम द इंसिजर्स. यहाँ से मेजर करते हैं. At 15 centimeters from incisors, you'll be able to find cricopharyngeus, beginning of the esophagus. At 23 centimeters from incisors, you'll be able to find the aorta. And then 28 centimeters from incisors, the left main bronchus. And finally at 40 centimeters, you are going to cross the diaphragm. So in anatomy textbook, the Bible of anatomy, that is Grey's Anatomy, but clearly mentioned kiya gaya, there are like 4 constrictions in the esophagus. Remember 15, 23, 28 and 40. 15, 23, 28 and 40, sir. Is it okay? Next one. Now welcome to the mediastinal surface. In the mediastinal surface of the lung, first of all, you'll be having the hilum of the lung, sir. Whether it is right lung or left lung, you're having hilum. और hilum के अंदर जो structures arranged होते हैं, for that you just remember the mnemonic. Above downwards there will be A, B, V. First you'll be having pulmonary artery, then bronchus, and then vein. Pulmonary vein, sir. How to remember this ABV? Remember with our respected ex-prime minister's name, Atal Bihari Vajpayee. Atal Bihari Vajpayee. Okay ना? ABV. और इसी को उल्टा कर दीजिए सर, VAB, and that is anterior-posterior. खत्म. तो ऊपर से नीचे, above downwards, आगे से पीछे, anterior posteriorly, it is VAB. तो ABV and VAB in the hilum. आसान हो गया. It's easy now. Are you getting me? Now once this is easy, sir, remaining things are damn easy, my dear friends. Now don't think that in your exam they'll be giving this image. No. They will not be giving this image with those structures. They'll be giving the image without the structure. And they'll be asking you, this impression is due to what? So first thing that every student should remember is that right lung or left lung middle से पास होता है esophagus. तो esophagus का यहाँ पर esophagus वाला impression यहाँ पर होगा ही होगा. Now अगर ये left lung होगा तो obviously your heart will be more towards there one. तो यहाँ पर ये heart वाला impression है. And from the heart, yes, ascending aorta is going to begin from here. And then it is going to arch. ये वाला arch of aorta वाला impression होता है. And then this one here will be the descending aorta. Are you understanding me? So in this manner, you are easy to decide, sir. ये बड़ा आसान होता है. And we can easily decide the right lung. After teaching this one, some students will be asking, sir, how to decide the right and left lung, sir? It's very easy. In the left lung, you'll be having a cardiac notch to accommodate the heart. And above that, you'll be having tongue-like structure, that is your lingula वाला part, sir. वो देखकर हम आसानी से identify कर सकते हैं. This cardiac notch will not be there in the right lung here, sir. Okay. Now, चलो ये सर ये तो सब आसान हो गया. अब यहाँ पर स्टूडेंट्स को कंफ्यूज कैसे किया जा रहा है? हाउ दे आर कंफ्यूजिंग इन द एग्जाम? दे आर गिविंग वन नर्व ओवर हियर एंड देन वन नर्व ओवर हियर, सर. चलिए मैं यहाँ पर लगाता हूँ A और B, सर. कैन यू प्लीज आइडेंटिफाई व्हाट इज दिस नर्व A? कैन यू प्लीज टेल मी व्हाट इज दैट नर्व ए सर? अब स्टूडेंट्स कंफ्यूज है, पता नहीं कुछ कुछ निमोनिक्स याद रख रहे हैं, जो आगे होती है, जो पीछे होती है, हाइलम के आगे, हाइलम के पीछे. यस, कैसे याद रखा जाए? हम्म. Now, my dear doctors, please remember here, don't try to remember that as आगे पीछे, हाइलम के आगे, हाइलम के पीछे and all. No. जो नर्व इसोफेगस के पास, देखो यहाँ पर गलती हो गई, देखो समवन इज आस्किंग वेगस नर्व, ए वाला वेगस नहीं है. सुनो, जो इसोफेगस के साथ में पास होगी दैट इज वेगस. इसोफेगस वेगस है ना. जो इसोफेगस के साथ में पास होगी वो होगी वेगस. और जो हार्ट होता है ना यार, जहां पर वो हार्ट होता है आपका, हार्ट के बिल्कुल पास से एडजेसेंट से जो नर्व पास हो रही है वो फ्रेनिक है. वो फ्रेनिक है. तो आगे पीछे कोई टेंशन लेने का जरूरत ही नहीं है. लर्न कॉन्सेप्चुअली, लर्न विद द कॉन्सेप्ट. द कॉन्सेप्ट हियर इज दैट द फ्रेनिक नर्व इज गोइंग टू ट्रैवल जस्ट एडजेसेंट टू द हार्ट. तो हार्ट के पास से जो नर्व पास हो रही है, इट हैज टू बी फ्रेनिक नर्व. दैट्स ऑल. इट हैज टू बी फ्रेनिक नर्व. आर यू गेटिंग पॉइंट हियर सर? तो ये फ्रेनिक होगी, वाली वेगस होगी, नो डाउट अबाउट दैट. इज इट ओके? चलिए आगे बढ़ते हैं सर. Now again, the moment I look at this diagram here, yes of course, मैंने कहा था esophagus is going to pass from the center. तो esophagus वाला impression दोनों lungs पे भी होता है. Now, I hope you all have learned about azygous vein. Azygous का meaning क्या होता है? Azygous means unpaired. It's unpaired. Okay, why the name is given like that? Unpaired, sir. So here you actually have the impression of azygous vein. It is a single and present towards the right side. अच्छा, अब ये azygous vein यहाँ पर arch होती है, arch of azygous. और हम सबको पता है, वी हैव ऑलरेडी लर्न इन डिटेल दैट एजाइगस विल ड्रेन इनटू सुपीरियर वेना कावा. इट हैज टू बी सुपीरियर वेना कावा. और ये कहाँ पर जाएगा सर? इनटू द हार्ट. चलिए दोबारा, लेट मी सी हाउ मच यू हैव लर्नड अलोंग विद मी इन दिस सेशन राइट नाउ. इफ आई एम ड्राइंग अ नर्व हियर सर, चलिए पहचानिए कौन सी वाली नर्व होती है सर? विच नर्व इज दिस वन हियर? डोंट वरी अबाउट आगे पीछे, जो हार्ट के साथ में पास हो रही है वो होती है फ्रेनिक नर्व. पढ़ने का तरीका. और अगर मान लो देयर इज वन नर्व प्रेजेंट हियर जो इसोफेगस के साथ में जाएगी, वो ऑब्वियसली वेगस होगी. परफेक्टली डन सर, है ना. दैट इज द वे हाउ यू आइडेंटिफाई दिस नर्व्स हियर. नेक्स्ट वन. Now these are the important topics about the hilum and mediastinal surface of the lung and all those things in thorax to be discussed in LRR session sir. Now moving on to the abdomen topic. In abdomen topic, nowadays they are giving about the planes of abdomen sir, and you have to remember they are at which level. Number one, there is a transpyloric plane or Addison's plane. Remember that will be at the level of L1. And then another one here will be the subcostal plane. From the name itself we can understand it is touching the lowermost margin of the costal. The costal cartilage is present over here. तो जो costal cartilages होते हैं, lowermost margin होते हैं, subcostal, and that will be at the level of L3. And then there will be one more plane which is in between the tubercles here, and that one will be the transtubercular plane here. And this transtubercular plane will be at the level of L5. अब जो आपके FMG एग्जाम में पूछा गया था, now I'll tell you the MCQs right now, sir. Listen to the MCQs right now. Number one, in the ilium bone, the highest part here will be the iliac crest. ये iliac crest होता है. And there is one more plane here which is going to touch at the iliac crest. And that is why the name is given as supracrystal plane here. And this supracrystal plane, remember, it will be at the level of L4. ये पूछा गया था आपके एग्जाम में. That was asked in your exam, my dear friend. Is it okay? L4, supracrystal. And then coming to the umbilicus here. यहाँ से दो सवाल. What will be the dermatome of umbilicus? I think आप सबने रट्टा मारा होगा T10. The skin surrounding the umbilicus, the paraumbilical region will be supplied by T10. Fine. But in your recent FMG exam, they have twisted. क्योंकि सारे स्टूडेंट्स रट्टा मार रहे थे. Umbilicus T10, umbilicus T10. उसने पूछा location. And location of umbilicus is between L3 and L4. You can clearly see in our diagram here, sir. So in this manner, all the points are covered here, sir. ठीक है ना? Next one, my dear friends, inguinal canal. Inguinal canal here right now. Definitely one question will be coming from here. Why? Because every time in FMG exam, one question will come from inguinal hernia. Now at this moment, when we are very much closer to the exam and doing LRR session right now, I hope I don't have to tell you about the number of layers in the anterior abdominal wall. You all know very well they are totally like 8 layers. 8 layers in the anterior abdominal wall. Now I'll tell you 3 points. Remember carefully here. Transversalis fascia. In this transversalis fascia, there is an oval shaped opening here and that will be deep inguinal ring. ये सवाल आपके FMG एग्जाम में 2 बार ही पूछा गया था कि डीप इंग्वानल रिंग किस लेयर में होता है? ट्रांसवर्सालिस फेशिया में होता है. एंड देन यूल बी हैविंग एक्सटर्नल ऑब्लिक एपोन्यूरोसिस हियर और यहाँ पर होता है ट्रायंगल शेप्ड ओपनिंग एंड दैट वन विल बी सुपरफिशियल इंग्वानल रिंग. तो सुपरफिशियल इंग्वानल रिंग इज प्रेजेंट इन एक्सटर्नल ऑब्लिक। अब इन दोनों के दरमियान में इंटरनल ऑब्लिक है और ट्रांसवर्स एब्डोमिनस है, इन दोनों को जोड़ दो। तो join the internal oblique and transverse abdominis, and you can clearly see both of them will be joining together. Together they are going to form a common tendon which is referred to as conjoined tendon or falx inguinalis, and that will be formed by internal oblique plus transverse abdominis. First, I want you all to remember these 3 points worth repeating. Let us repeat that again. So here, deep inguinal ring will be present in which layer? Transversalis fascia. Superficial inguinal ring is present in external oblique, and conjoined tendon is formed by internal oblique along with the transverse abdominis. Join the deep inguinal ring with the superficial inguinal ring. Join the deep inguinal ring with the superficial inguinal ring. Together they are going to form a canal, and that canal will be the inguinal canal. ठीक है ना? That is the inguinal canal, my dear friends. ठीक है? Now, in this diagram itself, you can learn what are the boundaries as well as content. Now, if this is the inguinal canal over here, what is present anterior to this one? इसके आगे external oblique है, internal oblique है. Wow, it is easy. What is present behind this inguinal canal? Transversalis fascia, conjoined tendon. Absolutely easy here, sir. Anterior हो गया, posterior हो गया. Superiorly, you can clearly see there internal oblique and transverse abdominis is going above the inguinal canal. No need to mug about it at all. Just remember this diagram in your mind. You will be able to answer that one. So what do you have superiorly there? You'll be having the internal oblique plus transverse abdominis. And below the inguinal canal, you'll be having inguinal ligament. That's all. And then content in females, it will be like a round ligament of the uterus. I hope you also have learned about that one in obs-gynae. A round ligament of the uterus along with ilioinguinal nerve. And in males, what do you have? Spermatic cord. So spermatic cord along with the ilioinguinal nerve. That's all, sir. We are done with the entire topic of inguinal canal. Now welcome to the spleen topic. In spleen topic, I want you to remember one important question, that downward displacement of the spleen in splenomegaly. अगर splenomegaly होता है तो downward displacement of the spleen is prevented by which ligament? That ligament will be phrenicocholic ligament. नाम में ही लिखा है phrenicocholic, between the colon and the diaphragm. So remember, downward displacement of the spleen will be prevented by phrenicocholic ligament here, sir. Okay. Next one. Kidney. In the kidney, you'll be asking about the relations of the kidney, sir. Anterior surface relation and posterior. Posterior surface relations of the kidney is very much easier. Just draw one horizontal and two vertical line here. Upper half of the kidney will be related with diaphragm. Now some students will be wondering here, sir, how come diaphragm is coming behind the kidney? Just tell me the shape of the diaphragm. It will be dome shaped. So if you have like both the kidneys present over here, the dome shaped diaphragm is coming behind the kidney. Absolutely right. And then below here, medially there will be psoas major muscle, and then just lateral to that quadratus lumborum muscle, and just lateral to that transversus abdominis muscle. So that will be the posterior surface relations of both the kidney. Now welcome to anterior surface relation. This image based question was given to you, sir. So how to deal with this one? I'll tell you in a simple manner. Upper part of both the kidney will be covered by suprarenal gland. Suprarenal gland. So chalo, ye to same hai. Lower part of the kidneys will be having the colic area and colic area, the jejunal area and the jejunal area, sir. Okay, na? Because the colon is going to go from here, the transverse colon, and then descending colon is going here, and that is going to go in front of both the kidneys. And below that will be having the coils of jejunum. So till here, it is absolutely the same for both the kidneys. First, you learn it in this manner, the way I'm telling you here. Okay, na? The upper pole of both the kidneys will be having suprarenal gland, suprarenal area will be there, and lower pole will have colic and jejunal area. The middle part will be different, sir. Now on the right side, what do you have in front of the right kidney? On the right side, you'll be having like big bulky liver present here. And then, yes, of course, the duodenum is going to take a turn here. That is your second part of duodenum here, sir. Makes sense? And on the left side, what do you have here? You'll be having spleen. अगर spleen होगा तो common sense वाली बात है, the pancreas is going all the way up to the spleen. So this is pancreatic area, and whatever is left out, that will be covered by your stomach here, sir. That is gastric area. Makes sense? So in this manner, make it easy here, sir. Okay. तो आपके exam में, in one of the exam, they have given this image, and in that image, they have put an arrow mark here, sir. Identify what it is related to. It is related to stomach. Perfectly done. Next topic here, sir. Yes, another very, very high yield topic. I don't even have to tell you like again and again, because we are dealing with all the high yield topics here. Openings of diaphragm. There are three major openings of diaphragm, that is vena cava opening, esophageal opening, and aortic opening. Remember, vena cava opening will be at the level of T8, esophageal opening will be at the level of T10, and aortic opening will be at the level of T12. Vena cava opening is the one which is present in central tendon of diaphragm. You can clearly see there in the diagram. Whereas aortic opening is between the right and left crus of the diaphragm. और ये तो इमेज बेस्ड क्वेश्चन आपके एग्जाम में रिसेंटली दिया गया था. Between the right and left crus of diaphragm, you'll be having aortic opening. Now we know very well if the opening is present there, you need to remember the structures. What are the structure passing through vena cava opening? Inferior vena cava. लिखो और भूल जाओ. They will never ask you vena cava opening से inferior vena cava pass होगा. Remember, along with that, there will be right phrenic nerve passing from here, sir. T10. T10 esophageal opening है तो यहाँ से क्या पास होगा? Obviously, esophagus is going to pass. लिखो और भूल जाओ सर. Examiner will never ask you what is passing through esophageal opening. Esophagus. Along with the esophagus, vagus nerve will be passing. याद आ रहा है कुछ? I hope you're able to recall. And what is going to pass through the aortic opening? Of course, aorta. Along with the aorta, there will be azygous vein, and along with the azygous vein, there will be thoracic duct. There will be even thoracic duct passing from here, sir. So that is about all the openings, where they are located, and finally what is passing through the openings of diaphragm. Next one is about abdominal aorta. Abdominal aorta, of course, abhi मैंने आपको पढ़ाया, so it has to be beginning from where only? T12, and it is going all the way up to L4, sir. Right at the level of L4, it will be dividing into that common iliac arteries. Now, abdominal aorta is giving like many branches here, like ventral branches, dorsal branches, and lateral branches. In short, it is giving the branches in every direction. Ventral, dorsal, and lateral. But right now in this LRR session, I want you to remember, ventrally it is giving 3 branches. Number 1, there will be celiac trunk. Number 2, there will be superior mesenteric artery. Number 3, there will be inferior mesenteric artery. Celiac trunk will be given at the level of, right at the level of T12 only. ये आपके FMGE exam में पूछा गया था. Superior mesenteric artery will be at the level of L1. Inferior mesenteric artery will be at the level of L3. Okay. So celiac trunk will be given at T12, and then superior mesenteric artery at L1 and inferior mesenteric artery at L3, sir. Fine. And apart from these 3 ventral branches, remember 1 lateral branch. Laterally वैसे तो 4 branches होते हैं, so remember 1 lateral branch, and that lateral branch will be testicular artery or ovarian artery, sir. In short, we'll call it as gonadal artery. तो testicular और ovarian artery आपके एग्जाम में 2 बार ही सवाल पूछा गया है, and that too a simple question, sir. Testicular artery is a branch of which one? Remember, it's a branch of abdominal aorta. Ovarian artery is a branch of which one? Of course, it's a branch of your abdominal aorta. Done, sir. Okay. Next one, celiac trunk. Now, celiac trunk, it is given right at the level of T12, and there are like 3 important branches from here. One is your left gastric artery. Another one will be the splenic artery. Another one will be the common hepatic artery. The easiest one will be the left gastric artery. Yes, moderate one will be the splenic artery, and then the most difficult one will be the common hepatic artery. Let us see all of them one by one right now. Now, from the name itself, we can see here, left gastric artery is going along the lesser curvature of the stomach, and on the way it is giving the branches only and only to esophagus, esophageal branches. That's all. We are done with the left gastric artery, sir. Left gastric artery, खलास. ये सबसे आसान है, जैसे मैंने आपको कहा था. Done. Number 2, there will be splenic artery. And splenic artery, the first point, remember, it is a branch of celiac trunk, and it has to go to the spleen, right? So will it be going in front of the stomach or behind the stomach? It is going behind the stomach. It is one of the stomach bed relation. Now, while going towards the stomach, it is giving the branches along the greater curvature of the stomach. That is gastroepiploic artery and the short gastric arteries near the fundus. And finally, into the hilum of the spleen, there will be hilar branches. So, perfectly done. Okay. And finally, welcome to the most important one, the common hepatic artery. From the name itself, you are able to understand common. Common means it will be again dividing into 2 arteries here. One is the one which is actually going towards your liver here. That is proper hepatic artery. Another one which is going down here. It is present between the stomach on one side and duodenum on the other side. Stomach, gastro, duodenum, duodenal. Gastroduodenal artery. So first you people remember that common hepatic artery will be in turn dividing into, yes, proper hepatic artery and gastroduodenal artery. Proper hepatic artery and gastroduodenal artery. Now first let us deal with the gastroduodenal artery here, that is in turn dividing into 2 branches. It is ending by dividing into 2 branches. One going along the greater curvature, gastroepiploic artery, right one, and this is going between the pancreas present over here and the duodenum. So it is superior pancreatico-duodenal artery. ये होता है याद रखने का तरीका. Okay. And then after that, my dear friends, remember the hepatic artery, the proper hepatic artery is dividing into right hepatic, left hepatic. Right hepatic is the one which will be giving the branch to the cystic artery, to the cystic arteries. That's all done. Is it okay? Now by this, we are done with all the branches given by the celiac trunk. Now welcome to the last and final thing that you have to revise in your abdomen topic. That is about your peritoneal folds. Now in this diagram, first you're able to see here, this one will be the stomach here. Stomach के आगे यहाँ पर liver होता है, and due to the rotation of gut, the liver will be going towards the right, and behind here this will be the spleen. So okay. In front of the liver, there will be a ligament. That ligament will be falciform ligament. And what is the content of that? It will consist of ligamentum teres. And we know very well ligamentum teres is what? It is a remnant of left umbilical vein. It is a remnant of left umbilical vein, sir. Now, between the stomach and the liver, there will be omentum, and that omentum is lesser omentum. I can show you in this diagram here. Between the liver on one side and the stomach on the other side, there is a omentum. Which omentum? Lesser omentum. But right now we are taking which section here? Transverse section. So when you take a transverse section, stomach, liver, and this is the lesser omentum. Now in that lesser omentum, you have a free margin here. In that free margin, you have got the portal triad. And what is the portal triad? There will be a portal vein, and then the proper hepatic artery, and then you'll be having the bile duct. Portal vein, proper hepatic artery, and the bile ducts in the free margin of lesser omentum. Now between the stomach and the spleen, gastrosplenic ligament, and that will consist of course, this is the greater curvature of the stomach, and greater curvature of the stomach will be having gastroepiploic artery and the short gastric arteries towards the fundus. Greater curvature of the stomach here, the gastroepiploic as well as the short gastric. तो ये दोनों arteries जो है ना कहाँ पर होते हैं? These two arteries are present in between the stomach and the spleen, gastrosplenic ligament. Makes sense? And then finally, this is the celiac trunk here in this diagram, and celiac trunk is giving a branch, and that branch is going to the spleen. Of course, it is splenic artery, and that too present behind the stomach. So the splenic artery here, along with the tail of the pancreas, will be found in the splenorenal ligament. और ये आपके FMG एग्जाम में दिया गया था. The name was given as linorenal ligament. सर स्प्लीन को हम लीन कहते हैं ना, तो इसीलिए इसका नाम था linorenal ligament. So linorenal ligament is actually the one where you have the splenic vessels along with the tail of the pancreas. Perfectly done. Now this space which is present behind the stomach here, this space here will be the lesser sac. Now this space here will be the lesser sac here, and the remaining space here will be the greater sac. Now lesser sac and greater sac are in communication with each other with the help of that opening. That opening will be epiploic foramen. Now what are the boundaries of this epiploic foramen here? In front of the epiploic foramen, lesser omentum with the portal triad. And what do you have behind the epiploic foramen here? Inferior vena cava. So it is very, very clear from this diagram here. You don't have to mug up at all. You're able to see right in front of the epiploic foramen, there is lesser omentum with that, free margin where you have the portal triad. And then behind that one, you'll be able to see the inferior vena cava. It's written here. Anterior to epiploic foramen and posterior to epiploic foramen completed here. Okay. Now what about the superior inferior? Where exactly do you have this epiploic foramen, sir? Yes, it is present here. है ना? तो epiploic foramen के ऊपर क्या है? Clearly आप देख सकते हो. Above that epiploic foramen there is liver, but you have to remember which lobe of the liver, the caudate lobe of the liver. And below the epiploic foramen you are able to see the first part of duodenum present here, sir. That is the first part of duodenum. That's sir. So epiploic foramen के जो boundaries है, most of the students will be banging their heads how to remember this one करके. Just in two diagrams here we are done, sir. तो इस डायग्राम में आप याद कर लो anterior posterior, and in this diagram you can remember the superior inferior here, sir. Made easy here. Okay. Now moving ahead with pelvis and perineum topic. और इस टॉपिक से एक सवाल, वन क्वेश्चन डेफिनेटली प्रेजेंट ऑन 17 जनवरी, एक सवाल पक्का आएगा, एंड दैट विल बी अबाउट एक्सट्रावेसेशन ऑफ यूरिन. Extravasation of urine, sir. A person riding a bicycle here on bumpy road, and what is going to happen? Urethra will be ruptured, and this type of injury is referred to as straddle injury. तो यहाँ पर क्या होता है? ये straddle injury होता है. अब straddle injury में याद रखिए, the urethra that is getting ruptured in the straddle injury will be bulbar urethra. It is a PYQ clinical question given in your FMG exam, sir. Is it okay? So in straddle injury, when the person is actually riding the bicycle on the bumpy road, The urethra that is going to be ruptured will be bulbar urethra. Please remember that first point here. Second point that you have to remember here is that now suppose a person is falling in the manhole. When the person falls in the manhole, the pelvic will be fractured. और जैसे ही आपको ये वर्ड नजर आएगा एग्जाम में pelvic fracture, remember the urethra that will be ruptured will be membranous urethra. This is the first thing that you have to learn. Okay, straddle injury, bulbar urethra, pelvic fracture, membranous urethra will be ruptured. Now let us see one more thing. Okay. Sir, please don't mind, ये session कब तक खत्म होगा? This session will be completed in the next 30 minutes. Exactly. And I'll try to complete that before 30 minutes. Okay. So it will be completed in 30 minutes. Okay. So you people are actually very busy people. Very important timing nowadays. So another 30 minutes, just bear with me and this will be completed, guys. Okay. Don't be impatient there. Fine. Now please look at this diagram here. अगर मान लो membranous urethra will be ruptured. If membranous urethra will be ruptured, the urine will extravasate out into the deep perineal pouch. And then from here, the urine can even go into the space present around the neck of the urinary bladder, near the prostate gland and all. That space is referred to as space of Retzius. Okay, so if membranous urethra is ruptured, then what is going to happen? The urine will go into deep perineal pouch and the space of Retzius. Now suppose if the bulbar urethra is ruptured, sir, this is like dangerous. If bulbar urethra is ruptured, then the urine is going out into the superficial perineal pouch. The urine will also go into the scrotum. The urine will also go into the penile shaft, as well as the urine will also go into the anterior abdominal wall. The urine can go into the superficial perineal pouch, into the scrotum, into the penile shaft, as well as into the anterior abdominal wall. And you can see everything is actually written here in a crystal clear manner. Perfect. So these are the things you have to remember. But apart from that, nowadays what is happening, 2-3 years back, they used to ask the urine is extravasating where. Nowadays they are asking कहाँ नहीं जाएगा. तो अगर मान लो bulbar urethra rupture होता है, if the bulbar urethra is ruptured, then the urine will not extravasate into thigh. Reason? Fascia lata of the thigh. It is not going to extravasate into deep perineal pouch. Reason? वहाँ पर perineal membrane होता है ऊपर. And the urine cannot go into ischiorectal fossa because of the presence of Colles fascia. So you have to remember where urine cannot go and what is the reason for that one. Is it okay? तो मैंने आपको दोनों भी चीजें बता दी है इस LRR सेशन में कि यूरिन कहाँ जाएगा और कहाँ नहीं जाएगा. ठीक है. Next one, ischiorectal fossa. Now in this diagram, this fossa here will be referred to as your ischiorectal fossa. This is the lowermost part of the hip bone, ischium, on which you and me we are sitting right now, and this is the rectum here, sir. And this is ischiorectal fossa. Now on the lateral side, you'll be able to find obturator internus muscle. So laterally, you'll be having obturator internus. On the medial side, you'll be able to find the levator ani muscle as well as external anal sphincter. On the medial side, yes, levator ani, external anal sphincter. Okay. And then once you are done with the lateral and the medial, my dear friend, now what about the anterior and posterior? And that we have to see in the inferior view from below here. So जब इसको inferiorly देखोगे, anteriorly there will be a membrane here. That membrane will be perineal membrane. And posteriorly, of course, यहाँ पर sacrum होगा और ये वाला ischial tuberosity होगा. There is a ligament here, sacrotuberous ligament. Sacrotuberous ligament, and these muscle fibers are gluteus maximus muscle fibers. So I'm done with the anterior, posterior, and medial and lateral also. And yes, of course, in your exam they have given this image. You should be able to identify. I repeat again because this image was given to you. On lateral side, obturator internus, and on the medial side, levator ani and external anal sphincter here. ठीक है ना? नेक्स्ट वन, इंटरनल इलियाक आर्टरी. ये सबसे इजी टॉपिक है, अगर आ जाए तो 1 मार्क फॉर श्योर. मैं आपको बताता हूँ पढ़ने का तरीका. डोंट पैनिक. नाउ इन दिस डायग्राम यू आर एबल टू सी दिस इज द इंटरनल इलियाक आर्टरी हियर. फाइन. कैन यू शो द डायग्राम? वेयर विल इट नॉट गो? ये वाला, आई थिंक दिस वन हियर, डॉक्टर. हाँ जी. Now this is the internal iliac artery here. It is going to divide into 2 division here. One is your anterior division, another one is posterior division here, sir. आपको सिर्फ और सिर्फ posterior division के branches याद रखने होंगे. Remember as SIL branches. S for superior gluteal artery, I for iliolumbar artery, L for lateral sacral artery. That's all. And always the same type of question will be given in the exam. All of the following are the branches from the posterior division except one. तो बस ये 3 याद रखिए, काफ़ी हो जाएगा. Please don't remember the branches from the anterior division. There are like so many branches. After completing all 19 subject, if you still have energy and time left with you, you can learn them. No worries in that one, sir. No one is going to stop you in that one. तो यहाँ पर स्मार्टली पढ़ने का तरीका ये होता है, just learn the branches given from the posterior division. Okay ना, SIL branches, superior gluteal artery, iliolumbar artery and lateral sacral arteries. Done. And now welcome to, yes, we are almost at the end. जैसे मैंने आपको कहा था कि सर another like 20 to 30 minutes will be completing off. Now welcome to embryology part. Okay, are you ready? Someone is writing that I hate embryology. I request you to go to PrepLadder app and watch my embryology videos and you'll start loving it. It's all about concept there. It's all about concept there. Yes. चलिए सर आगे बढ़ते हैं, एम्ब्रियोलॉजी पार्ट से स्टार्ट करेंगे. Now in embryology, first of all, some basic information regarding your general embryology. Yes, embryology is very, very much fascinating. Okay, na? In embryology, first we are going to discuss certain like general points here. So from general embryology wala part. First of all, you'll be having primordial germ cells. They'll be asking you questions from here randomly. Everything has been concised at one place. Follow this one. Primordial germ cells are the one which are going to form the male and female gamete. First you remember that one. That means इनको क्या करना होगा, प्राइमोडियल जर्म सेल्स को अगर ये मेल और फीमेल गैमेट फॉर्म करते हैं तो इनको जाना होगा जेनाइटल रिड्ज में. Why? Because genital ridge is the one which is going to form your gonads. ये तो आपको पता होगा. I hope you have learned in obs gynae, है ना. So the male gonads and the female gonads are actually formed from genital ridge. Okay. तो इसीलिए प्राइमोडियल जर्म सेल्स को, बिकॉज दे आर द वन विच आर गोइंग टू फॉर्म द गैमेट्स, दे हैव टू गो टू द जेनिटल रिच. फर्स्ट पॉइंट टू रिमेंबर, प्राइमोडियल जर्म सेल्स आर प्रोड्यूस्ड बाय एपीब्लास्ट लेयर. I hope you all have heard about epiblast and hypoblast. Every point is like one question here, sir. Okay, they are formed from where? Epiblast. During which week? Second week. After forming from there, they will start migrating. They will migrate to yolk sac by which week? Fourth week. Already asked in the exam. And then from there, they'll migrate to actual place, that is genital ridge, by which week? Fifth week, sir. Okay, na? So primordial germ cells are going to form from epiblast. Then they will go to yolk sac. From the yolk sac, they'll be finally going to the genital ridge by fifth week. Please remember that one. Now we are migrate कर रहे हैं. Thank God in your body and my body, they migrated properly to the right place, and at the right place, the gametes are actually forming. Now in some unfortunate babies, what is going to happen? Wrongly, they'll be migrating. And they'll be wrongly migrating to the neck. And this condition will be actually referred to as craniopharyngeal teratoma. So what is craniopharyngeal teratoma? It is abnormal migration of primordial germ cells to neck. Similarly, if they are going to abnormally migrate to the sacral region or coccyx region, that will lead to sacrococcygeal teratoma. Acha. This is abnormal migration of again primordial germ cells to sacrum or coccyx. And sacrococcygeal teratoma also occurs due to the persistence of primitive streak also, sir. Primitive streak form होता है, normally उसको गायब हो जाना होता है. अगर वो रह जाएगा, if it persists, it will also lead to sacrococcygeal teratoma. Perfectly done, sir. Now welcome to spermatogenesis and oogenesis. Okay ना, फटाफट आंसर करते जाइए. Spermatogenesis कहाँ होता है? What is the location? Seminiferous tubule. What is the duration of this one, sir? Remember, 72 to 74 days. Please remember days. In the exam, 19 subjects in your mind. Of course, अगर पढ़ के जाओगे तो condition apply. 19 subject in the mind, full of tension, and you're like, सडनली वहाँ पर आ रहा है सवाल, स्पर्मेटोजेनेसिस कितने दिन में होता है, मतलब व्हाट इज द ड्यूरेशन ऑफ स्पर्मेटोजेनेसिस. नंबर तो सबको याद रहता है 72 to 74 करके. सम पीपल आर आंसरिंग देयर एज मिनट्स, सम लाइक आवर्स, है ना. कोई तो और भी डेंजरस है, लाइक सेकेंड्स, टू मच. सो प्लीज रिमेंबर इट इज डेज, 72 to 74 days. Okay. Now in the seminiferous tubule you'll be having cells, and these cells will be Sertoli cells. एक्चुअली जो सेल आपको नजर आ रहा है ये वाला सर्टोली सेल ही होता है, सर. पिरामिडल शेप होता है. इफ यू सी इन द मेम्ब्रेन ऑफ द सर्टोली सेल, यू विल बी एबल टू फाइंड ऑल द डेवलपमेंटल स्टेजेस. तो यस, स्पर्मेटोजेनेसिस बिगिंस विद स्पर्मेटोगोनियम. दे विल अंडरगो माइटोसिस टू फॉर्म प्राइमरी स्पर्मेटोसाइट. दैट इज व्हाई दे आर डिप्लॉयड इन नेचर. Then they will undergo meiosis 1 to form secondary spermatocyte. They will be haploid. And then they will be, yes, undergoing meiosis 2 to form what's it there? They'll be actually going to form the spermatid, and spermatid will undergo modification to finally form spermatozoa. So most of the time in your exam they're asking the questions here based on the sequencing. अच्छा, जैसे फॉर्म होगा तो क्या होगा? From the tip of the Sertoli cell, this spermatozoa will be released into the lumen, and this process is referred to as spermiation. After spermiation, the spermatozoa will start migrating, and finally they'll go to epididymis. And you cannot forget epididymis for your exam. So 3 points here. Where will be the storage of spermatozoa? In the epididymis. Where is the spermatozoa undergoing maturation? Answer epididymis. Gaining motility? Answer epididymis. ठीक है ना? Answer epididymis, guys. So storage of the spermatozoa, maturation of the spermatozoa, gaining motility, everything will occur in epididymis only. Done, sir. Now when it comes to oogenesis, I just want you to remember like 2 points, and those 2 points will be regarding the arrest of that one. Primary oocyte. Primary oocyte will be arrested in which phase, sir? The primary oocyte will be arrested in the prophase 1, and that to which stage of that one? That is diplotein stage. Whereas secondary oocyte will be arrested in the metaphase 2. खत्म. अगर आप ये 2 पॉइंट याद रखोगे ना, you will be easily able to answer the question. हमेशा आपके एग्जाम में यही सवाल पूछा जाता है. Okay ना? तो I repeat again, in oogenesis, just remember 2 points, my dear friend. Primary oocyte will be arrested in prophase 1, and secondary oocyte will be arrested in metaphase 2. Done, sir. Then next one here. Yes, of course, this diagram is very much important. So this diagram is transverse section of the embryo, that to which week, sir? 3rd week. And in the 3rd week, this one here will be the ectoderm. This one inside one layer will be the endoderm, and in the middle you'll be having the mesoderm. So why? Because already in the 3rd week, gastrulation will occur. All the 3 germ layers are formed. So ectoderm, endoderm, and the mesoderm will be formed there. Okay. Now welcome to this part here. This green colored highlighted structure here will be the notochord. Above the notochord, you're able to find a tube-like structure here, and this tube here will be the neural tube. And just adjacent to the neural tube, somewhere here will be the neural crest cells, NCC. So first you should be able to identify notochord के ऊपर होगा neural tube, and neural tube के बिल्कुल sides में होगा neural crest cells. Perfect, you're able to identify here. And then now welcome to the mesoderm, my dear friend. Now the mesoderm here in the 3rd week will be divided into 3 categories here. One adjacent to the notochord here. Notochord के बिल्कुल पास में जो होगा paraxial mesoderm, paraaxial along with the axis. Then जो middle में होगा intermediate mesoderm, and on the lateral side will be having lateral plate mesoderm. Now what will be the derivatives of this mesoderm here, sir? अब इन सब के derivatives क्या होंगे? तो please remember, my dear friend, intermediate mesoderm is the one which is going to form nephrogenic cord. And from the name itself, you're able to remember nephrogenic, it is going to form your kidneys and all. And it is also going to form genital ridge. And just now I told you that genital ridge is the one which is going to form the gonads. It means that, in short, intermediate mesoderm is helping in the formation of urogenital systems. Nephrogenic cord and the genital ridge. Urogenital system. Okay. Now paraxial mesoderm, it is the one which is going to become your somites. And I'll show you one beautiful picture. Look here. We are going to remove this ectoderm. हम क्या करेंगे ना, ऊपर से ectoderm को remove कर देंगे और हम देखेंगे ऊपर से. तो when you see from above, this is how the diagram looks like. तो हमने क्या किया, ऊपर से ectoderm निकाल दिया. Now in the middle you are having notochord here. On either side of the notochord there is paraxial mesoderm. And that paraxial mesoderm, slowly it is going to form spherical ball-like structure, and these ball-like structures are nothing but somites. Now these somites, in turn, they're having like 3 parts: dermatome, sclerotome, and myotome. Derma, it is going to form dermis of back of the body. Sclero, remember skeleton, it is going to form axial skeleton, sternum, the ribs, vertebrae and all. And then myo, nothing but muscle, it is going to form the skeletal muscle. It is going to form your skeletal muscle, sir. And if you have learned all these things, all these are nothing but derived from where, sir? Somites. All these are derived from where? Somites. And then whatever is left out, everything you dump it here, sir. Dermis of front of the body, lateral plate mesoderm. Appendicular skeleton, lateral plate mesoderm. Smooth muscle and cardiac muscle, lateral plate mesoderm. ये होता है पढ़ने का तरीका. That is the way how you're going to learn this one, sir. Is it okay? Now, once you are done with this one here, In exam, already they have given neural crystals. Neural crystals, what will be the derivatives? It is like a nonsense list. You need to memorize the entire list. Neural crystals के derivatives क्या होंगे? Remember one thing, neural tube जो होता है ना sir, neural tube is the one which is going to form your central nervous system. That means it is including your brain as well as the spinal cord here. तो जो neural crystals होगा obviously peripheral nervous system. So it is the one which is going to form all the ganglions as well as the enteric plexus also. Peripheral nervous system वाला part. This is very much important. Schwann cells which are going to form that myelin sheath. They are going to be derived from neural crystals. Adrenal medulla will be derived from neural crystals. And this is very, very much important. No more controversies. Remember, parafollicular cells are derived from the neural crystals only. In some of the places, yes, most of the students will be getting confused. They'll be thinking it is derived from ultimobranchial body. No, absolutely wrong. Remember, parafollicular cells are derived from the neural crest cells. The melanin forming cells, melanocytes, most of the skull bones, dentine, pharyngeal arches in the skull and all, and dermis of head and neck, everything will be derived from the neural crest cells. Now this is important again. Conotruncal septum exam में पूछा गया था. Remember, it's actually made up of two septums. One will be the spiral septum. One is the spiral septum. Another one will be the bulbar septum. So spiral and bulbar septum together, it will be referred to as conotruncal septum. Conotruncal septum here. Done. Then apart from that, yes, someone was continuously asking me about the notochord. Remember, notochord is the one. Okay, notochord is the one which will be actually inducing the ectoderm. Overlying ectoderm को stimulate करता है to form the neural tube. Fine. उसके बाद क्या होगा? After that, what should happen? The notochord should actually be gone. It should be degenerated. But instead of going, it will be actually gone. But apart from that, what is going to happen? There will be some remnant present in our body. There is a remnant of notochord. So please remember, one of the remnant of the notochord will be nucleus pulposus. अगर आप intervertebral disc का diagram देखोगे, in the intervertebral disc, the outer part will be the fibrous one. In the middle, you'll be having nucleus pulposus, and that is nothing but the remnant of notochord. The nucleus pulposus is actually the remnant of the notochord, sir. Okay. Apart from that, you can also remember apical ligament of dens and membrana tectoria or tectorial membrane जिसे हम कहते हैं, sir. All this will be the remnants of notochord. So in this manner, what I have done here, अगर आप observe कर रहे हो, I am done with the notochord, I am done with neural tube, I am done with neural crystals. All these three things are done here. After completing the normal embryology, how can't we not study about the clinical application? सबसे पहले आपको याद रखना होगा, इन जनरल रिमेंबर, अगर मान लो ये न्यूरल ट्यूब है सर. अब मैंने आपको क्या कहा था, न्यूरल ट्यूब इज गोइंग टू फॉर्म योर ब्रेन एंड द स्पाइनल कॉर्ड. अपर पार्ट इज गोइंग टू फॉर्म योर ब्रेन एंड द लोअर पार्ट इज गोइंग टू फॉर्म द स्पाइनल कॉर्ड. अब यार आप मुझे ये बताइए, इन योर ब्रेन डू यू हैव एनी ओपनिंग राइट नाउ हियर? नो, यहाँ पर कोई ओपनिंग नहीं है तो बंद हो जाता है. एंड स्पाइनल कॉर्ड में कोई ओपनिंग होती है क्या? नहीं होती है. तो क्या होना चाहिए? दिस न्यूरोपोर एंटीरियर, और इट इज ऑल्सो नोन एज क्रेनियल, or it is also known as rostral neuropore. Rostral neuropore. And then this one here will be the posterior or caudal neuropore. तो पहले आप आराम से इसका नाम सीख लीजिए. Neuropore. The cranial neuropore normally has to close by 25th day, whereas caudal neuropore will close by 27th or 28th day. If you want a better answer, the better answer will be 28th day. Is it okay? So the cranial neuropore will be closed by 25th day and the caudal neuropore will be closed by 28th day. In some unfortunate babies ये close नहीं होता है. अगर cranial neuropore close नहीं होगा, it will lead to a condition known as anencephaly. Similarly, if the caudal neuropore is not closed here, that condition is nothing but spina bifida. And this was the image which was actually given in your FMGE exam, where you are able to see the anencephaly also, as well as the vertebrae. The spinous process of the vertebra is not closed there, and you can clearly see the spinal cord is exposed outside. The anencephaly, along with the bony defect of the vertebrae here, that is nothing but rachis, craniorachis. Is it okay? So please take care about this one, sir. Are you clear with this one here, sir? Done. Now let us see the different types of the spina bifida. Number one, you will just have the defect of the vertebrae here, along with a tuft of hairs present behind here, sir. Defect of the vertebrae and tuft of hair, that is spina bifida occulta. Now suppose the meninges are protruding outside here and they are actually filled with the fluid inside that one. There is a spinal fluid filled inside that one. That condition is referred to as meningocele. Now suppose in that protrusion, even the nervous tissue is also coming outside. You can clearly see the spinal cord. Spinal nerves are coming out there, and that will be referred to as myelomeningocele. Myelomeningocele, sir. Clear with this one here? Next one. Development of diaphragm. Remember, diaphragm will be derived from four structures, sir. Number one, septum transversum. And septum transversum is the one which is going to form the central tendon of the diaphragm. अब हम सबको पता है डायफ्राम इज नॉट मेड अप ऑफ ओनली टेंडन, इट इज ऑल्सो मेड अप ऑफ मसल्स. एंड अभी अभी मैंने आपको बताया था स्केलेटल मसल कहाँ से फॉर्म होते हैं, सोमाइड्स. तो याद रखिए सर्वाइकल सोमाइड्स. सर्वाइकल सोमाइड्स आर द वन विच आर गोइंग टू फॉर्म द मसल पार्ट ऑफ द डायफ्राम सर. ठीक है ना. तो टेंडन हो गया, सेंट्रल टेंडन हो गया, मसल हो गया. अब बचा क्या है? इसोफेगस इज गोइंग टू पास फ्रॉम हियर. Esophagus is going to pass from here. Therefore, the peritoneum will come here, enclose the esophagus and go away. So therefore, I'm having a double layer of peritoneum here. Whenever you have a double layer of peritoneum, that is referred to as mesentery, and it is enclosing esophagus, it is mesoesophagus. Mesoesophagus, dorsal mesoesophagus. And then above here you'll be having pleura, below here you'll be having peritoneum, pleuroperitoneal membrane. Pleuroperitoneal membrane here, sir. Okay. Understanding here? So our entire diaphragm is actually made up of four parts here, sir. I repeat once more, it is worth repeating. Septum transversum, cervical somites, the dorsal mesoesophagus, and the pleuroperitoneal membrane. These four structures are going to form the central tendon of diaphragm. Sorry, it is going to form the entire diaphragm. Fine. Now, sometimes, unfortunately, in some babies, the pleuroperitoneal membrane is absent. If the pleuroperitoneal membrane is absent, now during development, the pressure will be more in the abdomen. So therefore, the loops of intestines are going to herniate into the thorax, and that is referred to as congenital diaphragmatic hernia. You are able to see the loops of the intestines herniating into the thorax here, sir. Compressing the lungs, lung hypoplasia वगैरह हो जाएगा. Congenital diaphragmatic hernia क्यों होता है? It is due to what? Absence of pleuroperitoneal membrane. Topic completed here, sir. है ना? Next one. Now, in the development of the heart, I want you to remember about हार्ट का जो डेवलपमेंट होता है ना सर, उसमें आपने ये वाला डायग्राम देखा होगा ना, हार्ट ट्यूब जिसमें 3 डायलिटेशन होते हैं. There will be like 3 dilatation here. Now this part from where we are going to get the blood inside the heart, that will be the sinus venosus, and this will be truncus arteriosus. Truncus arteriosus is the one which is going to form 2 blood vessels, sir. Ascending aorta, and it is also going to form the pulmonary trunk. चलो एक बार मैं दोबारा रिपीट करता हूं. Truncus arteriosus is the one which is going to form ascending aorta and the pulmonary trunk, sir. Ascending aorta and pulmonary trunk, guys. ठीक है ना? Now, between these two, there is a formation of septum, and that septum is nothing but aorticopulmonary septum. The name is very much meaningful, aorticopulmonary septum. And this septum is also referred to as spiral septum. इसी को हम कहते हैं spiral septum भी कहते हैं, सर. अगर मान लो ये स्पाइरल होता है तो नॉर्मली व्हाट इज गोइंग टू हैपन, फ्रॉम द लेफ्ट वेंट्रिकल ascending aorta is going to begin, and from the right ventricle pulmonary trunk is going to begin. अब लगाइए कॉमन सेंस. अगर मान लो ये स्पाइरल सेप्टम स्पाइरल नहीं होता है, if the spiral septum does not spiral, then what is going to happen? Of course, yes, उल्टा हो जाएगा. Ascending aorta is coming from right ventricle, pulmonary trunk is coming from left ventricle, और इसको हम कहते हैं transposition of great vessels. If the spiral septum is not spiraling, it will lead to transposition of great vessels. ठीक है ना? Similarly, अगर मान लो कि spiral septum form ही नहीं हुआ, if the septum is not at all forming there, sir, okay ना? Therefore, truncus arteriosus is going to remain patent, and that condition is referred to as patent truncus arteriosus. Patent truncus arteriosus. Okay. And and third and final thing, my dear friends, agar spiral septum, if there is an anterior displacement of the spiral septum, what do you mean by that one, sir? Agar मान लो कि truncus arteriosus है, if this is truncus arteriosus, septum transversum here, sorry, the spiral septum in the middle here, anterior displacement थोड़ा वो आगे बढ़ गया है. अगर ये आगे बढ़ जाएगा, then what is going to happen? If it is going to be anterior displacement अगर हो जाएगा, ascending aorta diameter will be more when compared to the pulmonary trunk. Ascending aorta will be more wider. If this ascending aorta is like more wider, it is going to override onto the interventricular septum. So overriding of aorta on the interventricular septum. Number 2, there will be pulmonary stenosis. And agar pulmonary stenosis ho jayega, the right ventricle has to work hard to push the blood. So there will be hypertrophy. तो combining all this together, it is referred to as what's a TOF. इसी को तो हम कहते हैं TOF, है ना. तो ओवरराइडिंग ऑफ आयोटा हो जाएगा, वेंट्रिकुलर सेप्टल डिफेक्ट हो जाएगा, पल्मोनरी स्टेनोसिस है, एंड देन हाइपरट्रोफी. सो देयरफॉर राइट वेंट्रिकुलर हाइपरट्रोफी, दैट इज नथिंग बट योर टॉफ्स, एंड इट इज ऑल हैपनिंग ड्यू टू व्हाट. ये मैं क्यों बता रहा हूँ आपको, व्हाई आई एम टेलिंग यू दिस वन सर. एवरीथिंग द डिफेक्ट्स इज रिलेटेड विद स्पाइरल सेप्टम. Spiral septum, sir. Hello, sir. I am from Nepal and we are watching your video in group. All the best to my students from Nepal there. Thank you. God bless you all. Now, welcome to development of arterial system, sir. Definite question in your FMG exam. Arterial system के development से आपके exam में definite सवाल यहाँ पर आएगा. Now, I hope every student remembers this diagram here. First, let me tell you in this diagram, then I'll show you this table here. वरना नहीं समझ में आएगा. Now, in this diagram, first of all, what is going to happen, like your entire arterial system is going to form. An arterial system is going to form from these arch arteries. The first arch artery, second, the third, and then the fourth, and then fifth and sixth one here. Now, out of that, please remember, okay, arch of aorta is derived from where? Remember, arch of aorta is derived from left fourth arch artery. Fourth arch artery, sir. Whereas all your carotid arteries are actually derived from the third arch artery, sir. The proximal part of that one is going to form common carotid, and then again it is going to continue. Distal part is going to form internal carotid. Whatever, remember the number, third arch artery. Now, this one here will be the pulmonary artery, and this one here will be the pulmonary artery. And remember, pulmonary arteries are derived from sixth arch artery. Sixth arch artery. Now, this is something very, very much important. The pulmonary artery and arch of aorta, they are connected by ductus arteriosus, and that is derived from left sixth arch artery. Perfectly done, sir. Okay. Now, I repeat again here. The left fourth arch artery is going to form arch of aorta. Third arch artery is going to form carotid arteries, and ductus arteriosus will be derived from the left sixth arch artery. Fine. If you have understood this one, now you'll be like, sir, you are telling only about the third one, fourth one, and sixth one. What about the first, second, and the fifth one? First point to remember here is that fifth arch is completely degenerated. Completely gone, sir. Nothing will be derived from the fifth arch. Fifth arch से कुछ भी derived नहीं होता है. What about the first arch artery? There will be a remnant, and the remnant of the first arch artery will be the maxillary artery, sir. That is maxillary artery. And what about the second arch artery? There will be a remnant, and that remnant will be stapedial artery. Remnant of this one will be stapedial artery along with hyoid artery, sir. Hyoid artery, that's all. Perfect. So the first arch artery is the one which is going to form your maxillary artery. Second arch artery is the one which is going to form stapedial artery along with the hyoid artery. Third is going to form carotid artery. Fourth is going to form arch of aorta. And fifth, कुछ नहीं form होगा. Sixth is the one which is going to form pulmonary artery and ductus arteriosus. Please remember this one, sir. And I hope you remember there will be a recurrent laryngeal nerve which is going to take a turn. And you know very well, left one will be more longer. Why it is more longer? Why? Because the left recurrent laryngeal nerve is getting stuck here itself. Which arch artery? The sixth arch artery. Okay. So that was a question asked in your exam. The left recurrent laryngeal nerve has got the longer course due to persistence of which artery? It is the left sixth arch artery, sir. Perfect. Now welcome to subclavian artery. Normally, the right subclavian artery has to develop from the right fourth arch artery. Is it okay? I told you left fourth arch artery is going to form arch of aorta. So right fourth वाला जो होता है, it is going to form your subclavian artery. मान लो कि there is abnormal obliteration of this one. This is obliterated. And then there is persistence of 7 cervical intersegmental artery. अगर ये persist होगा, तो that is actually abnormally developing into right subclavian artery. That is not the normal, abnormal right subclavian artery. And now you can see in the actual diagram here, it's going to come from behind the esophagus and the trachea, compressing that one, and that condition is referred to as dysphagia lusoria. So dysphagia lusoria में होता है abnormal right subclavian artery, and that is due to what? Remember two things there. It is due to the occlusion or the blockage of what's a right fourth arch artery. The right fourth arch artery will be obliterated. And yes, of course, 7 cervical intersegmental artery and the right dorsal aorta will be persisting there. And that is going to form your abnormal right subclavian artery, जिसकी वजह से dysphagia lusoria होता है, sir. Of course, ठीक है ना? Nikhil, you also have to remember about the intersegmental arteries. Now welcome to development of the venous system. Now remember, my dear friends, during development you'll be having three veins. Number one will be the cardinal vein, and you can clearly see cardinal veins are the one which is going to collect the blood from entire body of the embryo. Number two will be your umbilical vein, which is going to bring the blood from the mother. And number three will be the vitelline vein, which is going to bring the blood from the yolk sac. If you remember this source, it's very much easier, sir. अब कार्डिनल वेन से क्या फॉर्म होगा? याद रखिए, कार्डिनल वेन is going to collect the blood from entire body. And who is going to collect the blood from our entire body? Of course, superior vena cava and inferior vena cava. They are derived from cardinal vein. Makes sense? Who is going to collect the blood from yolk sac? Vitelline vein. And remember, yolk sac is actually your future gut. And from our entire gut, blood will be collected by portal vein. So portal vein has to be derived from vitelline vein. So done. An umbilical vein, at this point, I think I don't even have to tell you the entire story now. Before the birth, there will be two umbilical veins, sir. Right umbilical vein and the left umbilical vein. Can anyone tell me which one will be completely gone, sir? Right will regress, and only the left umbilical vein is supplying the blood. Right regress, left is left, sir. Right regress, left is left. The left umbilical vein is the one which is supplying the blood to the fetus from the mother. Now, after birth, what is going to happen? The left umbilical vein will be obliterated and it is going to become your ligamentum teres. Ligamentum teres. Perfectly done. So, development of venous system, just remember this one diagram, everything will be done, sir. Now, moving on, gut embryology. Now, in this diagram, the outer black colored line that you are able to see here, that is a body wall, which will be derived from ectoderm. Inner red colored line that you are able to see is actually your gut, which will be having foregut, midgut and hindgut, and that will be derived from endoderm. Now midgut is the one which will be giving an extension here. This extension here will be the vitello-intestinal duct, and hindgut will also give an extension known as allantois. Let us discuss the first topic right now, sir. What are the contents of umbilical cord? Umbilical cord के contents क्या होंगे? You are able to see number one, vitello-intestinal duct. You are able to see number two, allantois here. Number three, there will be a jelly-like substance surrounding there. What is jelly? And this too is very much important. Remember, you have both right and left umbilical artery, but vein only you'll be having the left one, the left umbilical vein, sir. So there'll be like two arteries and one vein. Okay. Now let us see the clinical application here. Now, what is the clinical anatomy? Remember, vitello-intestinal duct normally क्या होना चाहिए? In your body and my body, it is completely gone. It has to be gone. It has to be closed off. But in some people, unfortunately, vitello-intestinal duct will persist. ये रह जाता है. अगर ये रह जाएगा तो क्या होगा? Obviously, the meconium is going to come out of the umbilicus. Question already asked in your FMGE exam. Meconium coming out of the umbilicus. Meconium coming out of the umbilicus. What is the defect? Persistence of vitello-intestinal duct. Sometimes what will happen, only the proximal part will persist, sir, not the entire thing, only proximal part. And that diverticulum is referred to as, yes, Meckel's diverticulum कहते हैं. So Meckel's diverticulum is nothing but the persistence of proximal part of the vitello-intestinal duct. Done. You have to remember these two clinical applications here, sir. Okay. Now welcome to this hindgut wala part, sir. Ye wala part, this last part. Now this hindgut will be separated from allantois, sir. And hindgut we know very well, it is the one which is going to form your rectum here, and then it is going to form the anal canal. And this allantois is the one which is actually going to form the urogenital sinus. Allantois is going to form urogenital sinus. And the cranial part of this urogenital sinus will be urachus. It is urachus. Now, apply common sense, my dear friend. अगर ये वाला rectum होगा, तो rectum के सामने क्या होगा? Of course, urinary bladder will be there. Of course, urinary bladder. The urogenital sinus is the one which is going to form entire urinary bladder. Here itself will finish off everything, sir, in one diagram. Come on. So now tell me, entire urinary bladder is derived from where? Answer, urogenital sinus. Except ट्राइगोन. ये सवाल आपके FMG एग्जाम में पूछा गया था कि ट्राइगोन विल बी डिराइव फ्रॉम वेयर. रिमेंबर, ट्राइगोन इज डिराइव फ्रॉम वुल्फियन डक्ट, मेसोनेफ्रिक डक्ट, सर. ठीक है ना. एंड द क्रेनियल पार्ट इज नथिंग बट यूरेकस. यूरेकस क्लोज हो जाता है, एंड आफ्टर क्लोजिंग इट इज गोइंग टू बिकम द मीडियन अम्बिलिकल लिगामेंट, सर. इन सम अनफॉर्चुनेट बेबीज ये क्लोज नहीं होता है. अगर क्लोज नहीं होगा तो यूरिनरी ब्लैडर में जो यूरिन होगा, दैट यूरिन विल स्टार्ट ड्रिबलिंग आउट ऑफ द अम्बिलिकस. If that urine is coming out of the umbilicus, that condition is referred to as weeping umbilicus. And in weeping umbilicus, what is the problem? Persistence of urachus. तो दो सवाल यहाँ पर से. If you see meconium coming out of the umbilicus, the problem is with which duct? Vital intestinal duct. If you see urine coming out of the umbilicus, the problem is with the urachus. Persistence of urachus. Crystal clear concept. Okay. Now moving ahead, the next one, rotation of gut. You people know very well rotation of gut. Yes, of course. Foregut will rotate 90 degrees in clockwise direction. Midgut will rotate 270 degrees in anti-clockwise direction और hind gut rotate नहीं होता है. When it comes to rotation of gut, foregut will rotate 90 degrees clockwise, midgut 270 degrees anti-clockwise and hind gut rotate नहीं होता है. अब midgut जो होता है, during that midgut rotation, what is going to happen? The midgut is going to come out of the umbilical opening. Why? Because you don't have enough space to accommodate the midgut there. So it is going to come out of the umbilical opening there, and that is referred to as physiological hernia. Physiological hernia, I mean to say, coming out of that one, it will be on during 6th week. It will be again reducing back by 10th week. So normally the midgut is going to come out by 6th week and it will reduce back by 10th week. So thank God, your midgut, my midgut came outside, went inside. Our body is perfect here. Now in some babies, what is going to happen? Unfortunately, वो midgut बाहर तो आता है, लेकिन reduce back नहीं होता है. It will not be reduced back, and that condition is referred to as omphalocele. So failure of reduction of physiological hernia, that condition is omphalocele, sir, which is surrounded by this sac-like structure. Sac यहाँ पर present होता है. But what about gastroschisis, sir? In gastroschisis, what is going to happen? It is not about the physiological hernia, sir. In gastroschisis, it's actually anterior abdominal wall will be very much weak and ruptured, and then the coils of intestines are coming out. Remember, they are not covered by the sac here, sir. Sac यहाँ पर नहीं होता है. Perfect. Done, sir. Now welcome to the ectodermal clefts and the endodermal pouches. In total, you'll be having how many clefts here, sir? 4. And how many pouches are there? 4. Now in the ectodermal clefts which are present over here, the first ectodermal cleft is the one which is going to form external acoustic meatus and outer layer of the tympanic membrane. Second, third and fourth cleft is completely obliterated. Thank God कुछ पढ़ने का नहीं है. तो ectoderm, ऐसे याद रख लो सर, apply on your face here. Ectoderm, the first ectodermal cleft is the one which is going to form external acoustic meatus. Second, third and the fourth will be completely closed here. Now welcome to endodermal pouches. The first endodermal pouch from inside, अगर यहाँ पर external ear होगा, obviously this one will be middle ear now. So it is going to form middle ear cavity along with the eustachian tube, along with the inner layer of tympanic membrane. Second pouch is the one which is going to form palatine tonsil. थोड़ा सा नीचे palatine tonsil, but remember only epithelium. Third pouch, remember third pouch, thymus. Remember with the rhyming word there, sir. Okay. Third pouch is the one which is going to form thymus. And along with the thymus, because it has to migrate downwards, it is going to form inferior parathyroid gland. ध्यान से याद रखिएगा. And fourth pouch is the one which is going to form superior parathyroid gland. यहाँ पर important ये है, third and fourth pouch will be involved in the DiGeorge syndrome. I hope you all remember 22q11 microdeletion syndrome. DiGeorge syndrome में third and fourth pouch involved होता है. If you want a better answer, remember third pouch. Third pouch will be more better answer when it comes to the fourth pouch. Is it okay? Clear? I hope it is very clear, my dear friends. चलिए आगे बढ़ते हैं. Next one is pharyngeal arches. बस आपको मुझे ना ये डायग्राम बताना था यहाँ पर. Pharyngeal arches. I'm done with the cleft. I'm done with the pouches. Pharyngeal arches से क्या होता है? Yes, it's derived from mesoderm. So because it is derived from mesoderm, it is the one which is going to form your cartilage, it is going to form the bone, it is going to form the muscle. Now students are like, sir, how to remember so many structure? This is the best diagram. This is the best diagram, sir. Okay. In this diagram, whatever is derived from here, sir, this all part is derived from first arch. फिर ये वाला part जो होगा, this is derived from second arch. Then this part here is derived from third arch. So it is like, layer by layer you can remember. For example, malleus, incus, and then anterior ligament of malleus, and then sphenomandibular ligament, and then the mandible. All this will be derived from first arch. Stapes, styloid process, stylohyoid ligament, and then lesser horn and upper part of the body, that is derived from second arch. So in this manner, you can follow this diagram to learn all the derivatives of the pharyngeal arches. Extremely, extremely important, sir. Okay. Next one, development of the face right now, sir. How our face is actually going to form. Now, in the formation of the face, remember you require only two things here. Number one, this one here will be the frontonasal process. and this one here will be the mandibular process. You just remember like this. Look at me here. Everyone, please look at me here right now, sir. This part of the face is derived from mandibular process. एंड मैंडिबुलर प्रोसेस ही क्या करता है, मैक्सिलरी प्रोसेस भी फॉर्म करता है. तो इतना हो गया. अब बचा क्या, व्हाट इज रिमेनिंग राइट नाउ, फ्रंटल एंड नेजल. तो ये वाला फ्रंटोनेजल प्रोसेस. तो दो प्रोसेस होते हैं, एक मैंडिबुलर और दूसरा फ्रंटोनेजल. इन दोनों को जोड़ दो, फेस फॉर्म हो जाएगा. ओके, लुक एट दिस डायग्राम हियर नाउ. Now in this diagram here, mandibular and mandibular process will fuse together to form the lower lip here, sir. अगर मान लो ये फ्यूज नहीं होता है तो it will lead to yes midline cleft lower lip. If there is non-fusion of the mandibular process, it will lead to midline cleft lower lip. As simple as that. सर अब अपर लिप कैसे फॉर्म होता है? अपर लिप में एक पंगा है. There is a philtrum in the middle. There is a depression here, philtrum. Now this philtrum is the one which will be formed by medial nasal process, medial nasal process here, and then maxillary will come and fuse with that one to form your entire upper lip. So upper lip is completely formed by maxillary process fused with medial nasal process. Okay ना? तो चलिए स्टार्ट करते हैं. मिडलाइन क्लेफ्ट अपर लिप, सब कुछ इसके नाम में लिखा है सर. एवरीथिंग इज देयर इन द नेम. मिडलाइन क्लेफ्ट अपर लिप, मिडलाइन क्लेफ्ट अपर लिप, नॉन फ्यूजन ऑफ medial nasal process. Unilateral cleft upper lip, non-fusion of maxillary with medial nasal process. Bilateral cleft upper lip here, non-fusion of both maxillary with both medial nasal process. Okay ना? Then yes my dear friends, remember अगर मान लो ये maxillary fuse नहीं होता है, इसके साथ में even lateral nasal process भी अगर fuse नहीं होता है, if the lateral nasal process is also not fused there, then it will be like a cleft extending into the face. Oblique facial cleft कहते हैं. This is oblique facial cleft here, sir. ठीक है ना? Now once you are done with this one here, by this you can clearly see there we are done with almost entire embryology here, sir. Entire embryology is done there. Okay na? We are done with CVS, we are done with your CNS, neural tube, development of head and neck and face and all those things. Everything is completed here. अब चलिए आगे बढ़ते हैं सर. Yes, last 5 minutes we are going to finish off with your histology, like whatever is required, and then the types of joint. Okay, moving ahead. Dr. Sunil Mehra is asking here, sir, LRR है कि RR है? यार, okay, that's a separate discussion. We'll actually have a separate discussion onto that one. Okay ना? I'll come live again on YouTube. हम बैठ के यही सारी चीज़ें डिस्कस करते हैं. ठीक है ना? PDF पूछना चाहिए कि नहीं पूछना चाहिए, पहले पूछना चाहिए कि बाद में पूछना चाहिए. अच्छा, RR या LRR पहले पूछना चाहिए. जब फैकल्टी जब पढ़ाता है कि जब ज़्यादा होता है कम होता है, क्या करना चाहिए? ओके, जो भी है बढ़िया है. थैंक यू आयुष. I think the entire subject is revised. See, actually my intention is that it's not about, it should not be like just a tick mark activity कि हाँ I came online on YouTube and I just taught for some time and went back. It's not like that. I'm actually with my students almost till the last day of the exam. Okay, I want to help my student as much as possible. Okay, that is the reason why I'm like when I'm spending some time with you, it should be like quality time. ऐसे नहीं होना चाहिए कि टिक मार्क यार हाँ करवाना था सर, आए वहाँ पर आधे घंटे में कुछ बता दिया और चले गए, पता नहीं क्या हो गया क्या हो रहा है. ऐसा नहीं होना चाहिए. इट शुड बी लाइक अ कंप्लीट पैकेज. You should be I love like when you go back from the session with the smiling faces. हाँ यार चलो पूरा रिवाइज हो गया, अब थोड़ा कॉन्फिडेंस आ रहा है ना. हो सकता है कि whatever like 4 hours we are spending right now together, whatever like 3-4 hours we have spent together, might be हो सकता है कि this is the one which is going to push you from that 140 to 150. I am observing like after the result that day, on the day of the result, many of the students will be there with between like 140 and 150, 142, 144, 148. बहुत सारे students होते हैं, तो बड़ा दुख लगता है. I keep myself in their place and think यार बस 2 माह के लिए फिर वही 6 महीने फिर वही 19 सब्जेक्ट पढ़ना पड़ेगा. That is the reason why I don't take any risk here. तो अगर कोई स्टूडेंट मेरे साथ में 3 घंटे बिता भी रहे ना, इट शुड बी लाइक क्वालिटी टाइम यार. इससे हमारे मतलब लगभग सारे क्वेश्चन हो जाएंगे. I think that should be the that is actually my core vision, actually core thinking actually for my students. Okay, so that's the reason why just bear with me. I think it might be very boring to you, but बहुत important है, यही तो important है ना. Yes, thank you Sandeep. या हिस्टोलॉजी, इन हिस्टोलॉजी यू हैव टू लर्न अबाउट टू एपिथेलियम. देखो पहले तो ना आपको हिस्टोलॉजी में एपिथेलियम पढ़ना है. यू हैव टू लर्न एपिथेलियम एज वेल एज कार्टिलेज से. अब एपिथेलियम में ना आपको ना दो एपिथेलियम बहुत इंपॉर्टेंट है जो पढ़ने हैं. एक सूडो स्ट्रैटिफाइड एपिथेलियम. अब इसका नाम ऐसा क्यों रखा गया है? स्ट्रैटिफाइड का मतलब होता है, स्ट्रैटिफाइड मीन्स मल्टीपल लेयर्ड, बट सूडो फॉल्सली इट इज अपीयरिंग लाइक दैट. व्हाई? बेसमेंट मेम्ब्रेन होता है, द सेल्स विल बी प्रेजेंट लाइक दिस हियर. हालांकि वो सिंगल लेयर होता है, इवन दो इट इज जस्ट अ सिंगल लेयर, बट इनके जो न्यूक्लियाई होते हैं वो न्यूक्लियाई जो है ना, दे आर नॉट एट द सेम लेवल. तो बिकॉज द न्यूक्लिया आर नॉट एट द सेम लेवल, इट इज अपीयरिंग लाइक मल्टीपल लेयर, even though it is like simple layer. तो pseudo stratified. So falsely it is giving the appearance of a multiple layer because the nuclei are not present at the same level there. Examples कहाँ पर होते हैं सर? Pseudo stratified ciliated epithelium होता है ट्रेकिया में और ब्रोंकस में. Please remember that very much carefully. Number 2, transitional epithelium. Extremely important. और ऐसा मुझे ना intuition लग रहा है. I'm feeling that you know this question is gonna come on 17 January. 17 जनवरी को ये सवाल पूछा जाएगा. ओके या ट्रांजिशनल एपिथेलियम जो बेसल लेयर होते हैं, दीज सेल्स विल बी कॉलमनार एंड देन इन द इंटरमीडिएट लेयर विल बी हैविंग पॉलीगोनल. द मोस्ट इंपॉर्टेंट विल बी एपिकल. आप इसको पहचानोगे कैसे? विद द एपिकल लेयर ऑफ सेल्स. दिस एपिकल लेयर सेल्स हियर विल बी लाइक मोर बिगर सेल्स एंड दे आर गोइंग टू कवर लाइक 2-3 cells beneath them, and these bigger cells in the topmost layer, these bigger cells in the topmost layer are referred to as your umbrella cells. ओके ना, देर अम्ब्रेला सेल्स और यू शेप्ड सेल्स. ये बहुत इंपॉर्टेंट है, इसी से तो आप पहचानोगे. और ये ट्रांजिशनल एपिथेलियम कहाँ पर होता है? यूरेटर में होगा. आफ्टर यूरेटर यूरिनरी ब्लैडर होगा. आफ्टर यूरिनरी ब्लैडर यूरेथ्रा, बट रिमेंबर ओनली अप टू द प्रोस्टेटिक यूरेथ्रा. So because it is present in your urinary system, that is the reason why transitional epithelium is also referred to as urothelium. Transitional epithelium is also referred to as urothelium. Is it okay? Please remember that one. And yes, of course, cartilage. Cartilage will be of 3 types: hyaline, elastic and fibrous cartilage. Hyaline, elastic and fibrous cartilage. हमेशा स्टूडेंट सवाल पूछते हैं सर पहचाने कैसे? बड़ा आसान है, आपको बस 2 जगह देखना है. नंबर 1 सेल्स, chondrocytes. Number 2 मैट्रिक्स. Cells, the chondrocytes will be in groups. The chondrocytes are actually in groups in elastic cartilage as well as hyaline cartilage. Oh my god, sir हम differentiate कैसे करेंगे? Look at the matrix. If the matrix is very much clear, transparent like a glass, glass का ही नाम है हाइलोस, हाइलाइन होगा. अगर मैट्रिक्स में यहाँ पर आपको फाइबर नजर आएंगे, यू आर एबल टू सी दिस ब्रांच्ड फाइबर्स हियर राइट नाउ, मेनी ऑफ देम, दैट इज इलास्टिक फाइबर्स, दैट नथिंग बट इलास्टिक कार्टिलेज. खलास, इस तरीके से आप इसको आइडेंटिफाई करोगे. कॉन्ड्रोसाइट्स ग्रुप्स में होंगे, हाइलाइन या फिर इलास्टिक होगा. लुक एट द मैट्रिक्स, इफ इट इज क्लियर लाइक अ ग्लास, हाइलाइन. इफ इट इज हैविंग इलास्टिक फाइबर्स विच आर ब्रांच्ड, इट इज इलास्टिक कार्टिलेज. देन फाइब्रस कार्टिलेज अगर ये एग्जाम में दिया जाएगा, यू आर लकी ऑन दैट डे. Why? Because chondrocytes here are actually arranged in rows. They are not in groups, they are arranged in rows. And the fibers between them are parallelly arranged in a well placed manner. Fibrous cartilage. समझ में आ रहा है? So in this manner, my dear friends, you can easily identify. My intention in this LRR was to make identify the image. Image based question आता है cartilage पर. Examples तो आपको पता ही होंगे. Here and there हमने कई जगह पर आपको ना हाइलाइन, इलास्टिक और फाइब्रस कार्टिलेज के एग्जाम्पल्स बताए हैं. ठीक है, चलिए सर आगे बढ़ते हैं. Yes, this is also asked in your exams nowadays, sir, about the secretion from the glands. So there will be like 3 types of secretion. Number 1, merocrine secretion. Based on the mode of secretion, the glands are divided into merocrine, apocrine and holocrine. What do you mean by merocrine here? Whatever secretions are produced by the gland, those secretions are packed in the vesicle. Vesicle will go up near the membrane attached to that and leave the secretion. Only secretion outside by exocytosis. इसको कहते हैं merocrine. And examples बहुत important है. This will be in exocrine glands and the sweat glands. Exocrine glands and sweat glands, they are secreting by which method? Merocrine secretion. Apocrine का मतलब क्या होता है? Whatever secretions are produced in the gland, they are going to the apical part, and that apical entire part of the cell itself is pinched off. पूरा पार्ट ही निकल जाता है. और ये होता है mammary gland में और atypical sweat glands. And holocrine में क्या होता है? Entire whole. Holocrine में entire cell itself is going to die off. So whatever secretions are there, entire cell will die off and leave the secretion outside. That will happen in sebaceous glands. तो merocrine, apocrine, holocrine ये आपके एग्जाम में कई बार दिया जाता है. Please take care about this one here. Types of joints. Of course, definitely on 17 January, one question will definitely come from the types of joint. टाइप्स ऑफ जॉइंट तीन तरह के होते हैं सर. फाइब्रस जॉइंट जो इमूवेबल होता है, कार्टिलेजिनस जॉइंट जो मूवेबल होता है, पार्शियली मूवेबल होता है, साइनोवियल जो कंप्लीटली मूवेबल होता है, कंप्लीटली मूवेबल होता है. इज इट ओके? नाउ फाइब्रस जॉइंट एग्जांपल्स विल बी, नंबर वन एग्जांपल हियर विल बी sutures, the joint present between the cranial bone. Number two, the joint present between the tooth and the jaw, that is gomphosis. ठीक है ना? And the third one is syndesmosis. Syndesmosis is a joint between the two bones with the help of this interosseous membrane. Remember only two examples for your FMG exam. Number one, middle radial nerve joint. Another one will be the inferior tibiofibular joint, sir. Done, done, done. By this, we are done with the immovable joint here. Please don't forget this name, already given in your FMG exam. Don't get confused there, sir. Is it okay? I'll just repeat it again. Fibrous का मतलब होता है immovable joint. Remember three things. Number one, sutures. Number two, gomphosis. Number three, syndesmosis. Syndesmosis में the bones are actually joined with the help of interosseous membrane. Remember two examples. One is middle radial nerve joint. Another one is inferior tibiofibular joint. Done. Now welcome to cartilaginous joints. अच्छा, one more thing. There is something special joint, that is your shindialysis. Shindialysis is between the rostrum of the sphenoid and the vomer. Rostrum of the sphenoid is coming and fitting in the vomer. That is shindialysis. हालांकि ये भी it is one of the suture only, sir. क्योंकि स्फिनॉइड एंड वोमर आर योर क्रेनियल बोन्स ओनली, सुचरल बट समथिंग स्पेशल. नाम याद रखिए, शिंडाइलिसिस. नाउ वेलकम टू द लास्ट एंड फाइनल वन, दैट इज कार्टिलेजिनस जॉइंट. कार्टिलेजिनस जॉइंट फिर से दो तरीके के होते हैं, प्राइमरी एंड सेकेंडरी. प्राइमरी इज ऑल्सो नोन एज synchondrosis एंड सेकेंडरी इज नोन एज symphysis. Primary will be synchondrosis, secondary will be symphysis. Example, प्राइमरी कार्टिलेजिनस जॉइंट विल बी बिटवीन द एपिफाइसिस एंड डायाफाइसिस ऑफ द लॉन्ग बोन. वहां पर ग्रोथ प्लेट होती है, आपको पता होगा. ग्रोथ प्लेट कार्टिलेज की बनी होती है, तो इसीलिए दैट इज प्राइमरी कार्टिलेजिनस जॉइंट. एंड देन कॉस्टोकॉन्ड्रल जॉइंट. कॉस्टोकॉन्ड्रल जॉइंट, कॉस्टोकॉन्ड्रल जॉइंट इज ऑल्सो एन एग्जाम्पल ऑफ प्राइमरी कार्टिलेजिनस जॉइंट, सिनकॉन्ड्रोसिस. इज ओके? अगर आप ये दो जॉइंट याद रखोगे काफी हो जाएगा. And your examiner is very much interested about the secondary cartilaginous joint. कई बार आपके एग्जाम में इमेज बेस्ड क्वेश्चन दिया जाता है, and it is so easy to remember the examples. All the midline joint, this is the keyword. That is a keyword, sir. Midline joint, midline. ठीक है ना? तो mandibular-sternal joint, xiphiosternal joint, intervertebral disc, pubic symphysis, everything in the middle will be an example of your symphysis. Symphysis. तो आपने देखा होगा आपके एग्जाम्स में बार बार जो है ना एक्सरे इमेज दिया जाता है प्यूबिक सिम्फाइसिस वाला, और इस इमेज में एरो मार्क, आइडेंटिफाई विच टाइप ऑफ जॉइंट. आंसर, सेकेंडरी कार्टिलेजिनस जॉइंट, नथिंग बट सिम्फाइसिस. इज इट ओके? रिमेंबर मिड लाइन जॉइंट्स है. एंड बाय दिस we are actually done with the joints also, and remaining all the joints whichever you have learned will come under synovial category. So that is a movable joint, guys. ठीक है ना? और इस तरीके से वी आर डन विथ अपर लिम, लोअर लिम, थोरैक्स, एब्डोमेन, पेल्विस एंड पेरिनियम, एम्ब्रियोलॉजी, हिस्टोलॉजी, टाइप्स ऑफ जॉइंट, न्यूरोएनाटॉमी एंड हेड एंड नेक, माय डियर फ्रेंड. तो इस तरीके से अपना LRR परफेक्टली डन हो गया. एग्जैक्टली 4 hours ऑफ टाइम इट इज़ डन. And I request all of you to please revise this as many times as possible before going to the exam. And even please share this one with all your friends. Please help them, because we all believe that there is some energy. Yes, अगर आप किसी को मदद करोगे तो डायरेक्टली इनडायरेक्टली कहीं ना कहीं से गायब से आपको भी मदद मिलेगी एग्जाम्स में. ठीक है ना? तो डोंट बी हैविंग दैट कॉम्पिटिटिव स्पिरिट. वो FMG हो जाने के बाद कर लेना, आपके ना नीट PG INS सेट में कंपटीशन कर लेना. यहाँ पर कोई कंपटीशन नहीं है, सबको 150 क्रॉस करना है. दूसरों की मदद कीजिए, आपको कहीं ना कहीं से ज़रूर मदद मिलेगी. इज इट ओके? तो शेयर दिस विद एज मेनी फ्रेंड्स एज पॉसिबल. आस्क देम टू रिवाइज दिस वन. यू ऑल्सो रिवाइज मल्टीपल टाइम्स. एंड येस, ऑफ कोर्स, आई विल सी यू ऑन द अदर साइड. Yes, after the exam, I don't want you to be again in this online session. I want to see your pictures on Instagram and everywhere. Okay, yes, cleared with this marks. Okay, now. So have that manifestation. Okay, I'm going to score like 200 plus. I'm going to score 180. कुछ दिमाग में रखो. तो inshallah those things will come true. Okay. So God bless you. Take care. This is my bit that I can do for you. बहुत सारे मैसेज आ रहे थे जो मैं कर सकता था, ये मैंने आपके लिए किया है. तो please utilize this one. Okay. So take care. All the best. God bless you all. Thank you.